scientific session soon, as usual, with an array of case presentations by the postgraduate students. So this session will be moderated by Dr. Jashodhara Chaudhuri, who is a pediatric neurologist also attached to Institute of Child Health, Kolkata. So may I request Dr. Jashodhara to please come and start today's session. We will have chairperson of this session, Dr. Basudev Patro, and the judges panel comprises of Dr. Arun Manglik, Dr. Subhashish Bhattacharya, and Dr. Sumantro Sarkar. So Dr. Jashodhara Chaudhuri will be moderating the session, and may I request the chairperson, Dr. Basudev Patro, to please come on the dais, and also the panel of judges, Dr. Arun Manglik, Dr. Subhashish Bhattacharya, and Dr. Sumantro Sarkar, to please come on the dais.
Good morning to the esteemed audience. On the auspicious day of Independence Day, here we come for the annual office practice CME. That is an annual celebration for us all pediatricians of the state. And we start with a very interesting session, that is oral paper presentation on interesting neurological cases. So we have 5 students who will be presenting very interesting cases. And if we all are ready for the session, we will go about it. It will be a session, competitive session. So would request the participants to stick on their time and be ready for the questioning. So saying that, we call upon the first participant, Dr. Payal Chakraborty. And we request others to be ready, Dr. Devashmita Bhattacharjee, Dr. Anjali Gusia, Dr. Ajit Kumar and Dr. Jayashri.
A very good morning to everyone assembled here. I am Dr. Payal Chakraborty, second year MD PGT from Institute of Child Health, Kolkata. And I'm going to present this very interesting case about a child who could walk previously but now is unable to walk, and the parents brought the child to us in the OPD with the same complaint. This was a female child, 1 year 6 months of age, who was unable to walk. But the child could walk previously. At 1 year 3 months of age, the child could cruise with the help of the furniture support, but later stopped walking. Birth history was completely normal. The child was able to sit, but unable to stand independently as well. Predominantly, there was gross motor delay and mild speech delay, but the social and fine motor milestones were normal. Head holding was at 5.5 months, delayed, not on 3 months. At 7 months, the child could lift leg above the bed, but could not bring the food to mouth, unlike other children. Could sit with support between 9 to 10 months and sit without support at 1 year of age. This is a video showing that at this point of time the child was holding the pen, but now when the child is trying to hold the pen, there is a hesitation, like there is a weakness in the muscles. Among the important negative histories, there was no history of seizure, vision or hearing loss, no weakness of upper limbs. It was mostly the complaints of lower limbs. No waxing, waning, no history of any chronic disease. Sensations were intact. And in the family history, very importantly, no consanguinity, no abortion was there. No history of neurological disorders as well. Now here, when the mother is leaving the child is absolutely not being able to take any support below the pelvic girdle. Clinical examination shows the child was conscious and very much interactive with average nutritional status, normal head circumference, no dysmorphism, no neurocutaneous markers were there, higher mental functions were appropriate. Among the motor examinations, significant proximal weakness was there, and this weakness was mainly in the bilateral lower limbs. Truncal muscles relatively were spared, decreased muscle tone was found, and bilateral plantars were flexure, but bilateral knee and ankle jerks were absent, or I can say maybe we could not elicit it. There were no cerebellar signs, no cranial nerve involvement, spine was completely normal, no scoliosis was there, tongue fasciculations could not be seen, and most importantly, no sensory deficit. Among the differential diagnosis, so upper motor neuron lesions, less likely because the jerks were not exaggerated, it was rather absent, and the muscle weakness was progressive. And lower motor neuron lesions, we can have neuropathy, neuromuscular junction disease, myopathy or muscular dystrophy, among which More likely is a neuropathy because jerks could not be elicited. So, among the investigations, we planned for a NCV, that is nerve conduction velocity study, and very interestingly, in the NCV study, we got sensory motor axonal neuropathy involving bilateral lower limbs. Now, they have written to be correlated clinically, but in the clinical setting, we have seen that the sensations were absolutely intact. We did not really opt for an EMG because we avoided to give painful stimulation to the child, and just based on the clinical findings, we directly went for a MLPA for SMN gene duplication or deletion. And in the final diagnosis, we can now say after this test that there was homozygous deletion of SMN1 exon 7 and 8, we can see. But another very interesting finding was in the SMN2 gene, there was heterozygous duplication. That is, there was a duplication of both exon 7 and 8. There were 3 copies each, which says that the phenotype is a better one and might respond better to the treatment. So it's a typical 5q spinal muscular atrophy, and I have written SMA type 3 because the child could walk previously, but now is unable to walk. I am a little confused about the diagnosis as well. I've consulted my geneticist specialist, ma'am, and predominantly there was proximal muscle weakness. We have seen truncal muscles were preserved, no bulbar involvement, no respiratory involvement. So in the management, genetic counseling was done to the parents, physiotherapy for the inevitable contractures which might develop in the later period of time, nutritional optimization with pulmonary surveillance. And definitive management, we all know Zolgensma, we now have it, a one-time intravenous infusion that delivers a healthy working copy of SMN1 gene. But how many can afford in our country? So very obvious that Zolgensma was out of our option, and the child has been, a letter has been given so that the child can obtain risdiplam from the nearest center where the rare disease management takes place. So in the follow-up assessment, our child falls under the non-ambulatory children category, so we can do the CHOP intent score, and through it we can very well assess that how much the child is responding to the risdiplam treatment. And among the functional assessments, standing ability and walking distance and all these are assessed. With respiratory assessment is very important, even though in our case the respiratory muscles were spared till now. Nutrition is important, and orthopedic assessment in the future is important. This is the CHOP intent score, which is done for the non-ambulatory children. It has 16 total parameters and ranges from 0 to 4, and so total from 0 to 64 can be the grades. So learning points is that developmental regression after partial milestone acquisition is a red flag, definitely. So with that, the parents will come to your OPD, and I think the most important thing is to have faith in your clinical findings. Clinical suspicion remains more powerful. A normal CPK value, here what we had was thyroid was normal, CPK was normal, so the congenital myopathies could be very easily ruled out. The child was a female child, so Duchenne muscular dystrophy could be kind of ruled out. In females also it can be found, but very rare. Preserved bulbar function was there, and absent motor neuron signs substantially narrowed the differential for us with absent jerks as well, but intact sensory parameters. And suspicion of a genetic disease, very important, should not always be followed by sending a whole exome sequencing. If we had sent a whole exome sequencing, we could have missed the diagnosis, since West does not
Thank you,
cover.
Payal. Thank you.
Thank you. Thank you.
So, just I wanted to know, Zolgensma you mentioned about, and you mentioned that there was truncal muscles were preserved. How do you assess truncal muscles?
Sir, we can see after making the child supine, if the child is able to roll So the girdles and the truncal muscles are involved in that. In the CHOP intent score, there is a criteria for whether the child is able to roll after laying supine. So in that, maybe we can assess the truncal muscles, and the respiratory muscles also comes under the truncal muscles. So if the respiration is involved, then most likely truncal muscles are also involved.
It's a very nice case. Not its diagnostic part, but it's a management part is most important in this case. So my question, you have in the nutrition part, you have mentioned weight, height, BMI. So the child cannot stand. So how could you take the height in this child?
Yes, sir. It will most likely be length, and we'll have to take it from a like infantometer or with the help of the measuring tape rather than stadiometer.
So you need a corrected height, and you have to
Corrected
mention
height.
this is a corrected height.
Yes, sir.
Okay, thank
Yes.
you.
What do you think regarding the prognosis of this child?
I think, sir, the child will respond very well to the risdiplam treatment because the SMN2 has 3 copies in the exon 7 and 8, which favors good prognosis to the treatment. So probably the more number of genes are there, since we are giving gene modifying therapies, so it will probably respond well. And still now the child has, the main parameters like the respiratory and the truncal muscles have been preserved, so probably we'll go uphill from here.
Any prenatal diagnostic?
No prenatal diagnosis, sir. Even the fetal movements, the counts were absolutely normal in this child.
And this chance of second baby affecting this disorder?
Sir, we have asked the parents to go for a genetic counseling, the genetic testing, but since they are not from a very wealthy background, so we are, not very sure about that, but we'll definitely try to follow up about it. Thank you, sir.
Sorry, madam, no questions on the floor, please.
While you come down, you cannot hear her. Come down and answer to his. Joshua, call the next person.
So thank you for a very nice
Please answer the
presentation.
lady over there.
We will now call upon Dr. Deboshmita Bhattacharya for her presentation. Is she there, Dr. Deboshmita? If she is not there, Dr. Anjali Ghusia for her presentation.
Hello. Good morning, everyone. I'm Dr. Anjali Gusia. Today I'm presenting a case of floppy infant, a diagnostic challenge. So this
We cannot hear you, Anjali. You come a little bit closer.
So this 37-week term, small for gestation age, male neonate, presented on day 15th of life with respiratory distress following a choking episode, with a history of poor feeding, weak cry, and poor spontaneous movement with generalized hypotonia since
Anjali, it's not audible to us.
আরে একটু মাইকটা ঠিক করে দাও না।
Go to the closer. Go.
So coming to the history part, antenatally, mother was 28-year-old G3P1A1 with hypothyroidism on treatment. Antenatal USG showed intrauterine growth retardation, and there was a history of decreased fetal movement. In perinatal history, he was born at 37 weeks, was small for gestation age, and was delivered institutionally. In negative history, there was no history of birth asphyxia or prolonged resuscitation or neonatal seizures. In neonatal history, since birth, baby had a weak cry, poor suck, generalized hypertonia, poor feeding required angio-tube feeding. There was a recurrent episodes of choking and aspiration during feeds. He had a previous admission for poor feeding, lethargy, and dehydration. Current admission was precipitated by a prolonged choking episode with respiratory distress and cyanosis. In family history, nothing was significant. So coming to the examination part, in general examination, baby was alert, responsive to handling, with poor spontaneous activity and cry. In anthropometry, birth weight was 2 kg, length 50 centimeter, head circumference 35 centimeter, around third centile. In head-to-toe examination, baby has fair skin compared to parents, with small hands and feet, and bilateral undescending testes were noted. However, tongue fasciculation and microcephaly could not be noted. Neurologically, baby had frog-like posture at rest with history of marked axial hypotonia, significant head lag in pull-to-sit maneuver, ragdoll posture in ventral suspension, and positive slip-through sign in vertical suspension. There were reduced spontaneous anti-gravity movement with proximal muscle weakness, but importantly, deep tendon reflexes were present. Suck, Moro, rooting, and palmar grasp were weak, while pupils were equally reactive on light, and with extraocular muscles movement were normal. Withdrawal to painful stimuli preserved. So this is a course in our hospital. This baby was admitted with respiratory distress following aspiration and choking episode. He was stabilized with oxygen, with aspiration precaution and angio feeding. Initial evaluation did not reveal an infective, cardiac, metabolic and muscular explanation, as sepsis screening was negative, and serum CPK and echocardiography were normal. IM evaluation was done, which was unremarkable. However, neurological abnormality persisted. MRI brain was done, which showed ventriculomegaly with hypoplastic cerebellar vermis. So pediatric neurology evaluation considered spinal muscular atrophy and congenital myopathy. So at this point of time, we came to our differentials. So can it be a hypotonic CP? A central cause was considered. However, there was no history of birth asphyxia, prolonged resuscitation and seizures. So can it be a metabolic myopathy? An inborn error of metabolism was considered, but there was no metabolic crisis noted, and there was no history of, and IM panel was unremarkable. So can it be a congenital hypothyroidism? Particularly, mother has a history of hypothyroidism, and she is on treatment, but thyroid profile was normal of baby. So can it be a congenital myopathy and myotonic dystrophy? So these could be the possibilities, but maternal myotonia was, maternal myotonic history was absent, and baby had no myopathic phases or contractures. So after excluding all the central, metabolic and neuromuscular differentials, the syndromic clues pointed towards Prader-Willi syndrome. Meanwhile, whole exome sequencing report came, which was sent from outside hospital. It showed large deletion of chromosome 15 along with clinical features suggestive of Prader-Willi syndrome. In all probability, it is a Prader-Willi syndrome, but since MSMLPA is an investigation of choice, we have sent it from our hospital, but report is pending. With NG tube feeding and aspiration precaution, subsequently baby tolerated full feeds and remained free of further aspiration episodes and was discharged in a stable condition. So his approach to floppy infant. So whenever we encounter a floppy infant, the question should not be what is the diagnosis, but where is the lesion. It could be central, central, peripheral, or mixed. In central, it involves brain and the CNS. Here we look for altered consciousness, seizures, developmental delay, dysmorphism, and features suggesting of CNS involvement. In peripheral hypotonia, baby is alert, cognitively preserved, and with poor anti-gravity movements. Motor unit disorders, involvement shows DTR absent, muscle wasting, CPK elevation, and fasciculation. So in our case, it was initially pointing towards anterior horn cell disorders, but importantly, because DTR was preserved, we have ruled out anterior horn cell disorder. Let's discuss Prader-Willi syndrome. Genetic imprinting disorder caused by loss of expression of paternal genes on chromosome 15, Q11, Q13. Incidence is 1 in 15,000, 17,500 live birth. Genetically, 70% is due to paternal deletion of 15, Q11, Q13, 30% maternal uniparental disomy, and less than 5% is due to imprinting defects or chromosomal rearrangement. So Prader-Willi syndrome, in Prader-Willi syndrome, a neonatal period, severe generalized hypotonia with a weak cry, poor suck, and feeding difficulty and failure to thrive dominate. But in infancy and childhood, muscle tone improves followed by hyperphagia. So this is a diagnostic criteria of Prader-Willi syndrome, and this is a genomic mechanism of Prader-Willi syndrome. So there are 4 important genomic imprinting disorders: Prader-Willi syndrome, Angelman syndrome, Beckwith-Weidman syndrome, and Silver-Russell syndrome. So these are the important key takeaways from our case. Approach every floppy infant systematically by differentiating central from peripheral hypotonia. Think of Prader-Willi syndrome in a floppy neonate with poor suck, weak cry, and feeding difficulty. Early genetic testing confirms the diagnosis. MS-MLPA and whole exome sequencing helps to identify the underlying genetic defect. And early recognition prevents delayed diagnosis. Clinical suspicion remains the cornerstone. Thank you.
Thank you very much. I'd just like to know one question. What's the usual lifespan of these patients?
Early 30s.
Sorry?
Early 30s.
Okay.
My question is this. So what are the clinical pointers by which you suspect Prader-Willi syndrome? Because in the differential diagnosis, they are skewed. That means once you get the whole exome sequencing, the whole thing changes like that. So initially, what are the clinical pointers to suspect Prader-Willi, to keep Prader-Willi in your differential list? So the clinical pointers, please.
Sir, there was a severe generalized hypotonia and poor suck, difficulty in feeding with small hands and feet, and bilateral undescended testes.
What was the body weight of the child?
Sir,
Birth weight?
birth weight was 2 kg, and
Yes.
when we discharged the child, weight was 1.8 kg.
So, and any other parameters in the physical assessment?
So, baby was fair skinned than parents.
Are you following this child after diagnosis?
Yes, sir.
So, what are the complications this particular child may have in subsequent years?
So recurrent aspiration, difficulty in feeding.
As the father and mother both contributing the genetic problems, how will counsel the parents for the next babies? As both father and mother, they are contributing the genetic part of the disease. So the next children, if they want to bear, how will counsel the parent?
Thank you.
Thank you, Dr. Anjali. Now we call upon Dr. Ajit Kumar to present his case.
Good morning, everyone. Respected delegates, respected judges. Myself, Dr. Ajit Kumar, second year pediatrics PGT. I am going to present a case on meningoencephalitis masquerading a metabolic revelation. A 2-year, 6-month-old male child presented at ER with high-grade fever for 3 days and difficulty in breathing for 1 day. Having saturation of 90% at room air, this is a video of this child. The child is able to climb up a stair with 2 foot per step, which is appropriate for his age. And coming to birth history, coming at ER, the child presented with irritability, and having increased work of breathing manifested as tachypnea, expiratory wheeze, bilateral subcostal suctioning, intercostal retraction, and bilateral crypts. Color of the skin was pink, which suggests adequate perfusion. Coming to birth history of this child, the child was delivered at term through LSCS delivery, cried immediately at birth, having low birth weight of 1.8 kg, and having history of 3 days of SNCU stay due to neonatal jaundice. But there is no any history of seizure. On doing X-ray, there was upper lobe consolidation in the right lungs, and provisional diagnosis of severe bronchopneumonia was made, and child was immediately shifted to PICU. Put on invasive mechanical ventilation, maintaining saturation of 93%, started on IV fluids, antibiotics, sedatives, antipyretics. But the course of this child in PICU was very disturbing. On day 3 and day 4, multiple episodes of convulsion happened and anticonvulsants were added. On day 4, feature of shock developed, so anatropes added, and on day 8, fluctuating heart rate, persistent tachycardia, raised antipro-BNP. On echo, there is left ventricular dysfunction and ejection fraction was only 20%. So myocarditis was suspected and IV immunoglobulin at the rate 2 gram per kg given over 48 hours. On doing initial investigation, CSF shows lymphocytic phagocytosis, count were 60 cells, glucose 88, which were on the higher side, and macroprotein was 17. And CSF, CS, and viral panel of CSFs were negative. But CSF ATA was on the higher side, that is 48. Normal range is up to 10. Respective viral panel suggestive of rhinovirus and enterovirus. Autoimmune encephalitis markers were negative. Blood CS shows growth of Staphylococcus capitis, and tracheal aspirate show growth of Acinetobacter baumannii. On doing MRI on day 11, there is leptomeningeal enhancement, which is shown by red arrow, and there is arachnoid cyst at retrocerebral region. So at this point, we have some differential diagnosis in this child. First is Adam. In Adam, there is a multiple bilateral focal lesion in brain parenchyma, but in this child, we have not found this. Second differential is viral encephalitis, but viral encephalitis markers were negative. Third is autoimmune encephalitis, and also autoimmune encephalitis markers were negative. And fourth is a stroke. There is no any sudden onset neurological manifestation, and there is no any hyperintense or hypointense lesion in brain parenchyma, so it cannot be a stroke also. Now we are left with the two important differential diagnoses, tubercular meningoencephalitis and metabolic or genetic disorders. The point which is against the tubercular meningoencephalitis are CSF CB-NAT were negative, and in CSF there is no increase in microprotein, and there is also high sugar, and there is no any contact history. So it cannot be the case of tubercular meningoencephalitis also. So at this point we have one important diagnosis, that is metabolic or genetic disorder. So to know about this, we have sent the genetic study of this child also. But the course of the child further worsened. Child is having refractive seizure on day 13, 14, and 15, and blood pressure was also on the higher side, more than 99 percentile. So anticonvulsant were added, and antihypertensive were also added. And after prolonged ventilation, child was finally extubated, but the features like seizure, plantar extensor, regression of milestone, dystonia were still persisting. So repeat MRI was planned. On repeat MRI, there was bilateral enhancement in the putamen and caudate nuclei. And there is no any basal cisternal enhancement, which is against the tubercular meningoencephalitis. In tubercular meningoencephalitis, usually there is basal cisternal enhancement. Here there is no any basal cisternal enhancement. As we are thinking of neurometabolic disorder, so MR spectroscopy was also planned, and MR spectroscopy shows increase in choline peak, decrease in acetyl aspartate. So both MRI finding and MR spectroscopy suggestive of a neurometabolic disorder, that is biotin thiamine responsive basal ganglia disease. So coming to what is biotin thiamine responsive basal ganglia disease. It is a neurometabolic disorder characterized by recurrent episodes of acute or subacute encephalopathy, which is triggered by febrile illness, stress, fever. Usually there is three important phenotypes of this disorder: early infantile, classic, and third is adult Wernicke-like encephalopathy. Early infantile usually manifest in age group between birth to 3 months of age. Clinical features like hypotonia, irritability, feeding difficulties, seizure, and classic manifested as cogwheel rigidity, dystonia, seizure. Cogwheel rigidity and dystonia are the most common feature which is usually present, and it manifests in age group between 3 months to 10 years of age. And after 10 years, adult Wernicke-like encephalopathy usually manifested, and features like seizure, ataxia, ophthalmoplegia. Laboratory findings increase in lactate in CSF and blood both, and MRS shows lactate peak and reduce N-acetyl aspartate. The main cornerstone of therapy in this disease is supplementation of biotin and thiamine. Biotin 5 to 10 milligram per kg per day, and thiamine up to 40 milligram per kg per day, which can be doubled in case of acute cases. And this supplementation should be given lifelong. And genetic studies shows it is an autosomal recessive disorder with biallelic pathogenic variants in SLC 19A3 gene. So take-home message from this case is, this case highlights the diagnostic challenges of differentiating biotin thiamine responsive basic ganglia disease from tuberculosis meningoencephalitis and other common neurological illness. Initially, clinical and neuroimaging suggestive of tuberculosis meningoencephalitis, but later MRI suggestive of, which shows the bilateral enhancement in putamen and caudate nuclei suggestive of biotin thiamine responsive basic ganglia disease, and clinical features like regression of milestone, refractive seizure, plantar extensor also suggest biotin thiamine responsive basic ganglia disease. And after initiation of supplementation with biotin and thiamine, the clinical improvement occurs, and it further strengthens the diagnosis of BTBG. This case emphasizes the importance of considering biotin thiamine responsive basic ganglia disease in children with acute or subacute encephalopathy and bilateral basic ganglia lesion, as if we supplement this child with biotin and thiamine, it alters the neurological outcome significantly. This is a reference, and thank you for your patience listening.
Thank you. Good case. And the part is that the investigations are supporting the diagnosis practically everywhere. Now, I just wanted to know, I was curious about one thing. The child had presented with a respiratory issue. There was a pneumonia, child was in PICU, was ventilated. What was the neurological manifestation when you first got your MRI done?
Child was having seizure was there, and plantar extensor.
At that point of time. And what anticonvulsant did you give?
Anticonvulsant, we have started with Levera.
Which anticonvulsant would you avoid in due course in this child?
Valproate.
Anything else?
Usually about Valproate.
Okay.
So, in this case, what was the precipitating factor that biotin and thiamine deficiency?
Febrile illness started this manifestation, and maybe the deficiency of biotin and thiamine.
So it is one of the rarest of rare
Yes,
condition.
Yes, sir.
So you have mentioned in your one slide that you should be excluded in all other when the patient presents with tubercular meningitis.
Yes, sir.
That should be there, should not be there. It is not the immediate differential diagnosis of encephalomyelitis or TB
But sir,
meningitis.
in this case, all the features of tubercular meningoencephalitis was not matching. So we have done the genetic testing and the repeat MRI spectroscopy or a repeat MRI.
Was there this test like CBNAT or all this thing done?
Very negative, sir. CBNet very negative.
Okay. But CSF ADA is not that much specific and sensitive for TB meningitis.
Yes, sir.
So one point, I think you have given IVIG.
Yes, sir.
So what was the reason of giving IVIG in this patient?
Sir, for myocarditis, we have given myocarditis. There was persistent tachycardia, and the
So how do you explain this myocarditis with the original disease that you have presented? Why the myocarditis occurred in this patient?
So, because of respiratory infection, there may be myocarditis, or
Was it due to the viral infection? That viral panel?
Enterovirus was positive.
Enterovirus was positive
Yes,
in
sir.
your.
Yes,
So
sir.
could it be an enterovirus myocarditis?
Yes, maybe.
Okay, so IVIG was given empirically.
Yes, sir. for myocarditis.
It is rather an observation that from our old days, actually chronic alcoholics usually have this vernix encephalopathy due to thiamine deficiency. Now it is a chilled. That is the marvel of it. Thank you.
Thank you, Dr. Ajit. So now we call upon Dr. Jayashree to present the case. And another important thing that biotin thiamine deficiency, that is not that uncommon nowadays, and the MRI almost mimics Wilson's disease and it can be excellently treated, so that we are getting often.
Good morning to all the dignitaries present here. Today, I, Dr. Joyashree Nandi, a second-year junior resident in the Department of Pediatrics at Arjikar Medical College and Hospital, would like to present my case on Beyond the Seizure, a challenging journey through refractory convulsions. So we had this 6 years, 11 months old boy who presented to us with multiple episodes of generalized abnormal jerky movement of body with loss of consciousness for 1 day, associated with fever, headache, and 2 episodes of vomiting for the same duration. We assessed the child. The child was having poor GCS score of 4, irregular pattern of breathing, cold extremities, and delayed capillary refill time. So we managed the child with rapid fluid boluses. Management of status epilepticus was done, rapid sequence intubation was performed, and child was shifted to PICU. We took the birth history, which was termed normal vaginal delivery boy child who cried at birth. The perinatal events were uneventful. There was no history of trauma, intoxication, or febrile convulsion. The child had attained all the developmental milestones as per age, was immunized up to death. Anthropometrical measurements showed height for age and weight for age was among 75th to 50th percentile. Under general examination, what was significant was the child was having anisocoria. Fundoscopic examination showed papilledema. BP was less than 50th percentile as per age and height. Pulse rate was tachycardia with 180 beats per minute. Pulse volume was low. CPG was 79 mg per dl. Since the child was under sedation, so CNS examination was of no significance at that junction. We sent initial investigation which showed TLC count was 15,000, platelet 58,000, ESR was 70, and CRP was raised to 25. Sodium in the ABG was 134.9 millimoles per liter. So we were thinking, what could be the differential diagnosis? Is it a case of acute encephalitis syndrome or intracranial hemorrhage or any space occupying lesion or autoimmune encephalitis? Or it can be stroke or fires or CNS vasculitis. During the stay in PICU, the child was having a very stormy course. There was raised intracranial pressure which was managed with hypertonic saline and mannitol. On day 4, the child was still having refractory convulsions. So we performed a CT scan which is shown below, showing acute subarachnoid hemorrhage and acute subdural hemorrhage with intracranial hemorrhage, diffuse edema with midline shift towards the right lateral ventricle with 9 mm shift of the midline. On day 5, there was persistently raised intracranial pressure, hypertension with BP more than 99 percentile, so we gave the child injection labetalol. On 6th day, we performed MRI and MR angiography. Side by side, we were doing various other investigations where scrub, lepto, malaria, Japanese encephalitis were all negative. Even the blood CS and urine CS were negative. EEG was performed, which was within normal limit as well. We performed lumbar puncture in this child with CSF count showing 8 cells, few lymphocytes, others were almost normal. Autoimmune panel from the serum was also normal. The MRI finding shows diffuse gyral edema involving the right frontoparietal region with associated intracranial hemorrhage, with subtle sulcal subarachnoid hemorrhage with 9 mm midline shift towards the left side and effacement of adjacent sulci. However, the MR angiography was within normal limit. Day 8, we performed decompressive craniectomy as shown here. Now on day 9 to 13th, the signs and symptoms subsided, but left-sided hemiparesis developed in this child. On day 14th, we were planning to wean off from ventilation, so we have done tracheostomy in this child. Now, since its course in PICU on day 76, a repeat MRI of brain was done since the child was having refractory convulsions and was deteriorating soon, which showed newly developed leptomeningeal and pachymeningeal enhancement on left parieto-temporal region. MR angiography at that point of time was also within normal limit. One by one, we started excluding all the diagnoses which we thought previously. It is not a case of AES or ICH or space-occupying lesion or autoimmune encephalitis or stroke or fires. Now we present it as a case of primary CNS vasculitis. Most likely it is a small vessel CNS vasculitis. So consequently, we managed the child with pulse therapy of corticosteroids, injection methylprednisolone. Child started improving, then we performed cranioplasty and discharged the child. So now what is the discussion on this child? Primary CNS vasculitis is an autoimmune mediated inflammatory rare disease with the criteria of newly acquired focal and or diffuse neurologic deficit and on psychiatric symptoms. Angiography or HPE shows evidence of vasculitis in absence of a systemic underlying condition. It is a very rare of a rare condition occurring 2 to 3 per 10 million children in the age group of 8 to 11 years, presenting with persistent headache, seizures, stroke, and hemiparesis. Still date, MRI and MR angiography are the investigation of choice, and as pediatrician, early diagnosis and treatment alter the neurological outcome. So, in this case, as the inflammatory markers were raised, that gave us a clinical suspicion of CNS vasculitis. Also, we must remember that MR angiography can be within normal limit, suggesting small vessel CNS vasculitis. In this child, brain biopsy was not done due to risk of complications. Take-home message from this is a rare disease and MRI is the main modality. Brain biopsy is gold standard and early immunosuppressive therapy improves outcome. Thank you everyone for your time and patience.
Just have a simple question. You did a lumbar puncture.
Yes, sir. We
Now,
did a lumbar puncture.
What precautions would you take before you go to do a lumbar puncture in this patient?
Yes, sir. As a pediatrician, when we approach any child for lumbar puncture procedure, the first is taking an informed consent from the parents. First, then we will prepare the patient. In this case, when we perform a lumbar puncture, since the child was intubated and was under sedation, so we will take the help. First, we will, from the back side, specifically where there is the iliac crest at that level.
The child had intracranial bleeds.
Yes, sir.
So does that point to something?
Yes, sir. In that case, if there is intracranial bleed in these...
Raised tension.
Yes, sir. In this case, with intracranial bleed and...
What precautions did you take?
What precaution? There was raised intracranial tension in this child, but in this case, we performed aseptically. It was done.
There was papilledema you have mentioned.
Yes, sir.
Already.
Yes, sir. Papilledema was also present in this child. Once we ruled out that papilledema subsided, only then we have performed this lumbar puncture in this patient.
Okay, you have mentioned platelet count was 58,000. How do you explain that low platelet count in your case?
So it was the finding that we got when the child came to us. But
You have mentioned there's a raised intracranial tension.
Yes, sir.
So what may be the reason? The vasculitis, where such raised, severely increased intracranial tension was there?
Sorry, sir, I didn't get it.
Why there is a raised intracranial tension in your case?
Oh, raised intracranial tension was because of the hemorrhage that has occurred in the brain that was having a mass effect which was compressing the ventricles of the brain, and there was a midline shift associated with that, due to which there was a raised intracranial tension in this child.
You did CSF study, and also you have mentioned there is a subarachnoid hemorrhage and subdural hemorrhage. So CSF was xanthochromic?
No, sir, it was not xanthochromic at that point of time, because at that point of time, repeat papilledema was ruled out in this child. Thank you, everyone.
Thank you for your presentation. Now we call upon Dr. Deboshmita. And another thing, CNS vasculitis previously thought to be like fatal. Now it is almost treatable most of the times with good immunomodulators. We use cyclophosphamide, and MR vessel wall imaging is now available in Kolkata also to have a good diagnosis.
Good morning, respected chairmen, judges and colleagues. I am Dr. Deboshmita Bhattacharjee, first year pediatric resident, RKMS P. Today I am presenting the case of an 8-year-old girl with prolonged fever and an evolving neurological illness. I have chosen to present this case as a timeline because in retrospect, the sequence of symptoms was the most important clue to the final diagnosis. This case highlights how neuroinflammatory disorder can initially masquerade as an infection before revealing its demyelinating nature. This is an 8-year-old female who presented with persistent fever of 15 days duration. She had initially been admitted to a local hospital and received broad-spectrum antibiotics, including meropenem and amikacin, followed by doxycycline, but showed no clinical improvement. At this point, the first red flag was already apparent: persistent fever despite adequate antimicrobial therapy. She was therefore referred to our center for further evaluation. By day 15, the fever continued. Investigation showed marked systemic inflammation with significant leukocytosis, elevated CRP, and a high ESR. However, the infectious workup was unrevealing. Blood and urine culture were sterile, and common tropical illness, including dengue and scrub typhus, were negative. So at this stage, we were facing a child with persistent fever, strong inflammatory markers, but no identifiable infectious focus. Then the clinical picture changed. On day 18, she developed neck rigidity. This immediately raised concern for CNS involvement. MRI brain showed features suggestive of encephalitis, and CSF examination revealed lymphocytic pleocytosis. Our differential broadened considerably. We considered viral encephalitis including HSV, EBV, inflammatory demyelinating disorder, CNS vasculitis, and even malignancy. Acyclovir was started and extensive investigation were continued. However, despite all of this, a undefined diagnosis still remained exclusive. Then on day 26, she developed ataxia, incoordination, and reluctance to stand. This was the major turning point. If we look at the story now, first prolonged fever, then neck rigidity and encephalitic feature, and now ataxia with a motor abnormality. MRI of the cervicodorsal spine showed bilateral longitudinal spinal cord gray matter lesion suggesting inflammatory myelopathy. This shifted our thinking towards a neuroinflammatory disorder. We sent an anti-MOG antibody and it was moderately positive, and suddenly the pieces began to fit together. The fever had initially suggested infection, the neck rigidity and CSF findings suggested encephalitis, and the ataxia and spinal MRI suggested inflammatory myelopathy. and the positive anti-MOG antibody provided the crucial clue. The final diagnosis was MOG antibody-associated disease, MOGAD. This video demonstrates her ataxic gait at the time of neurological worsening. Informed consent has been taken from the parent. She was treated with IV methylprednisolone followed by IVIG. The response was encouraging with marked improvement in gait and coordination. She was discharged on a tapering dose of oral steroid. At this stage, we hoped the disease had entered remission. However, approximately 2 months later, she returned with decreased vision, predominantly affecting right eye. MRI orbit demonstrated bilateral optic neuritis. Visual acuity in the right eye had deteriorated to finger counting, while the left eye remained normal. She again responded well to methylprednisolone with improvement in vision. This relapse confirmed the relapsing nature of her disease. After TPMT testing, azathioprine was initiated as maintenance immunosuppressive therapy along with a slow steroid taper. Looking back, 3 clues were particularly important. First, prolonged fever that behaved unlike an infection. Second, the gradual emergence of neurological sign. And third, the progression from encephalitic features to inflammatory myelopathy and subsequently optic neuritis. The anti-MOG antibody ultimately connected what initially appeared to be separate clinical events. This case reminds us that sometimes the diagnosis only becomes apparent when we observe the evaluation of the phenotype over time. My take-home message is simple: prolonged fever with evolving neurological manifestation should prompt consideration of neuroinflammatory disorder, including MOGAD, even when classical demyelinating features are absent initially. Affected children often exhibit markedly elevated systemic inflammatory markers, which can lead to misdiagnosis as severe bacterial infection, resulting in unnecessary broad-spectrum antibiotic use and delayed diagnosis. Early recognition is important because these children often respond dramatically to immunotherapy, and timely treatment may prevent long-term neurological morbidity. When a fever no longer behaves like an infection, it is worth stepping back and reassessing the diagnosis rather than continuing to pursue infection alone. Thank you for your attention.
Thank you, Devashmita. Now, when you had the diagnosis getting MOGAD through investigations, at that point of time, were there any ophthalmic manifestations?
Yes, sir, we did VEP and OCT, which was negative, normal actually.
So it did not have any ophthalmic manifestations at that time, but they presented later on after 2 months.
With optic neuritis.
Okay.
When there is a prolonged fever with such a neurological manifestations, how do you rule out the most common infection, that is your tuberculosis, CNS tuberculosis?
Sir, we did CB-NAT from gastric lavage and IGRA, then we did CB-NAT from CSF also.
Okay. Any other autoimmune
Yes.
workup like ANA and the
Yes,
others?
sir, we did autoimmune, ANA also we did autoimmune, which was normal.
Initially, there was no ophthalmological manifestation.
No, sir.
And you started anti-inflammatory immunosuppressive at that time also.
Yes, sir. We actually, when the MOG came positive, we started methylprednisolone. The child improved a little. Then we have to give her immunocompression, IVIG.
So what do you think? In spite of immunosuppression, the patient developed after 3 weeks or something, patient developed visual problem.
Yes,
What could
sir.
be the reason?
In MOGAD, there can be a relapse after 1 month of the treatment.
So it is a process of exclusion. By process of exclusion, you have reached the diagnosis. The lifelong treatment of this immunomodulator with methylprednisolone or something, oral prednisolone like that?
Sir, we have to give azathioprine as an immunosuppression, and we will bridge it with steroid. For at least 2 years, we will monitor the patient. If there is no relapse or no significant symptoms, then we can taper down.
So long-term follow-up is necessary.
Yes, sir.
Thank you very much.
Thank you, Dr. Devoshmita. So here we come to the conclusion of the oral paper presentation. Now we will proceed towards poster presentation in a different area beside the registration counter. I request the judges to proceed there, and as well as the participants, Dr. Ritodip Nondi, Dr. Bornali Kishku, Dr. Mitranjan Khan, and Dr. Jahid Ahmed. Now over to Sir for the next.
Thank you, judges and the moderator. Now we conclude the
Please,
session.
the judges, the moderator, chairperson, please stay there. On behalf of Institute of Child Health, we would like to honor you with a small token of appreciation for your time, knowledge, and your dedication. This is Dr. Subhashis Bhattacharya. This is my classmate, Dr. Arun Mangoli. Only. So now we will start to our next session. One of our star attraction and one of our very respected guests. May I call Dr. Surjit Singh to please come to the dais. And I'd like to also call our head of the department, Dr. Priyankar Pal. Priyankar, please come to the dais. And where is our, I'm not seeing, director is here. Dr. Apurvo, you are here. So before we start anything, I'd ask them to let's have our Independence Day is today, so let's have the national anthem before we start the next part. Start. I'll ask the director, please come to the dais. So, may I hand over the mic to Dr. Priyankar Pal, who will be introducing our guest, Dr. Surjit.
So, good morning. in a gathering of pediatricians, I don't think Professor Singh needs any introduction actually. So I think his legacy speaks what he is. And Sir will be speaking on his favorite topic, Kawasaki disease. And we all know that what we know about Kawasaki disease in India is because of what he initiated years back. So over to Sir.
Okay, good morning. So it's been 69 years since Dr. Kawasaki described this condition in Tokyo. And over these 69 years, we have made a lot of progress in as far as diagnosis of this condition is concerned, treatment of this condition is concerned. In India, it's been close to 30 years since we became aware that this disease exists in India. And even in India now, awareness about this condition has gone up significantly. But there are still several loopholes in the diagnosis, several loopholes in the treatment about which we need to be aware so that we can take care of these lacunae. So this is a recent systematic review and meta-analysis that we have done at PGI, which shows that worldwide, 1 in 9 children with Kawasaki disease have coronary artery aneurysms at the time of presentation. That means when they first come for medical care, 1 in 9 already have developed aneurysms. So what it means is that the diagnosis has been delayed. These are worldwide data. And the pooled prevalence of coronary artery aneurysms worldwide is 11.8%. That means in spite of whatever advances have been made in treatment, 11.8% children, when they are discharged, when they are followed up, still have aneurysms. So there is still a lot of work that we need to do. And this is a cause for serious concern. That means in spite of whatever knowledge we have gained over these 70 years, we still are nowhere near perfection. So I have taken up 5 areas where we can make some progress and which can help in early diagnosis and better treatment of this condition. So the first and foremost fault line is that the diagnosis of this condition is completely clinical. So we know that Kawasaki disease, what it is, fever for at least 5 days, presence of 4 of the following 5 conditions which we all know, and illness not explained by any other known disease. So when we see a typical case of Kawasaki disease, there is really no problem in diagnosing these children. But the mistake that we often do is start an endless process of investigations. And it is these investigations which often lead us astray. Kawasaki disease remains a clinical diagnosis. It was a clinical diagnosis in 1967 when Dr. Kawasaki first described this. It remains a clinical diagnosis in 2026 when we have so many investigations available. In 2017, the American Heart Association gave a very important update as far as diagnosis of Kawasaki disease is concerned, and this pertained to the fact that diagnosis of KD can be made even if the characteristic signs are present only on history. That means we don't have to document it. If the mother claims that there was a rash, if the mother says that the eyes were red, even this is included in the diagnostic criteria. The idea was to pick up more and more patients with Kawasaki disease. In the recent update of 2024, the stress has shifted on to early diagnosis. So it's not only is it important to diagnose KD, but it is equally important to diagnose KD in time before the coronary damage has occurred. So in the 2024 update, the stress was that you can diagnose this condition even at day 3 and day 4 of fever if the clinical setting is right. The second place where we falter is in recognition of incomplete Kawasaki disease. So in centers all over the world where there is a reasonable cohort of KD, the percentage of patients who have incomplete KD varies somewhere between 30 to 50%. That means almost 1/3 to half of our patients with Kawasaki disease have incomplete KD. So what it means is that the criteria that we have for diagnosis of KD are nowhere near perfect. So we have to be on the lookout for identifying children with incomplete Kawasaki disease. So incomplete Kawasaki disease basically means that there is presence of less than 4 of the following 5 conditions, the usual conditions. That means all 4 conditions are not there in the child. So that means if a patient has, for instance, conjunctival injection which has disappeared, or if the mother has not noticed, it could still be Kawasaki disease. The rash may have disappeared, the mother may not have noticed, but that didn't stop the physician from picking up incomplete Kawasaki disease. This was a 1-year-old boy who presented with fever for 7 days and had extreme irritability. Now, in this child, there was no other clue other than the fact that there was a reactivation of the BCG injection site. In this setting, where there is fever, extreme irritability, and this BCG inactivation site reactivation, there is no differential diagnosis. This child does not fulfill the criteria for Kawasaki disease. He has what is known as incomplete Kawasaki disease, and he needs urgent treatment. If you delay the treatment because the criteria not being fulfilled, we can land up in serious difficulty. So this is the challenge of incomplete Kawasaki disease. The AHA guidelines have also highlighted the importance of picking up incomplete Kawasaki disease. In 2017, the AHA guidelines highlighted the fact that incomplete Kawasaki disease is by no means mild Kawasaki disease. In fact, it can be even more severe because the diagnosis gets delayed and hence the treatment gets delayed. In 2024, they have gone a step further and they have said, do not wait for the full phenotype to manifest itself. You have to pick up incomplete Kawasaki disease in these given clinical circumstances before you get the full phenotype. Because if you wait for the full phenotype, it may be just too late. The other thing that they have highlighted is that treatment for incomplete Kawasaki disease, just as treatment for complete Kawasaki disease, has to be done early, ideally in the first 10 days, and these days they are saying ideally in the first 5 to 7 days. Even 10 days may be too late. So you have to pick up KD, you have to pick up incomplete KD in the first 5 to 7 days. A couple of years ago, we carried out a collaborative study for incomplete Kawasaki disease at 4 centers in the Asian region. This was coordinated by Dr. Hiromichi Hamada, and incomplete Kawasaki disease was seen in almost 1/4 of the patients with Kawasaki disease at these 4 centers. And BCG inoculation site reactivation was a useful clinical sign for diagnosing IKD in Asia, but there were regional differences. For instance, it was much, much higher. The occurrence of this reactivation was much higher in countries like Japan and Taiwan, but was not seen that frequently in India. But if you have incomplete Kawasaki disease, coronary artery aneurysms occurred in almost 1/5 of these patients. 20% of patients with incomplete Kawasaki disease had coronary artery aneurysms. Carrying this study a little forward, we reanalyzed our patients with BCG site reactivation over the last 20 years, and we found that patients with Kawasaki disease who have BCG site reactivation had a much, much higher risk of coronary artery aneurysms. So this is, in a way, a surrogate marker for a high risk category of Kawasaki disease, BCG site reactivation. The third fault line that I wish to highlight is regarding imaging in Kawasaki disease. Now, over the last maybe 40 years, a concept has grown that echocardiography is the be-all and end-all for imaging in Kawasaki disease. The reason is that this was the only imaging modality that was available to us all these years. But around 2010, people started working on other imaging modalities like CT coronary angiography and MR coronary angiography. MR coronary angiography in KD has been done in very few centers. It requires a lot of skill. It takes almost 45 minutes to do the scan, and technically it is very, very difficult to master. While CT coronary angiography takes just a few seconds, it's much easier to do, and this is one modality which has come up in a big way over the last 15 years. So we must now realize that imaging in Kawasaki disease goes much beyond echocardiography. With echocardiography, we have to remember that echo is likely to be normal in the first 7 days of fever, even when the child has classic KD. That means if the echo is normal, it should not be assumed that KD is not there. If you do the echo on day 5, day 6, it's going to be normal, even when the child has book picture Kawasaki disease. And echo studies need to be repeated frequently. At Chandigarh, we do it on a daily basis. The echo is repeated on a daily basis. This may not be practical at all places. So echo has many limitations as far as Kawasaki disease is concerned. Then there are various Z scores that are available. There are at least 5 well-documented Z scores that have been published. But if you look at the Z scores, so in this child who was 2 years old with a weight of 12 kg, height of 89 centimeters, you look at the left anterior descending coronary artery. The difference in Z scores in the various scores that have been published can be substantial. And according to one of these Z scores, the Z scores here were touching close to giant aneurysms, while according to some other score, it was just above normal. So this is a difference that can occur depending on which Z score system you are using. All Z score systems are correct, but they have been devised for a given population. We don't yet have standardized Z scores for most of the Asian countries, except Japan. So they have lot of lacunae. The Z score systems that have been published have lot of lacunae. They may be valid for one population and not for another. So since 2010, CT coronary angiography has come up in a big way. At our center, Dr. Manful Singhal started doing this in 2013. That was the time when we acquired the 128 slice CTCA machine at Chandigarh. But the problem with CTCA is the radiation exposure. If you're not careful, you will end up giving close to 10 to 15 millisieverts radiation to the baby, which is totally unacceptable. So what Dr. Manfool did was to try and decrease the radiation exposure. And this he did by working with the Siemens team, by playing around with the software, by playing around with the injection technique. And over the years, what we have now developed there is we do the procedure under light sedation, never under anesthesia. In the United States, when they do CTCA in Kawasaki disease, it's almost always under general anesthesia. We have never used general anesthesia. We just use light sedation. Then this has to be done, these are technical terms, but radiologists would understand. This is done with a prospective adaptive ECG gated sequence. At most centers, it is done with retrospective gating. We have to do it with prospective gating. The tube voltage is only 80 kVp. At most centers, they will do it at 100 or 120 kVp, which increases the radiation exposure. So with this methodology that Dr. Manfool has used, our radiation exposure is less than 1 millisievert, which arguably is the lowest radiation exposure for doing this procedure anywhere in the world. So this has been, this is a technique that he has developed over the last 13 years. And with this technique now, we are doing this procedure more and more frequently in children with Kawasaki disease. And what have we learned? We have learned that aneurysms in the left circumflex coronary artery, which are missed on echocardiography, are picked up on CTCA. For years, we have been taught that aneurysms are rare in circumflex artery. But that was because echo was not picking up those aneurysms. If you start doing it, you pick up aneurysms in the circumflex artery, and we see them in almost 1/5 of patients with Kawasaki disease. The second major finding was, we have always been taught that Kawasaki disease affects the proximal segments of the coronary arteries. The middle and distal segments are not affected. Again, because echo never picked up the distal aneurysms. So on CT coronary angiography, when you start doing it, you realize that a significant number of these aneurysms are in the distal segments. Some of them are only in the distal segments, while in other babies, they occur both in proximal and distal segments. With echo, you will miss the distal aneurysms. Can CTCA be done during the acute phase of KD? That means when the child is still febrile, he's still sick, can you do it right away? And Dr. Manfool started doing this during the acute stage. And this is perhaps, till date, the only publication where CTCA has been done not on follow-up, but during the acute stage of Kawasaki disease. And how has that helped us? This was a baby who developed a thrombus in the proximal left anterior descending artery. This thrombus was missed on echo. And it's very difficult to pick up a thrombus in the coronary artery during the acute phase. It was missed, but it was picked up on CTCA. This child on echo appeared to have what looked like a dilatation of the left main coronary artery. But when this CTCA was done, it was found that this was a congenital anomaly. In this patient, there was a single coronary trunk from which both the right coronary and the left main coronary artery were arising. There was no dilatation of this trunk. This was found out only on CTCA. Had we rested only on echo, we would have ended up over-treating this child. So anomalies of the coronary arteries occur in somewhere between 2 to 3% patients. But if you're doing only echo, you're likely to miss this, and you're likely to, there'll be problems in the treatment of a given patient. The fourth fault line that I would like to stress on is the treatment of Kawasaki disease. So till around 2005 or so, treatment appeared to be very straightforward. You diagnose KD, you give IVIG. It was as simple as that. Around 2005, people started realizing that IVIG is not enough. There are many other drugs which need to be given so as to decrease the risk of developing coronary artery aneurysms. So in the 2017 update of the American Heart Association, they emphasized on treatment augmentation. That means if a child has been given IVIG, he is not improving, or he's developed IVIG resistance, then you augment the treatment with IVIG, second dose of IVIG, or you use infliximab. Then they realized even this is not enough. So in the 2024 update, they went a step further, and we now have treatment intensification. That means you start with drugs other than IVIG, in addition to IVIG, right from the beginning, based on coronary risk stratification. That means when the baby is admitted, you find out whether this is low risk or high risk KD, and then you intensify the treatment. So standard risk and high risk KD, high risk KD needs treatment intensification with infliximab and steroids, and a large proportion of children with Kawasaki disease fall in the high risk category. All infants, especially male infants, they are high risk. Infants who have had fever for long durations, they are high risk. Infants who have very high inflammatory parameters, they are high risk. Then infants with macrophage activation syndrome or shock syndrome, they are all high risk KD. They need treatment intensification ab initio, right from the beginning. KD is not a one-time disease of childhood. Mothers often ask that if the coronaries were initially dilated, now they are normal, is my child going to be normal? May not be. Because those coronaries which have been affected by KD, they will never become normal. They may be anatomically normal, but functionally they will never be normal. And these coronaries, if you do the CTC on follow-up, they may blow up as coronary calcifications. So this was a child, 11-year-old child, who was treated at 4 years. When we did the CTC at 11 years, this is what she showed. Her coronary calcium scores were that of a 77-year-old elderly person. This is myocardial ischemia in young adults on KD follow-up. That means these children who were not picked up as KD during childhood, when they were followed up, they had developed coronary artery aneurysms as adults, and they landed up in the adult coronary care units. This was a child who we had diagnosed as incomplete KD in 2015, treated, we thought we had picked up incomplete KD, done a good job, but in 2025, 10 years down the line, this child had a sudden death. So this is what Kawasaki disease is. Follow-up has to be indefinite, virtually lifelong follow-up. So at the last IKD symposium in Montreal, the theme of the symposium was Kawasaki disease is a medical emergency. There is just a window of 3 to 4 days in which you act. If you delay the diagnosis or the treatment, the consequences are going to be very grave. Any mistake that you commit is going to be a fatal mistake in some cases. And Kawasaki disease does in 5 days what atherosclerosis does over 5 decades. So that is the importance of Kawasaki disease. Thank you very much.
Thank you, Dr. Surjit Singh. May I call our principal, Dr. Joydev Rai, to hand over a small token to Dr. Surjit Singh. Our next topic will be clinical conundrum in pediatric endocrinology, and the speaker is Jaivinder Yadav, and she would be introduced by Dr. Hriday De. Dr. Hriday De, are you here? Dr. Hriday. I think Dr. Hriday is not there, sir. You may start now.
So thank you. Good morning. So at the offset, I want to thank you, the organizers, especially Dr. Apurva Ghosh, for giving me the opportunity to speak along with the experts in the field of pediatrics. So I would be discussing 5 cases of common pediatric endocrine disorders. So some of which presented with the common manifestation with uncommon diagnosis. In some cases, the diagnosis was easy, but the management was challenging. So we will begin with the case of Master A. The child was 1 year, 3 months, and the parents brought this child with the main complaint of increase in the penile length. So for last 2 months, parents were concerned about the increasing penile length and there was some pubic hair growth at the base of penis. So whenever the child present with these manifestations at this age, this are features of precocious puberty, and the chances of organicity are much more higher if the child presents at the age less than 6 years with precocious puberty. We tried to rule out the causes, common causes of organicity in this age group. So we asked about the increase in testicular volume. So according to parents, the testicles were normal in size. So usually precocious puberty is associated with height spurts. So there was the parents didn't notice any height spurt. There was no change in voice or facial hairs. So these features are suggested that the manifestations are recent in onset only. So regarding the CH is one of the common cause of precocity which can present at this age. So there were no features of hyperpigmentation, any features of adrenal crisis, constipation, muscle cramps. No features, CNS features suggesting some intracranial space occupying lesion like headache, blurry vision, vomiting, fever. And no features suggestive of any abdominal mass or suggesting any abdominal tumor. So McCune-Albright is one of the uncommon diagnosis which can present with precocious puberty in this age group. So no manifestation suggesting McCune-Albright syndrome like skin lesions, cafe au lait spots or recurrent fractures, and there was no history of any drug intake regarding the exogenous exposure to testosterone. So other history like birth history, developmental immunization history was normal. The onset of puberty in the parents was at normal age. So there was no early precocity in the parents. And so in examination, most of the examination was normal, no neurocutaneous markers. In anthropometry, the height was slightly on higher side as compared to mid-parental height. So in SMR staging, we noticed that the testicular volume was increased. It was around 5 cc and the penile length was 8.2 centimeters. So there was some discordance between the penile length and the testicular volume we expect at this point. So we use usually this is the standard staging system which is used for assessing the SMR staging in children. So this child has SPL of around 8 centimeter, testicular volume of 5 cc and small stage 2 pubic hair were present. So this is the normal sequence of pubertal events in males. So usually the onset of average age of onset of puberty in males is around 11.5 years, and any onset of secondary sexual characters below age of 9 years in boys is considered as a precocious. So it follows a sequence of gonadarchy. First sign of puberty in males is increase in the testicular volume, then it is followed by the pubarchy, pubic hair, and growth spurt, and in last it's a spermarchy. So usually testicular volume and the penile length go hand in hand. In our child, the testicular volume was corresponding to stage 2, but the SPL was close to stage 3 or stage 4. So there was a discordance. So this is not a typical feature of central precocious puberty, because in that central precocious puberty, both go hand in hand. So other examinations were normal. So this is the summary of the case. 1 year, 3 month child presenting with precocious puberty with testicular volume of stage 2 and the penile length of around stage 4. So main differential diagnosis we kept are central precocious puberty because the testicular volume is on higher side. CH should be ruled out because sometimes the puberty may be peripheral in onset, but it can switch to the central and follow up. Rare causes, if you have ruled out the central precocious puberty, still the testicular volume is high on bilateral side, then the HCG secreting tumor should be ruled out. And one very rare diagnosis is familial male limited precocious puberty, but usually strong family history is there in these scenarios. So this is the normal development of puberty. So mainly the HPG axis get activated, the GnRH act on the gonadotropes in the pituitary, leading to LH and FSH secretion, which acts on the Leydig cells in boys and serotonin cells, which increases the testicular volume. So testicular volume increases because of both serotonin cell and the Leydig cell, and major contribution is from the Leydig cell. In girls, it acts on theca cells and the granulosa cells to cause follicular growth and the hormonal secretions. So in boys, as I discussed, the first sign is gonadal enlargement and followed by pubarchy and penile enlargement. In females, the first sign is the thelarchy. So what are types? So types is central, it's gonadotrophin dependent true puberty. This is the normal sequence of puberty which occurs in all children. So peripheral puberty is, it's independent of the normal HPG axis. The source of the gonadotroph, sex steroids is from the either adrenal or from the testis, which is independent of HPG axis. And sometimes it may be combined, it may be peripheral from to begin with, and then the central axis kicked in. So how do we differentiate? So true precocious puberty, the HPG axis is active and there would be high amplitude of GnRH, and then there would be gonadotrophins, LHFSS would be raised, and it follows the normal sequence which happens normally at appropriate ages, and it's always isosexual. In comparison, peripheral precocious puberty or pseudopuberty, it occurs as independent of HPG axis, and the source of the androgens is from adrenal gland or the testis, which is independent of HPG axis activation or exogenous exposure, and it can be heterosexual as well. So this table lists the from the Nelson common causes of gonadotrophin independent precocious puberty. So it can be adrenal disorders like CH, tumors, familial limited precocious puberty, testicular tumor, or HCG secreting tumor, or exogenous exposure. So this is our experience of precocious puberty, and most of the children who have presented, especially in boys who have presented less than 6 years, the organicity is much more common, and we are able to pinpoint the lesion in more than 50% of the cases. So testicular volume can give us a clue about the etiology. So if both testicles are enlarged, then it points towards your central precocious puberty. If the testicles are small in size, then it points towards your peripheral precocious puberty. So if your testicles are enlarged but they are not corroborating with the other markers of puberty like your pubic hair or the penile length, then you should consider HCG dependent precocious puberty. And if there is asymmetrical enlargement of testes, then the testicular tumor should be ruled out. So this is the standard biochemical workflow which we use in diagnosing precocious puberty. So we use LH, FSH and testicular size. So if your LH is raised and testicular volume is more than 4 ml, then CPP is diagnosed, central precocious puberty. In case of LH or borderline LH, we do GnRH stimulation, and if your stimulated LH is more than 5, then it's suggestive of CPP. If it is less than 5, then peripheral precocious puberty should be ruled out. So common causes are your adrenal tumors and the testicular tumors. So we do USG abdomen and testicles. And if they are normal, then you have to look for the rare causes. So CH should be ruled out, testotoxicosis can be considered, and the HCG and other tumor markers like AFP should be done to rule out the beta HCG tumor. So in our case, the LH was on lower side 0.3 only, those just borderline. FSH was normal, testosterone was raised. So we went ahead with the GnRH stimulation test. GnRH stimulation test was normal. The peak response was just 1.9. So suggestive of peripheral precocious puberty. Ultrasound abdomen and scrotum was done, which was normal. So we were not able to pinpoint any cause of precocious puberty in this child. Then we went ahead with the beta HCG, and it was raised, and AFP was also raised. So it was suggestive of beta HCG secreting tumor. So what is the source of this tumor? We were confused. So we went ahead with the imaging of MRI and chest and abdomen to rule out the tumors. So in MRI, we were able to find out one small hyperintense lesion in T2 sequence, and the tumor, the differentials given were primary hepatic germ cell tumor versus hepatoblastoma. So the child underwent the resection of the tumor mass, and the histopathology proved it to be a mixed germ cell tumor. So few days later, we got a second case, 7-year-old child who presented with features of polyuria, polydipsia, and the features of precocity, increasing in phallic size and pubic hair. In addition, the child has other features of hormonal deficiency. He had history of dizziness, history of fever, vomiting, history of seizure was there, and features suggestive of hypothyroidism like constipation, lethargy, and cold intolerance. So this child has history of multiple pituitary hormone deficiency along with precocious puberty. Although he didn't have any classical features of raised ICP or any seizures or compression of the ophthalmic pathway. So on examination, the blood sugar was on lower side, the height was slightly on higher side as compared to the mid-parental height. In this scenario also, the testicular volume was small, it was just 4 cc, but SPL was 9 centimeter. So again, there was discordance between the penile length and the testicular volume. So we were expecting central precocious puberty in this child. So we went ahead with the endocrinal investigation. So endocrinal investigation was suggestive of multiple pituitary hormone deficiency. Thyroid profile was suggestive of central hypothyroidism. Cortisol deficiency was there. Testosterone was raised 200, but LH was just 0.3, suggesting peripheral precocious puberty. Serum osmolarity was normal, but urine osmolarity was just 45, suggesting central DI. So we suspected some tumor. So most likely we were suspecting germ cell tumor. So we went ahead with the tumor markers, and AFP and beta HCG in this child was highly raised, and we went ahead with the CSF level of HCG and AFP, they were also raised. So MRI was planned, and this child got a huge mass in the supracellular region in heterogeneous cystic mass suggestive of germ cell tumor. So the child underwent the chemotherapy, and unfortunately the child succumbed to the complications. So now we have third case. This was a 4-year child who was developmentally normal, and the parents were noticing the child is having excess weight gain, poor height gain, and generalized hirsutism and pubic hair for last 2 years. Along with this, the child has cushingoid features, stunting, and stage 2 hypertension, but the parents were taking the child to different practitioners, but no diagnosis was made. They tried alternate medicine as well, and this child has features of virilization. So this was a heterosexual case of precocious puberty in a young child with androgen excess, cortisol excess, and hypertension, and the child suffered one episode of stroke as well. So these are the photographs of the child. You can see that the child has a lot of hirsutism, and the pubic hair are stage 4. And in addition, the child had clitoromegaly as well, suggesting heterosexual precocious puberty. Normally, we expect in precocious puberty, height spurt is there. But if your height is compromised, or if there is a slowing of height velocity, then there are only 2-3 differential diagnoses you should consider, either adenocortical tumor and hypothyroidism. These are the 2 common diagnoses in a child with precocious puberty and growth failure. So this child has growth failure and precocious puberty. So endocrine investigation we did, the cortisol was highly raised, and the DHEAS was very high. So suggestive of adenocortical tumor. Mostly adenocortical tumors are easy to diagnose in childhood because most of these are functional tumor, and they secrete both cortisol and the sex steroids. So we went ahead with the imaging, and the CT abdomen was suggestive of huge suprarenal mass on the right side, and the child underwent the surgery and doing well after 5 years of surgery now. So moving ahead with from the precocious puberty, now I will discuss one case of infantile onset obesity. So this was a 3-month-old baby which we received, and the parents were complaining that the baby is having excess weight gain since day 20 of life. And the weight gain was almost double which we expect from at this age. It was around 58 grams per day, and along with this the child has features of diabetes insipidus, like parents were changing diaper every 1 hour. However, parents denied any exposure to drugs or any other signs of precocity, but the weight gain was around 2.75 Z scores, and the baby was falling in obesity range according to the growth parameters. And on examination, the child was detected to have hypertension. So from the look, we can find that this child has features of Cushingoid features, suggestive classing Cushing disease. So moon-like faces, plethora was there, short neck was, chubby appearance was there. So and in addition, we find a mass in the abdomen. So there was 6 into 5 centimeter mass in the right lumbar region, along with features of this Cushingoid features. So it was considered to be a functioning adrenal mass because the child is having classical Cushingoid features. So common adrenal masses which can present at this age, because the onset was very early, we were considering that it is a fetal origin mass. So common differentials are adrenal hemorrhage, neuroblastoma, pulmonary sequestration, but it was functioning mass. So it was not fitting in. So we were considering adrenal adenoma and adenocortical tumor as our first differentials. So we went ahead with the investigations in this child. So biochemistry was normal. The endocrinal investigation revealed that the cortisol was highly raised. It was 1300 plus, and ACTH was suppressed, suggesting adenocortical tumor, and DHS was slightly raised for the age. And the echo was suggestive of left ventricular hypertrophy, suggesting that hypertension was long-standing. Then parents give history that the antenatally also some mass was described by the ultrasonologist, and so we went ahead with the antenatal scans, and the mass was detected in the antenatal period. So we went ahead with the MRI abdomen, and the large suprarenal mass was detected, and it was a functioning adenocortical tumor. So FDG PET was done. It was metabolically active mass. So the child underwent the surgery, and the mass was resected in toto, and histologically it was suggestive of adenocortical carcinoma, but there was no capsular breach, and the child has good outcome. Now he is around 7-year-old and doing well. He is developmentally normal, and the all features disappeared within 3 to 4 months after surgery. So this is the last case. So this was the diagnosis was easy in this case, but the management was challenging. It was a 14-month-old girl who presented to us and admitted twice with us. The baby was diagnosed as preterm LGA child, 2.73 kg, developed hypoglycemia since day 1 of life. So admitted outside, worked up for the hypoglycemia, and the critical sample revealed that this baby has persistent hypoglycemia with raised insulin level, suggestive of congenital hyperinsulinism. But the hypoglycemia was difficult to manage, and it was persisting beyond 2 months, so the baby was referred to us. So we evaluated the baby, and the cause was known that this child is having congenital hyperinsulinism, no family history, no risk factors for transient hyperinsulinism in this baby. So baby had cherubic faces, hairy forehead due to the drug received for hypoglycemia, but failure to thrive. Typically these babies have excess weight, but because this child was mostly on IV fluids, that's why the weight was on lower side. So this baby was fitting all features of congenital hyperinsulinism, like normal pH, low ketones, and hyperinsulinemia. And we went ahead with the genetic testing, and the genetic diagnosis was ABCC8 in gene mutation. which is pathogenic, and this mutation is difficult to treat because it doesn't respond to the common drug which we use for management of congenital hyperinsulinism, that is digoxide. So we tapered that drug and we switched on to the second line drug, which is octreotide. So most of the children who doesn't respond to digoxide respond to octreotide. And we went ahead with the continued glucose monitoring in this child. But still this child is having 32% of events of hypoglycemia. We expect it to be less than 1%. So we went ahead with the imaging. So sometimes if we find a focal lesion, then that lesion can be resected and the child gets cured. But in this mutation, we expect usually diffuse disease. So there was no focal lesion identified in the DOPA PET. So the child was planned for near total pancreatectomy because that's the last resort which is left with us if the child is not responding to the medical therapy. So this child underwent the near total pancreatectomy. 95% of the gland was removed. And the histopathology was suggestive of this insulin secreting tumor. So in second admission, we were able to taper off the IV fluids. We were able to taper off his octreotide, and we discharged the child on spoon feed. But again, the child got admitted after 4 months with repeated episode of hypoglycemia. So even after 95% resection, the child was still having excess insulin secretion. So we have to restart on the octreotide. And after a few months, we switched on the long-acting octreotide in this child. And now the baby is doing well, growing well, and the development profile is normal for this child. So this was the photo of the child at the age of around 14 months, developmentally normal. Thank you.
Thank you, Dr. Jaivinder Yadav. May I ask you to please come down? I asked our beloved Dr. Maya Mukhopadhyay to kindly hand over a memento. Mayadi was our head of the department, and it is a great honor that she has come.
And Mayadi was my first boss also. I started working under Dr. Maya Mukhopadhyay.
Now, may I call our pediatric skin expert, Dr. Sandipan Dhar, who will be talking about common and interesting cases in pediatric dermatology.
Good morning. Thanks to Paulson's Dharma for sponsoring this particular session. I shall share a series of interesting cases. Some of them are common, some of them are certainly not. But what I would like to do in next 20 odd minutes is trying to give you some clue for some very important things, either diagnosis or prognosis. Let us come to the first case. Hyperpigmented macule in a 5-year-old boy. Most of the time, you think it is a post-inflammatory hyperpigmentation or sometimes a epidermal nevus, isn't it? But would you like to think something else? PGTs and residents, mostly and younger dermatologist, pediatrician colleagues. Do you find something else here? Don't you see this? Or that? Here? Okay. Once you stroke, immediately the diagnosis is in front of you. This is called Derrier's sign. And immediately you can make the diagnosis. It is a case of cutaneous mastocytosis. So the take-home message from my end is, which I always share in various platforms, that don't discard a simple hyperpigmented macule in a child without stroking it. So you might be missing cases of mastocytosis. I have seen innumerable number of cases being missed as what I said just now. And as you know, mastocytosis can infiltrate the organ and become systemic mastocytosis. So it was a case of mastocytosis, and what you saw is Darier's sign. In neonatal intensive care unit, NICU, very irritable newborn, just few days old, with this type of lesions, which are extremely tender on palpation, and child winces, the baby winces on pressure. Any diagnosis? Anybody could think? Oh, wonderful. Who said that? Kya? It was your case, I think, in ICU, ICH. So, what you have to do, that you have to see it carefully, because this is very important. And something more important than that is doing some investigations and counseling the parents, because the parents become very much, anxious about it. You have to counsel them, because by and large subcutaneous fat necrosis of the newborn is a self-limiting disease in more than 95% of the cases. There are occasional complications which I shall be talking with you in a short while from now. So what investigation? One single investigation you will do. Of course, if required, if it is protracted, you will do a skin biopsy, but something more than that, something else, blood test, calcium, wonderful. So you have to do a calcium level, and as you can see in our institute's report, you can see the calcium level is high. So why the calcium level is high? Anybody has any clue? Any answer to that? Because this necrosed fat is engulfed by macrophages, and they release huge amount of 125 dihydroxy vitamin D, right? So that increases the calcium level. Not only that, there is associated complications in case of extensive subcutaneous fat necrosis or very severe type of subcutaneous fat necrosis. Other complications are hypoglycemia, anemia, and thrombocytopenia. By and large, subcutaneous fat necrosis with mild elevation of the calcium level doesn't require any treatment. It is self-limiting. But if it is severe, you might have to recourse to short course of oral steroid, or you have to give biphosphonate also, and stop dietary intake of calcium in all possible ways. These are very severe cases of subcutaneous fat necrosis I am talking about. So this was the case of subcutaneous fat necrosis of the newborn. See this case very carefully. This 4-year-old child is brought with eczematous lesions on the body, on the face. See the face. Something interesting you can observe, lot of hemorrhage on the skin, isn't it? Hemorrhage also occurs in atopic dermatitis. This looks like atopic dermatitis. Immediately some dermatologist or you will make a diagnosis of atopic dermatitis. But there is a difference between hemorrhage seen on skin of atopic dermatitis child versus in this condition. I shall be coming to what is this condition. See, this is an atopic dermatitis child where there is a lot of hemorrhage you can see on the face, but something else you see is severe crusting. It indicates that there was oozing which has dried up and this crust, and because of itching this hemorrhage has occurred on the face, which you don't see in the case I just now highlighted. Do you see such things? You don't see. But you see frank hemorrhagic points. See one more case of atopic dermatitis. There are marks of scratching and there is hemorrhage, right? Which is much different from the case which I am presenting to you right now. There is no mark of scratching. So where from the blood is coming? So basically then you have to do a peripheral blood smear by a good hematologist, pediatric hematologist, and look for what? Unless you can make a diagnosis, you can't say what. What is the diagnosis? What you should look for? Both the count of platelet as well as the size of platelet, both will be less, right? This is called microthrombocytopenia. And that clinches the diagnosis of Wiskott-Aldrich syndrome. Of course, after that, you can do a lot of genetic studies, WAS gene and all these things. But these are the very important clinical markers to clinch the diagnosis. Many a times, these are confused by one of the finest dermatologists of the world also, has been confused. So it is extremely difficult in some situations. So that's why I have brought such cases, I told you at the beginning. On the trunk also you can see similar kind of thing, hemorrhages, crusting, and it looks identical like atopic dermatitis. So it was a case of Wiskott-Aldrich syndrome. Unfortunately, you know, this child when, we saw in our institute has already received cyclosporin for atopic dermatitis. And that has added fuel to the fire, fuel to the fire. The platelet count has gone down further. So it is extremely important to make a correct diagnosis for the prognosis of the child. Come to the next case, a 3-month-old female infant presented with hypopigmented macules of 3 months duration. Just follow this case. I will show you gradual evolution of this case. You see the hypopigmented lesions on the trunk? Both the earlier case as well as this particular case, both Dr. Apurva Ghosh and myself saw. I'm sure he must be smiling, sitting there. So we diagnosed initially as a pityriasis alba. And also we kept a possibility of post-inflammatory hypopigmentation. Sometimes it is very important, particularly in dermatology, I believe not only in dermatology, in all specialty, to follow up the child for a long time. And that's why the criteria of diagnosing SLE has come, that it is a gradual evolution of several criteria. It is true for all diseases. So one time, don't jump to the diagnosis just at the first glance. You follow up the child. Many times you may not be able to reach the diagnosis. 2 months later, see the same child. No convulsion. I saw somebody's expression. So there were lichenoid papular lesions. Any dermatologist, if you show this picture, will make a diagnosis of lichen nitidus, I am sure, and we also made the same diagnosis. But that was wrong. We thought these are all lichen nitidus. And we followed up the child. Because we are not very happy of making a lichen nitidus. I have seen hundreds of lichen nitidus, but I have not seen this type of lichen nitidus. Why I am saying this type of? There were some hemorrhagic points actually, with which I was a bit, confused. Is it lichen nitidus? Is it something else? Let us see after another 3 months what happened. The baby was brought to us with the lesions over the scalp, stuck on lesions, lichenoid lesions, not like seborrheic capitis or seborrheic dermatitis, but something which is we call infiltrated. It is there inside the dermis. It is not on the epidermis, outside the surface, along with something which is very clinching for this diagnosis. There is hardly any other clinical diagnosis where you will see such infiltration over the palms and soles. I am sure many of you by this time must have made your mind about the diagnosis. May I hear from anyone? LCH, wonderful. Yes, by the time the baby has developed low-grade fever, hepatosplenomegaly, diffuse infiltrate on the X-ray chest, X-ray skull showed osteolytic lesions, X-ray chest, diffuse infiltrate, X-ray skull showing osteolytic lesions. Skin histopathology was done, which showed that on hematoxylin eosin stain there are large cells with pale vesicular cytoplasm and coffee bean shaped nuclei. I have been taught this. I am not an expert in dermatopathology. So we made a diagnosis of Langerhans cell histiocytosis. We did the immunostaining. As you all know, that S100 protein once was very popular, but it is not well validated. So nowadays we don't attach much importance to S100 protein analysis. CD1A antibody is more specific and sensitive for picking up the cases and confirming the diagnosis of Langerhans cell histiocytosis. So this is CD1A antibody staining. Next case. So this was a case of Langerhans cell histiocytosis. Here you see, this is very clear-cut margin of vesicles on, ophthalmic division of the trigeminal nerve dermatome in a 5-year-old boy with moderate pain. They don't have much pain like adult patients. What is the diagnosis? Herpes zoster, yes, that's right. You see clear demarcation at the central line. That is the hallmark of herpes zoster, which often confuses with another conditions. Unfortunately, this girl was treated with acyclovir for 7 days. After that, the girl was brought to me by the parents saying, "Doctor, the herpes is not going." I looked at the child and after that examination, I said, "There is no herpes. How it will go?" You see another, same child, after my treatment, same child, I gave just topical steroid and antihistamines. Sorry. So this was a case of insect hypersensitivity. Some insect rubbing has occurred because of the secretion of the insect. There is bezier pattern of, sometimes it is very peculiar, it happens on the dermatome exactly like herpes zoster. But you can also see that it is not restricting to, ophthalmic division. It is going beyond that, and it is a very bizarre pattern. And a very important clue I can give, whenever you are in confusion, ask the parents, when did they see these lesions first? And in 90% of the cases from my 35 years plus experience in pediatric dermatology, I can tell you, the parents will say when they got up in the morning from bed, early morning. Because overnight the insect has crawled. Right? That will give you a clue to the diagnosis. And confirming the diagnosis and not confusing is so very important for not only the disease, but also the prognosis as well as counseling of the parents. This is a 7-year-old girl. As you can see, she has lamellar ichthyosis, the entire body. But something which I wanted to bring to your notice is look at the eyes. Many a times we tend to forget. I mean, we means I say even our dermatologist colleagues also. We tend to forget to look at the eyes. We get busy with the management of the skin. But the child cannot close the eyes. And there is a huge risk of exposure keratitis. So be careful. Send the child to a pediatric ophthalmologist for the necessary measures. Because unfortunately, I am aware of 2 children who lost their eyes, lost their vision because of keratomalacia, because this type of, ectropion was not corrected. This type of ectropia needs to be treated very aggressively, no less aggressively than the ichthyosis. So we tend to forget often. This is my last case. 5-year-old boy with high fever, failure to thrive, skin rash appearing 3 days after starting phenobarbital for convulsion, had lesions over the trunk. Can you see the lesions? I'll show you the close-up of the lesions. This lesion has a very characteristic appearance. Any dermatologist will say that this is something which is stuck on appearance, looks like psoriasis, but unlike psoriasis, when the entire thing is taken out, it leaves behind a raw surface. And that suggests that this is not psoriasis, but something else. What is this something else? Is histology showed psoriasis from appearance? Any guess? See, he had psoriasis-like lesions on the scalp also. But he had something more, and two very important clues we got while examining the child. Lesions over the glans penis. Entire circumference of the glans, prepuce is inflamed. This is called sarcinate balanitis. And swelling of the knee joints. So, what is the diagnosis? Psoriasis-like lesions, sarcinate balanitis, bilateral knee joint arthritis with effusion. Next step, ESR was 90. In how many diseases you get ESR of 90 with this type of presentation? Does it remind you of some disease? Ritter's disease, wonderful. So it was suggestive of pustular psoriasis. Then we had to do HLA-B27, which came positive. So it was a case of childhood Ritter's disease. So please do remember, in certain situations, difficult situations, you have to solve it by following several steps of presentation, not only restricted to the skin, but beyond skin also. So I have come to the end of my presentation. This is the color atlas and synopsis of pediatric dermatology, 25 years of endeavor by me, starting from 2000, and this is the 5th edition. Let me share with you that this is currently the only book in the world in skin of color on pediatric dermatology which has seen the light of 5th edition, and for this I was felicitated in World Congress of Pediatric Dermatology, Buenos Aires, Argentina, 2025 April. Thank you. One more thing. This is the Bengali book for the parents actually, about the skin care, how they should take care, mother mostly, of their child, and what are the early signs that they should not do panic, they can manage at home. And the name of the book is Shishu Talk Ojana Kotha, that means Baby's Skin Untold Story. So if you are interested in this book, it is there in the Nivedita stall, just opposite to ICH, huge banner with Indian flag. So you can collect it. It is 500 rupees per copy. And when it was released, I promised to Dr. Apurva Ghosh, not only as a director of this institute, but he gave huge inspiration to me to write this book. Apurva, do you mind coming over the stage? Because there is some little formality to do. So whatever royalty has been collected from the sale of this book, today I am going to share, hand over one small check of 1.5 lakh rupees to him. And that makes it total 4.5 lakh in 3 installments. In fact, the 1,000 copies of the book, 500 rupees you can calculate, it is 5 lakh. Only the production cost is deducted. Rest everything I have given to our institute for the underprivileged children's treatment.
So may I request our beloved Shatiji to hand over the memento. And I also request Sandeepan, please hand over the check to Dr. Thank you. Now I hand over the mic to Dr. Shurupa will.
Good morning, ladies and gentlemen. Very happy to share with you that ICH is now growing bigger academically, in research, and of course, infrastructurally, with a new 10-story hospital coming up in the same premises. In this enduring yet very enriching journey of ICH, we have had so many friends, great doctors, great philanthropists, and great thought leaders of Bengal who have helped us along the way. So it is befitting that on this auspicious day, the Independence Day of India, the 80th one, and the annual day of ICH, we felicitate a few of our friends of ICH. And one of the great personalities we have with us today, whom we want to felicitate on stage, is Dr. Shubhendu Rai. Sir, please. Nobody needs an introduction to Dr. Shubhendu Rai. He's the director of Drs. Ryan Trivedi Laboratory, a great senior histopathologist. Sir has helped us solve many difficult cases in ICH. A big round of applause for him. Ladies and gentlemen, with a big round of applause, felicitation to Dr. Shubhendu Rai. Can we have Dr. Kundu on stage, please?
I'm yet to see a senior pathologist handing over all the reports to all the patients and individually discussing with the patient about their reports. I mean, I'm so grateful to Dr. Shubhendu Roy that he is our ultimate faith. Whenever we are in trouble, we send the patients to Dr. Shubhendu Roy. And the parents and the patients are so happy because he will individually deliver all the reports to all the patients in the evening. Thank you, sir, for your contribution to the, West Bengal, not only West Bengal, all over the eastern region, he is famous. And it's one of the famous institutes, someone said that it's one of the famous institutes of Asia also. Thank you, sir.
Good morning, everybody. I really want to thank the organizers, ICH and Dr. Apurva Ghosh, for inviting me to be here this morning. It's indeed a very big honor for me to be here this morning. And I take this opportunity to thank, firstly, my teachers who have inspired me and helped me during my formative years, and then my colleagues, my peers, and also the public of Calcutta. I've tried to do my best. I don't think that anything is enough, no matter how much you try, but I'm very, very thankful that in my twilight years, I'm happy to have got all the support and help from all my colleagues. Thank you.
Thank you, sir. So our judges has given the results of the paper presentation and also the poster presentation. May I call the head judge, Dr. Arun Mangulik, to come on the stage and announce the results. There is a small token of prize for the winners, and which we will give it later.
May I request our co-judges to be here, please? Yeah, Dr. Shubhashish and Dr. Shumantro and Dr. Shapan Mukherjee, please. Dr. Shapan Mukherjee, please. Shumantro, please. So the presentations were really wonderful, and it was difficult at times to judge out. But yes, there has to be a final day. So I'll start. So the fifth person was, we'll start from the back in the paper presentation, was Dr. Anjali Gusia. The fourth was Dr. Joyshri. The third was Dr. Payal. Are they all here? The second went to Dr. Ajit Kumar. And the winner for the, obviously everybody has guessed, was Devoshmita Bhattacharya. The only flaw in her was that she came late. Now in the poster presentations, there were 3. The third person was Dr. Mitranjan Khan. The second was Dr. Ritudeep Nondi. And the winner is Dr. Bornali Kishku. Are there any of the presenters here, please? Come. They can get the certificates. They were. You collect, you're the first, you're the winner, so you collect your cash prize from Dr. Kundu. He'll take care. So he's the second prize winner. Yeah, you can also collect your certificate, please. Anybody else on the paper presentation, please come. So now we come to the poster presentations. Please come. Bornali, she is the winner. And Mitranjan, please. I think 2 of the presenters are not here. They can take the certificates. Yeah. Thank you.
Thank you. Yeah.
Up next, we have our next presentation, Bleeding in Children, Lessons from the Lab, by Dr. Jasmina Aluwalia. And we will also like to welcome Dr. Deepshika Maiti for the introduction of the session.
Welcome to this August occasion. Our pleasure. We often see patients, kids, presenting with different kinds of bleeding. And Dr. Ahluwalia is going to bring to us important lessons from the laboratory regarding these children with bleeding, how to proceed about them. She is a very senior person from the Department of Hematology, PGI, Chandigarh. We welcome you to Kolkata and look forward to an enriching session.
Thank you so much for that. The only pathologist here in an August gathering of pediatricians. I think the biggest learning comes from our mistakes, and the clinicians may make a mistake or the lab may make a mistake, but it's that exchange between the two that teaches us a lot. I'm going to share a couple of cases from where I have learned, or we have been able to tell our clinicians what they need to do to improve our testing. There are two types of referrals that are made for bleeding disorders. One is that the clinician writes specifically, please do a factor VIII assay for me, and that's all that I have to do in my lab. The second is I get a form saying, bleeding disorder, please work up. So you may be following any of these patterns. Let's see what happens when we get cases like this. So bleeding, we know, in children can present at any age. It can vary in severity from a mild epistaxis to a fatal intracranial hemorrhage. And it can be the result of anything. Either the factors are deficient, or the platelets are less or abnormal in function, or the vessel wall is defective. The etiology can be very varied. ITP is a very common diagnosis in pediatrics. Trauma, leukemia, infection, sepsis, vitamin K deficiency, and sometimes an inherited bleeding disorder. All of them may present in the same way, So the lab really plays an integral part in helping out the clinician to fix the cause of bleeding. Despite having very severe bleeding, many times the cause is not apparent. So of course, there's need for laboratory testing. We'll help you categorize the coagulopathy, whether it is coming from a platelet defect or a coagulation factor defect. Once we fix that, we may help you to subcategorize it so that you can treat it better. For instance, von Willebrand disease, you might want to treat type 1, type 2, and type 3 differently. And once treatment starts, we need to monitor the therapy. So that's where the lab will help you. Let's go through some general things which I feel I should share with my clinical colleagues, because these matter very significantly to us. Coagulation tests are expensive, they are difficult to perform, and they're very finicky to how you collected the sample, transported it, and how it reached the lab. So we are very, we always emphasize this, that collect the right sample in the right way. History there's no getting away from history, that it's the integral part of coagulation testing, be it your clinic, be it our lab, we need the history. Deep muscle bleeds, hematorosis, we would think of a coagulation defect, whereas if it's a mucocutaneous bleed, then I'd think of a platelet function defect, and I'd direct my testing in that fashion. The presence of a comorbid disease like liver disease or DIC is very, very important for us to know in the lab. Most of the coagulation factors are synthesized in the liver, so a liver disease may cause lowering of coagulation factors. DIC consumes coagulation factors, so a very sick child, the cause of bleeding may be this, rather than an inherited disorder. Has the patient received any recent transfusions? Because then I'm not going to be able to give a baseline factor level in that patient, and my test results will be compromised. So what we need is a freshly drawn citrate sample for coagulation tests. No samples which have been stored in the fridge are encouraged. Any sample that's underfilled or that was hemolyzed because of bad collection or got clotted at the time of collection or while transport is going to be rejected. At our institute, we actually have a pathologist DM resident sitting who screens the history and screens the kind of sample we are getting into the lab, because it's that vital for us to be sure of what we are releasing as the report. So all of you are very familiar with this diagram on the right side. This is the coagulation cascade. We know that we use this to reach the diagnosis of a coagulation factor deficiency. The intrinsic pathway consists of factor 12, sequentially activating 11, sequentially activating 9, sequentially activating factor 8, and then it comes onto the coagulation, the common pathway where factors 2, 5, and 10 are activated to finally convert fibrinogen into insoluble fibrin, which forms the clot. In the extrinsic pathway, there's only factor 7, which has to team up with tissue factor and activate factor 10. So though this is not what is truly happening in the body, this is what is happening in the test tube, and we make use of it to set these tests up: the prothrombin time, the activated partial thrombin time, the fibrinogen assay, platelet count, with the platelet count, a blood film examination, the thrombin time, and the bleeding time. So these 6 tests are essentially the screening coagulation tests, which are actually a must for, taking us forward when we undertake the investigation of a bleeding disorder. Clotting time, a great favorite among some of the clinicians, is an absolute no-no in today's world. We have so many better tests that this is not very reliable except in certain circumstances. So the PT looks at the extrinsic pathway and will be also prolonged in common pathway defect, and the APTT will be prolonged in the intrinsic pathway defect, but also will be prolonged with the common pathway factor deficiencies. Now, what do I do when I see a prolonged PT or APTT or both in our lab tests? The next thing, if I get a prolonged clotting time, I have to take a call. Now, is this a factor deficiency or is this an inhibitor? There is no third option for me. So for that, the next thing I do is we mix the sample with normal plasma, which provides a deficient factor. So if it's a factor deficiency, this would correct. And once I get a correction pattern, then I would confirm that factor deficiency with a factor assay. Suppose it doesn't correct with normal plasma, that means there is an inhibitor in the sample, and the common inhibitors that we see are lupus anticoagulant, anti-factor VIII antibodies, and heparin. Heparin in hospital settings. We are often not told that the sample was drawn from an indwelling line, so we have to keep our minds open to this. And then we go ahead and do the specific tests for those. But remember, in many bleeding disorders, the initial coagulation screen may completely be normal. So these are the commonest one would be von Willebrand disease. If we are thinking of that, the clinician should warn us, and we would put up a panel of the von Willebrand factor antigen and activity assays. The other one is factor 13 deficiency, for which we will do a 13 assay or a urea clot solubility test. And the last group is the platelet function disorders, where we really have to do a whole number of tests: flow cytometry, release assays, light aggregation, and even EM sometimes to reach the diagnosis. So with this background in mind, it's a sketch. I know now we'll be seeing a lot of numbers, but that's unfortunately what I had handled in the lab, so I can show it to you from this side. A female child weighing about 2.7 kgs had bleeding from the umbilical stump on day 3 of birth. There was a history of an elder sibling death in the family with bleeding, but there were 2 healthy siblings as well. She was worked up at a nursing home where the coagulation test revealed a prolonged PT and APTT. So the neonatologist there correctly thought of a vitamin K deficiency and gave her 1, 2, and 3 injections of vitamin K, but there was no improvement. So she was sent to our lab, and we repeated the tests again. And as you can see, both the PT and APTT are prolonged, just as they were in the center which she had been seen before. The only thing else that we added was the third part of our coagulation screen, which is the fibrinogen assay. And here we see that the fibrinogen is low. This patient has actually afibrinogenemia, which is presenting with bleeding from an unusual site. So the other causes of PT and APTT prolongation, which we might see in children, is vitamin K deficiency, liver disease, DIC, but these would have the correct clinical settings along with them. The child is usually unwell. Or we can have inherited deficiencies of factor 2, 5, 10, or a combined factor 5 and 8 deficiency. So this case is just to highlight that if you do not use the complete screen and just say PT, APTT karva do, you might miss a rare diagnosis, but this would not be made without a fibrinogen assay level. So this should be a part of our screening coagulogram. A 16-year-old girl was referred to us with history of multiple episodes of epistaxis and 1 episode of hematochezia. There was no history of joint swellings or ecchymosis or menorrhagia, and the center from where she was referred showed that there was a prolonged APTT. So correctly, the pediatrician thought that this is a von Willebrand disease and asked us to work up accordingly. And when we see her screening coagulogram, we see that it's just the APTT which is prolonged, which is what we already know. So now the next question to answer is this prolonged because of a factor deficiency or an inhibitor? The answer is, I have to do a mixing study in the lab with normal plasma. So this is how we do. The patient's plasma is prolonged, APTT 107, but when I mix it with normal pooled plasma, that 107 comes down to 30. It's corrected from 107 to 30. So this is likely to be a factor deficiency. Now, which factor deficiency? The commonest I'd think of would be a von Willebrand disease. In von Willebrand disease, the APTT is prolonged due to a factor VIII deficiency. So the next thing we do is a slightly more prolonged mixing study in which we mix the patient's plasma with a factor deficient plasma. So suppose the patient's plasma does not have factor VIII, and I mix it with a factor VIII deficient plasma, and the clotting time remains prolonged. That means that is the factor which is deficient in the patient. In this patient, when we did a mixing study with factor VIII and 9 deficient plasma, we see that the clotting time is correcting from 107 to 32, which means she does not have a deficiency of factor VIII and she does not have a deficiency of factor 9. So von Willebrand disease is out. So what should we do next? The third coagulation factor in the intrinsic pathway which causes bleeding is factor 11. So we add factor 11 deficient plasma, and now we can see that her clotting time is prolonged. That means her plasma and factor 11 deficient plasma are deficient in the same thing. So this is a factor 11 deficiency, which is confirmed on factor 11 assay to be very low. This is a very rare bleeding disorder, very uncommonly seen in our country. And the important part is the factor levels do not correlate with the amount of bleeding she has. These patients may present late. Some of them may not present till they have been given a surgical challenge. So it's very important that when we pick up these rare bleeding disorders, we must screen the other siblings in the family because they may not have presented yet they may have very low factor levels which may put them at risk for bleeding. So all females who have bleeding and a prolonged APTT are not von Willebrand disease. The third case is of an 11-year-old male child who had petechiae and ecchymosis since a month and a half of age. After that, he bled from various sides. Post-trauma, he had epistaxis, he had hematuria, but there was no joint bleed. And when we screened him, we found that he had a prolonged APTT. So the first thought, male, bleeding, prolonged APTT, we would think of hemophilia A. But we go algorithmically. What is the first thing we need to do? Is it an inhibitor or a deficiency? So we do a mixing study which suggests that it has a factor VIII deficiency, which is confirmed on a factor VIII assay to be 3%. So I've signed this report out as a moderate hemophilia because in moderate hemophilia we have factor VIII levels between 1 and 5%. At this time, our laboratory had just acquired a new coagulation analyzer on which we would be able to do von Willebrand factor assays. But von Willebrand disease is not very commonly referred to us for workup, so we were not getting enough cases to open the first kit. We started collecting a number of patient samples just to see how the kit would behave in different situations. And this child sample was also kept for testing. 1 month later, when we did the test, we find that his von Willebrand factor antigen was less than 5 and his activity assay for von Willebrand was 5. So what we thought was a moderate hemophilia was actually a von Willebrand disease. So all males with low factor VIII are not hemophilia A, and it's very important to exclude von Willebrand disease in cases of moderate and mild hemophilia, since severe von Willebrand disease can have factor VIII levels between 1 and 10%. This is so important for us in the lab to correctly identify, because if you send a patient for prenatal testing or for carrier screening, and we screen the patient of von Willebrand disease for the hemophilia A gene, we are likely to release a normal result, which means we may go completely wrong in our antenatal testing. So this was a game changer for us, this case. After this, in all cases of hemophilia, we do a von Willebrand factor panel, irregardless of the factor levels. A 4-month-old baby was brought with history of irritability, and he had subdural hematomas, but there was no history of trauma. He was on anticonvulsants and had received fresh frozen plasma prior to coming to the hospital. Now in this case, when we started the workup, we looked at the PT and APTT, which are very prolonged, and so the fibrinogen is normal, so it's not afibrinogenemia. Now the next thing we have to answer, is this a deficiency or is this an inhibitor? So we do a mixing test. Here both the PT and APTT are prolonged, so we do a mixing test on both of them. And what you can see is that in the mix, both the PT and APTT are correcting. So this is a factor deficiency. But because both PT and APTT were prolonged, my thoughts are now going to a common pathway defect. That is either a factor 2 or a 5 or a 10 deficiency. So we try and mix with those deficient plasmas, but we didn't get a very clear picture. So next thing left to us is to do factor assays. In this child, the factor 2 assay was 24% and the factor 10 assay was 17%. So now in a 4-month-old child, when I get these values, I don't want to think of an inherited bleeding disorder straight off. This is a multiple coagulation factor deficiency, but I really don't know if it's inherited or acquired. So what we do is, if we look at our coagulation cascade, with this data, it looks like there is a factor 10 and a factor 2 deficiency. Now, this could be as a result of liver immaturity or liver dysfunction or vitamin K deficiency. Vitamin K deficiency goes out here because the patient's is very much a contender here because the patient's factor 5 levels are normal. Vitamin K, factor 5 is not a vitamin K dependent factor. So obviously this child received vitamin K and was referred to came back to us at a later time. We needed to reconfirm these findings to pinpoint what was the bleeding disorder. 2 months later, when he comes, we see that the PT is a little better. The APTT is also better, but still very much prolonged. So now we do a mixing test only on the APTT, and we see that it corrects to 35. So we have a factor deficiency. Last time there was a factor 2 and factor 10 deficiency, so we recheck them and we find that they are now normal. But what we can see is that the PT was a little prolonged, so we run the factor 7 assay and we get that factor 7 is lower than that in adults, but all right for a 6-month-old child. But what we are now suspicious of is that what is causing this factor APTT to be prolonged so much. We just tested with factor 8 deficient plasma and we see that there is no correction. The clotting time of the mix is 100. So this, and when we did a factor 8 assay here, we confirm that this child has hemophilia A. If we had left that child at 4 months of age, he was labeled as a multiple coagulation factor deficiency. It's only on repeat testing that we could confirm this. And now we are looking at the intrinsic pathway. So this is where our focus is now on factor 8. And we reconfirmed this on a repeat test 9 months later. So this brings me to the concept of developmental hemostasis in children. We must, all of us, remember that factors 2, 5, 7, 9, 10, 11 will not reach normal levels till 6 months of age. Any abnormal report that you are encountering for children with bleeding with these factors, please keep this in mind. This needs to be confirmed after they are 6 months of age. These factors may cause prolongation of PT-APTT. Always compare with pediatric reference ranges, and vitamin K deficiency recent transfusions in these patients can confuse the picture. So repeat testing is sometimes required to reveal the real cause of bleeding. A 6-year-old girl came with nephrotic syndrome. Her hemoglobin and TLC were normal, but the nephrology unit reported thrombocytopenia. There was no history of bleeding, and in the family history, the mother also had thrombocytopenia along with hearing loss, and her maternal uncle had been diagnosed as ITP and had already undergone a splenectomy. So the nephrology unit says this is a syndromic autosomal dominant thrombocytopenia with nephrotic syndrome. And to them, MYH9 gene defect was the most likely possibility, and they asked us to look at the peripheral blood film to see for May-Heglin anomalies which are seen in neutrophils in this condition. So we saw the peripheral blood film, and I can see a large platelet which is marked out by an arrow, but I could not see any inclusions in the neutrophils in this child. And there was no history of bleeding. Now the child kept coming on follow-up. Every 6 months the junior resident would change. Every 6 months we would get a film. Every 6 months I was asked to look for May-Heglin anomalies. I was really tired, and I said, there must be something else. You should think of something else here. The child was lost to follow-up. She reported to another center in 2015, where she underwent workup for nephrotic syndrome, including a mutation analysis. And when the mutation analysis was done, it revealed a heterozygous missense mutation in the MYH9 gene. So this was a real problem here. Now this MYH9 protein is very interesting. It's important to maintain cytoskeletal integrity, and it's shaped like this. There is a head part, there is a hinge part, and a long tail. And it's a huge gene with 40 exons, and there can be a mutation anywhere. And those mutations which are present in the head area and in the tail area usually have neutrophilic inclusions. Those mutations which are close to the hinge area do not have neutrophilic inclusions. Our child had a mutation there. So my thought process that it was not MYH9 because I did not see inclusions was wrong. So MYH9 is a set of spectrum of disorders, and where neither is macrothrombocytopenia common to all, nor are neutrophilic inclusions common to all, nor is sensory neural deafness or nephritis or cataract common to all. So in our patient, because we had these three things, she fits in Epstein syndrome. So not all MYH9 related disorders are associated with neutrophil inclusions. The story doesn't end there. She came back 10 years later with fever and lethargy and splenomegaly, and now on her film we could see blasts, and she's developed ALL. She responded very well to ALL standard risk therapy, and just because she was such an interesting case, we looked back, and on reading we find that myosin heavy chain 9 is a tumor suppressor gene. So there's more to it than what just meets the eye, and there's still much to learn about the MYH9 gene. This was highlighted in one of the publications from the department, where we have to rely on genetics more than morphology to reach a diagnosis. And just 3 months later, a 10-month-old child was investigated for thrombocytopenia. He had one episode of epistaxis. He had a low platelet count. And now when we look at the neutrophils, you can see a blue inclusion in the neutrophil, which is the MYH9 inclusion. So the father also had low platelet count, labeled ITP. Grandfather had low platelet count, labeled ITP. So this patient now fits into the May-Heglin spectrum of MYH9 related disorders. An 11-year-old girl came from Patna. She had CNS infarct and was on aspirin. There was body ache and weakness, and the clinician asked for a factor V assay. Now factor V assay is a very odd request in a patient who has a stroke. We thought maybe they are asking for factor V Leiden, which is a mutation associated with a risk for thrombosis. But no, the clinician said this patient has had an episode of epistaxis. I don't want to keep her on aspirin if that is the fact, and some lab from Delhi has reported that she has low factor V levels. So we tested this child again. All the screening coagulation parameters were normal. The factor V assay was normal. We also did the genetic mutation, which was normal. So what could have happened here? I think the factor V Leiden mutation was wanted, but what was ordered was the factor V assay. The sample was transported from Patna to Delhi, and factor V is a labile factor. If it's not handled well in transportation, it degenerates. So the factor V levels were low. So I think it's very important for our clinical colleagues also to remember that they must ask and tick for the right test. Factor V assay is not equal to factor V Leiden mutation. So I'd like to conclude this small talk with the following points: that good history and good communication are indispensable to the diagnosis of bleeding disorders. Piecemeal screening can delay the diagnosis. Confirmatory tests and follow-up tests are sometimes necessary for final characterization. Acquired causes have always to be excluded first, they are more common, and genetics has an indispensable role in the accurate diagnosis of some bleeding disorders. My learning has been the result of a very good lab, very supportive people, and a very good team of clinicians and DM students who believe in my right and wrong reports and help us correct them by providing us feedback. I'd like to thank you for your attention.
Thank you for your excellent speech, and I would have missed this lecture had I not been very insistent and consistent to Dr. Surjit Singh that you will have to bring your wife, because I wanted to see that the success of Dr. Surjit Singh not only depends on Dr. Surjit Singh, but because of this lady also. And behind every successful man, there is a woman, and behind every unsuccessful woman, there is a man. And I think this man is Dr. Surjit Singh, who didn't allow me to bring Dr. Aluwalia. And thank you for an excellent, excellent lecture.
Continuing with our felicitation program, can we once again have Dr. Shubhendu Rai on stage to honor him with the memento? Dr. Rai, if you can please be on stage.
Hello.
We now felicitate Dr. Debashish Mukherjee, our very own. Sir is serving as the Vice President of the Institute of Child Health Trust. He has been a cornerstone of our institution for over 4 decades now. His visionary leadership and dedication have proven instrumental in bringing a strong foundation for ICH to thrive and expand in its healthcare mission. Today, his enduring legacy continues to inspire excellence and empower pediatric care across the region. Dr. Debashish Mukherjee. So it's an honor to have you on stage.
Dr. Debashish Mukherjee was my junior resident, and then subsequently he became Dr. Debashish Mukherjee joined me when I was the chief resident of Institute of Child Health, and subsequently he became the faculty, and his special interest in pediatric radiology, and he was trained by Dr. Shishir Kumar Bose, and is one of the best colleague that I have ever in my life. Thank you, Debashish, for your continuing contribution.
Thank you, everybody. Thank you, Institute of Childhood. Thank you, Apurvada. The inspiration and whatever I have achieved in life has been due to my training at the Institute of Child Health and the fact that I had a Dr. Apurva Ghosh just above. Whatever I have done, whatever I have achieved, everything I owe to one man. And that is Apurvada, Apurvada, and Apurvada.
Next, I would like to welcome Dr. Mahesh Mohite on stage to moderate the session, panel discussion on office emergencies. Our esteemed panelists will be Dr. Ognishekar Shaha, Mihir Sarkar, Prabhash Prasun Giri, and Dr. Kaushik Maulik.
So we welcome Dr. Mahesh Mohite, who has come from Mumbai. And incidentally, he is the Joint Secretary of Indian Academy of Pediatrics, an astute academician. And it's a pleasure to have him again with us. So welcome, Dr. Mohite.
Thank you very much. So thank you very much, ICH Kolkata, for having me here. Not only for having me here, but a kind of academic feast I'm enjoying since morning. Absolutely, in recent time, you didn't get that high quality talks back to back. I could not leave the hall. It was so high quality kind of academics. Coming to our session today, we are not going to discuss very hi-fi stuff. Maybe revision of our knowledge and maybe few new things which has come to emergency medicine, few new protocols which will going into that. A slightly extensive one, but we have got a very good faculty lineup here and they will be very precise in each of the answering so that we can finish up the presentation equally well. So we have Dr. Prabhas, then Dr. Kaushik, then my friend Dr. Mihir, and of course Agnida. So let's begin with the presentation. This is about the emergencies in office practice, and actually every child in pediatric OPD is a potential emergency because of, except maybe vaccination child, but that also can become an emergency if occasional one catches up anaphylaxis. That's because of low reserves they have, high physiological and pathological demands they have. The early recognition and stabilization efforts can have a huge impact on the final outcome of these patients. There are few emergencies which can be managed in the OPD, but many need to be stabilized in the OPD and later to be transferred to emergency room or to PICU for further management. And for all pediatric emergencies, safe transport plays a key role in the survival. So if you are working only in office practice, you must have that other system on standby, where in case of emergencies, the child can be stabilized and can be taken to the nearby hospital or emergency room. So we are going to focus only on the initial stabilization part of all the emergencies that we discussed. And let's move on. So starting with Prabhas, my friend. What is the universal approach? You get any emergency in the OPD, we are talking about office practice mainly. So what's your universal approach to any emergency, Prabhas?
So actually, if any emergency or in the OPD, whenever you're getting a patient, pediatric patient, the first thing is that pediatric assessment triangle that usually we do. That is a doorway assessment of the first assessment or first impression when the child arrives. So in this pediatric assessment triangle, we are yet to touch the patient, we are yet to examine the patient fully, but we need to see the appearance, workup, breathing, and the circulations of the patients just by the initial impressions. That's very much important. In few of the patients, just after these initial impressions, we can determine that what evaluation you need to do. We can have a time for airway, breathing, circulation, disability, or you need to just shift the patient to emergency, or you can treat it in OPD basis, or just transfer the patient to PICU. So first thing, this pediatric assessment triangle is very much important.
Perfect. So after that initial decision whether this child is very sick and requires resuscitation straight away, and if that is not there, is conscious, is breathing okay, then what's the next stage, Dr. Mihir?
Yeah, so this is the very precise and targeted approach. So if there are any arms of this PAT triangle, if it is there isn't a problem, then the patient is going to the triaging in the red area of the triaging. That means the patient needs immediate intervention at that moment. Maybe the patient, maybe the cardiac arrest or maybe some respiratory failure. So the patient will go directly to the red area of the triage and will do the resuscitation bay. And then we will go to this pentagon, that is the airway, breathing, circulation disability and the exposure assessment, but it have to be complete. And if you practice it quickly, within a minute you can complete this, then you will not miss anything. Most of the times we see the resident just look at the ABC, they miss the D and E component most of the time, but make it a habit, then you will get a lot of information that you can help in the emergency stabilization of the patient.
So basically this immediate impression, primary assessment, secondary impression has some kind of a basis behind it. The immediate impression is to find out whether this child has immediate threat to life. If that is so, then without thinking what is the cause, what is next, first you stabilize the child and avoid that death-like situation. He's not breathing, intubate him. He's pulseless, give fluid, give oxygen. Once you ensure that there is no immediate threat to life, the primary assessment tells you which system is under maximum threat, whether it is neurology, whether it's cardiology, whether it's respiratory, because that's the next thing which will bring him to the death. The final common pathway goes through one of these three failures. So recognize which one is immediately under threat, you stabilize and then move forward. So what's after that, Dr. Agnida?
I think the first bit is just do what is absolutely vital to keep the baby alive. And once you have done that, and then you have got, you need to take some very short and directed history, not a detailed history, but a very short history of what has been happening. And then try to figure out how can you go ahead further. And there are those sample acronym that really helps. I'm not going through them. But just go through a very short history so that you know how to proceed further.
When we discuss about an emergency, we don't go through like a ward-like history with symptom sign. We see whether it's immediately threat to life. If so, which system is under first kind of a scanner, stabilize that, and then you go for the cause under it. We many times are not concerned about the cause. We want to stabilize and save the life. Kaustubh, how to set up an emergency compatible office or clinic practice? Many of them are office practitioners, so do they have to take any specific precaution?
Okay, so I'm Dr. Kaushik. So it is very important to have some basic setup and equipment in the clinic or office, because as sir told appropriately that any condition can potentially turn to an emergency. So in subsequent slides, as you'll see, that common emergencies will be discussed. So we need to have a basic set of drugs which we will come into later, including our adrenaline, dextrose, etc., which might need to be given even in the office. So we need to have basic resuscitation equipment like a self-inflating resuscitator, ambu bag needs to be there, and a small source of oxygen can be there obviously, and to manage seizure cases obviously who suddenly have seizures during the OPD visit, we need to keep midazolam nasal spray, and of course we need to have a small area for the resuscitation bed where in case if anyone becomes acutely sick, that can be addressed there. Along with that, we need to have a prompt connection with an ambulance service, transport, and a few personnel who can transport the patient properly, and also the referral system, like to which hospitals we can refer the patients in case the patient is so much critically sick that they cannot be managed only in the OPD. So this picture more or less sums it up. As we can see that ambulance is there.
So basically in the era of today's AI, when I ask this question to ChatGPT, how to set up and give a poster, this is what is given to him. In our UG, PG days, we used to remember mnemonics and we used to remember the photograph. Actually, this is far more difficult than remembering that. Prabhas, you want to say something?
Yeah, one very important thing is that sometimes we keep some emergency drugs like adrenaline, but many of the times we have seen that we have brought the adrenaline 2 years back and already expired. So if you want to keep two things, you have to keep a fresh adrenaline that is not expired actually. And if you want to keep ambu bag, please keep at least pediatric and neonatal bag. different masks.
So those
If you want to
basic
keep these two
minimal things are legally also mandatory.
To summarize this, the 4 A's that we say, the 4 is staff, that is the manpower who will do what if there's emergency situation happens. Then staff, STUFF, that is what are the equipments and drugs that will be required, that will be there. And then space, then if there is emergency, then where in your OPD you will do the resuscitation, that the thing, the space, and then system. That Prabha has said that the drug, checking the drugs expiry, checking the equipment, and who will do what role, and when they will call the help for transport for ambulance or other hospitals. So phone number, so that the system should be there, we have to keep ready. So 4 A's you have to remember in the setting.
Perfect. That's basic. That's sort of last question. Can you do all those things which you see in that poster, or what basic minimum essential things? Like tomorrow you see a development expert having his clinic and somebody collapses there, and if you don't have those basic things, perhaps he also may be coming under legal scanner. So there are few things which are absolutely mandatory irrespective of what kind of a pediatric practice you do. And that's what Dr. Amir Sarkar just now told you. What specific training programs are available? Dr. Kaushik, in India, for someone who is starting new, or maybe someone is in the 20 years of his practice and he want to get it updated. So are there any programs available in India for a pediatric emergency?
Sir, for the office emergencies per se, in case of any emergency, so we need to be acquainted obviously with the BLS and the PALS. That is extremely important, so that can be provided in case of any emergency. Then there can be certificate courses which are organized, like the courses by the Indian Academy of Pediatrics. We also have different workshops on the office emergencies in pediatrics. They are short courses. And also we can train by simulation, which also leads to a much better retention and also hands-on practice. So with these things, all the general pediatricians can be well equipped to as to how to deal with emergencies in office practice.
So we basically have to not only to get ourselves updated, but we need to keep our staff also trained for that multitasking.
According to this, I think also NRP is important.
Yeah, and some institutes are now pediatric emergency is coming up as a specialty also. I think there are long courses for just on pediatric emergencies.
Yes.
Some centers are doing it, like PGI, and some that is also available for career pediatric emergency.
Even IIP is having those courses. We are presently having that course of 6 months course, which is online, followed by a contact session. And that's, you have that certificate, that's good enough to say that you have gone through that course. Let's move further. Mir, what are the medico-legal implications of those emergencies which come in the OPD practice?
Yeah, so the medico-legal implications are many, but because you cannot deny, first of all, that any patient who is coming in the emergency requiring some sort of resuscitation, you cannot deny. So you have to have a set to just give the primary management, and then you have to have a setup to get to call for help and transfer the patient safely to a healthcare facility, and that communication and that chain have to be maintained and throughout the process. You cannot just give cannot accompany the patient required that you have to do. So these are the things that you have to be keep in mind, and also should not fear that if there is some mishap happens in the emergency, then they can be sued or they can be just blamed that has been done. But yes, if you can make a system and make a note what was the patient condition, and you record it and do the primary resuscitation and send, then you will be medically safe, medico-legally safe.
So bottom line, Supreme Court has made it mandatory that you have to attend and stabilize that case irrespective of your speciality. Any emergency comes to you, you have to make the stabilizing effort and take that patient to a safe place and then hand over. If you fail to do that, you are liable to be litigation. So be careful, you should be handling every possible emergency. Let's move to few common cases along this. So Prabhas, you are an office practitioner. There is a 9-month baby boy, 8 kg, brought to your OPD for immunization, given MMR vaccine, a classical scenario. Few of you might have gone through anaphylaxis experience. This is one of them. So 15 minutes later, the crying mother rushes the child from way back home for a child having breathing difficulty, cold limbs and bluish hue to the face. Child has urticarial rash on the trunk, gasping breath, pulses are not palpable, and this has happened within 15 to 20 minutes of the vaccination. What will you do?
So there is a clear-cut case of vaccine-induced anaphylaxis. So it's very easy to manage it theoretically, but in practical purpose, it's almost a nightmare for a pediatrician. So it's just given a vaccine and child developed anaphylaxis. The first thing is that you have to identify the anaphylaxis. You know that any catastrophe happens after vaccination should be taken as anaphylaxis until proved otherwise. Rash, respiratory distress, stridor is not universal. If the patient collapses following the vaccinations, you have to think that this is anaphylaxis. Next that you have to take care of the airway, breathing, circulation, and disability. If you have oxygen, give 100% oxygen RBM, and the drug of choice is the adrenaline. Remember that you have to give that undiluted adrenaline, that is 1:1000. The dose is 0.01 ml per kg. You have to give that deep intramuscular dose. You have to give deep intramuscular. The subcutaneous dose is not approved in these cases. This is the main thing that you have to do. First, give the oxygen, call for help, and give the adrenaline by deep IM injection.
Perfect. So this is one emergency. Thankfully, we practice less and discuss more, but still we have to be updated with everything coming along that. And this child subsequently required intubation because 3 doses of adrenaline didn't work. Intraosseous was managed because initially IV was not there. Intraosseous was managed, pushed 1 ball. Ultimately, he responded and stabilized. Then was transferred to PICU for further resuscitation. Few questions related
Mohite,
to this.
just one clearance. If you are treating anaphylaxis, you don't need to dilute the adrenaline, right? It's undiluted, 0.1 ml for each 10 kilo. It's not diluted. You don't need to dilute. Yeah, sorry.
Not less than 0.1 ml, whatever may be the body weight. So the minimum dose.
Minimum dose.
Yeah, but one more important point is, as we discussed in the resuscitation part, we do airway, breathing, circulation, and then drug. This is one emergency where D presides over airway breathing. So first you give the intramuscular adrenaline, and then you can do the rest of the stabilization, because time is money. You delay that adrenaline by 5 to 10 minutes, we may release the patient, irrespective of what you do after that. So, Maulik bhai, how do you diagnose anaphylaxis in a clinical setting? Just couple of questions related to anaphylaxis, which we want to get it clarified.
So the hallmark signs of anaphylaxis, like they can be like stridor, they may have respiratory distress, they may have clinical signs of hypoxia, although cyanosis is a late sign. Pulses will be feeble, there will be signs of hypoperfusion, shock, skin rash may or may not be there, there may be arterial rashes. But it's very important to remember that a patient decompensating acutely or after some time of a vaccination, so the suspicion for anaphylaxis must be very, very high. It's not like that all features need to be present and then only I'll stamp it as an anaphylaxis. Because if we miss the critical window of intervention, then the outcome can even be fatal. Ideal site for adrenaline injection, so we have to give a deep intramuscular injection. So it should be based upon the patient's age and muscle mass. So we should have an adequate muscle size so that we can give a proper deep intramuscular injection. Anaphylaxis can happen in maybe in the thigh. Anaphylaxis
so
can
if you
happen in
have an IV in line, suppose in the admitted patient develops anaphylaxis and they already have an IV, will you still prefer IM or will you give IV?
So that's what. So in anaphylaxis, the typical anaphylaxis cases happen in the OP setting. So it is told to give deep IM. In admitted patient with monitoring facility, it can be given IV, but adrenaline given IV has critical monitoring issues. You have to stand at the bedside and closely observe. So that is why ideally IV is not preferred, but yes, admitted patient IV in situ, so it can be given. But the ideal
first line will be always IM as far as possible, because chances of arrhythmia are very high with IV adrenaline.
Yes.
So always the preference is intramuscular, and 2 or 3 doses not working, then one may use IV. If the IV is not there, then intraosseous. So always IM is the first line. Subcute, obviously the venous system is collapsed, so one may not be using it. IV is not a preferred mode unless 3 doses of IM they fail. Any role of antihistaminic here?
No.
So no, antihistaminic is only for skin rash.
Skin rash.
It's only for skin rash.
Yeah. So if there is only lower respiratory, that is wheeze spaces sometimes happen, then roll of salbutamol may be there. No, and no steroid, no antihistaminic is helpful.
So any roll of steroid?
No.
So, but the tendency of giving steroids before adrenaline is much more. Even in the admitted patients. The patient has developed some anaphylactic reactions first, the knee-jerk reaction to give steroids, but it's not likely.
I mean, if you are needing more than 2 doses of adrenaline, then steroid may have some role in further treatment, but immediate treatment, no, steroid does not help.
So steroid, there is some kind of a delayed recurrence of anaphylaxis after 4 to 6 hours. So for that mast cell stabilization, steroid is useful. It's not that it's not there, it's there in the literature, but the role is not for, as Agni ji said, that it's not for immediate, but few patients they recur with after 4 to 6 hours. So for that to prevent, steroid has some role. Any diagnostic test you need to do in anaphylaxis?
No, as such, there is no diagnostic test.
If I am in doubtful, if I am doubt.
But if I'm in doubt, we can do a serum trip test. But another thing is that sometimes if you see that you want to do some skin hypersensitivity test to few patients, those are already allergic. So prophylactically you can get a serum trip test. If the serum trip test on the hair side, then for this skin prick test or some other antigen introductions test, you have to be very cautious that the serum trip test on the hair normal side, this patient can develop an anaphylaxis after giving the skin prick test. So you have to be very cautious.
So tryptase levels can be done in first 2 to 4 hours, rest everything is not. In fact, just now Dr. Sandeepandar showed about the mastocytosis case. That's one of the differential diagnosis of anaphylaxis, where the mastocytosis will have the tryptase level lasting even for days. But this is the one where the tryptase level will drop within 2 to 3 hours. Not very common, we rarely do it. First of all, we don't see very often. But if someone is having those kind of recurrent attacks, then that's the way one can prove or disprove it, doing a tryptase levels.
Just wanted
How do you
to make
prevent?
a point.
Is there any advances? Yes.
Regarding the syringe to use while giving this adrenaline in anaphylaxis, because
yeah, that's what I'm coming to. That last question. Any advances?
Yes, sir. So the thing is that when we are giving in the OP setting, it's very important to keep the 1 cc syringe because the volume may be very low, like 1:1000 adrenaline, 5 kilochild, 0.05 ml. So it is impossible to take that in a larger size syringe. So otherwise EpiPen is there, of course. So if that is available, then injection can be administered with that, especially when anaphylaxis is happening due to some agent outside the OP setup or something.
But unfortunately, it's not available freely here.
But US FDA recently approved intranasal adrenaline for using in anaphylaxis. Intranasal spray they have approved in after certain kg, I think after 20 kg of age, they have approved intranasal.
Yeah, 1 mg and 2 mg intranasal FDA approved, not yet available. Less than 30 kilo 1 mg, more than 30 kilo 2 mg. But it's not yet available. And EpiPen, it's very sad that EpiPen is not available in our country. You can get it, you can import it, but then it's hugely expensive.
Right. So the few things are there in the Western world now. Sublingual is coming, intranasal is coming, DPI powder. Those are rare ones. Biologicals, yes, can be used if it's a recurrent severe one, but not, we don't see that very often as we said. Let's move to the next case. Dr. Agni, please. The 10 months baby boy had low fever, mild cold cough for 1 day, brought at 11 p.m. with abnormal inspiratory sounds with breathing difficulty, and how do you manage this?
Obvious stridor, this coming early in the morning, this age, croup is my diagnosis unless my kid is very toxic, which this kid is not. So it's croup, he needs some steroid, preferably dexamethasone.
So he has few red flags in here. So what's category, and you want to give Dexa and Adri to every of the group that comes to you?
No, not necessarily. You need to figure out how bad the situation is. It's like, you know, stridor at rest or only at crying. So that's 1 degree of severity. And then is the child systemically unwell, like breathing, really struggling to breathe, getting saturations dripping? That way you sort of, I don't really bother doing a score. I cannot remember all the score points, but you have to have some degree of severity assessment. Then depending on what you find,
grossly we can say mild, moderate, severe, where moderate to severe is something which is at rest and
Just
that on becoming severe distress.
Just one thing to tell that if your patient's having a stridor and the most probable diagnosis is acute laryngotracheal bronchitis or croup, and if this patient is not in impending respiratory failure that need intubation, then the first thing is that you should not make the child upset. If you make the child upset by doing a lateral X-ray or doing an ABG, putting a IV line, everything, that will make the child more upset and the partial obstruction may be full obstructions. So in this child, if you just assess if the child can swallow, if the child swallows, it's better to give the oral dexamethasone other than putting an IV line and giving the IV dexamethasones.
So steroid become for almost all cases, adrenaline SOS if there is significant distress, adrenaline by nebulization. Steroid is systemic, not oral. It's not inhalation steroid, it's a systemic steroid and adrenaline by nebulization.
Remember the dose is higher here, 0.6 mg per kg, and do not separate the child from the mother, as the child gets irritated, it will more severely
Yes,
will increase.
yes, yes. So do you hospitalize every of your group patients?
If it is moderate group and it's settling with the dexamethasone and one nebulization perhaps, and you will observe the 4 hours, if there is the steroid is settled, child is active, then you can discharge home. But even after giving the nebulization and adrenaline even 4 hours, if you require repeated nebulization, and then you have to admit and give the child observation. Yeah.
Okay, fine. So generally it's moderate to severe, somebody at rest, somebody with severe distress, you will definitely hospitalize. Mild early group, you may give oral steroids and can call them, most of them 1 or 2 doses, they are okay. By next morning, most of them are okay for discharge. Role of oxygen, NRBM, high flow cannula, any role? Steroid adrenaline we said. Mir?
No, this I think again, though the oxygen, if it is hypoxic, you have identified, then only give, and if it also give the non-threatening way. So take the help of the mother and give the free flow oxygen. Don't try to give with the nasal cannula or the mask forcefully on the child. So that is important. Again, the upper airway obstruction, we try to avoid non-invasive ventilations, like then that will be more severe obstruction. So that you want to avoid. And steroid, adrenaline, we have all done. The moderate to severe you will require. How many doses and how many days? Dexamethasone single dose. If it require, repeat after 24 hours, not before that. Adrenaline you can repeat after the 30 minutes after observation if it is required.
So generally you will see the response within 12 to 24 hours. Some patient continues to do it beyond 24 or 48 hours. What do you do?
Yeah, beyond 24 hours, if it is requiring, then after 24 hours, you can repeat the second dose of the steroid and then adrenaline nebulization, and then antibiotic. Usually it is the viral infections, antibiotic don't have any role. But if it is the very severe going downhill course, very life-threatening group, so that is the very problematic, because the putting the patient airway patent, it will be a problem here because the airway is narrowed, so that patient needs a hospital care, and if it is life-threatening group, then the intubation and the advanced airway may be required. So keep the ENT person ready. Sometimes the surgical airway may be required if severe life-threatening group.
It's very rare. But not to forget, you just look for any kind of...
If a group is not getting better by 24 hours, you are possibly not really dealing with the laryngotracheal bronchitis, you are dealing with something else. So you need to have a look. Possibly I will be more inclined to have a look down.
So you may have some kind of markers like this where it could be suggested, it could be internal hemangioma. If you see anything in the neck space, beard area hemangioma, that could be a surrogate of internal hemangioma, and then definitely you need to do a scopy to find out if there is any additional lesion. In fact, one of the cases which we dealt with was this one, wherein this child's croup did not subside in 36 to 48 hours. And this was about 15 months old girl was brought, and then when we did a scopy after that, there was a clear furniture work was going at home, and you could see that foreign body sitting in the things, and which was being treated as croup for almost 48 hours. So there was a foreign body in the larynx, which could be easily pulled up by a forceps, and the child did well after that. Yeah, I can see that. Let's move to the next case. This is another case of 6 years old who is a known case of asthma on a controller therapy. Mother calls from home, child has exposure to fire smoke and becomes acutely sick, breathing fast and having difficulty in speaking, has wheezing sounds. Maulik, what advice you want to give? She is calling you, I am coming to the clinic, she is going to take about 1 hour to travel, child is breathless. Want to do something on the way?
So, since child has become acutely sick and breathing fast, so on the way if they have metered dose inhaler with them and the child is able to inhale, despite the tachypnea, then levosalbutamol or salbutamol puffs can be given around 4 in number stat. And after that, I mean, the kid needs to be rushed to ER as fast as possible, and the puffs need to be repeated every 10 to 15 minutes. And of course, oral steroid, if it is available with them or not available, they can purchase and give a stat dose, maybe around 1 mg per kilo. And then after coming to the ER, then further assessment and stabilization needs to be done.
Perfect. So he's already received about 12 puffs of salbutamol. He's received, that's what is the first line of management as per the guidelines today. 1 milligram per kilogram oral prednisolone. Mind you, it's oral, it's not inhalation. There are some controversy whether nebulized can be given. The early nebulized one can prevent further admission rate, but it's controversial. We still go with a systemic corticosteroid, which is 1 milligram per kilogram, give orally, and then we give MDI puffs, which is 100 milligram beta-2 agonist salbutamol, to be given about 2 or 3 puffs about 12 to 18 puffs in first 1 hour. So if that much of time child is going to take, then you give it on the way. Now this child comes to the hospital, he's already looking hypoxic, saturation low, severely wheezy, subcostal intercostal retractions are there, he's conscious but find difficulty in making full sentence, there is bilateral poor air entry, severe distress. What are the red flags, Prabhas? Quick, we have got maybe another 10 minutes.
Definitely when you are getting a patient of status asthmaticus, you need to differentiate between status asthmaticus and life-threatening asthma. So there are a few red flag signs are there that the child is not able to talk a single sentence, and he's so much irritable or lethargic, silent chest, he has some hemodynamic instability, the saturation is low. So these all are the red flag signs. This needs urgent attention and admission to the child to the pediatric intensive care units.
Perfect. So red flags are basically symptoms of system failure. His hypoxia is taking on his brain and is becoming lethargic. You get a saturation. In asthma, mind you, it's an airway problem. There is no reason for him to become hypoxic. The time he becomes hypoxic, he has already gone into sort of early respiratory failure. His CO2 is already built up. So this is something which we should be worried about. He's already having retractions, he's drowsy. So those are all red flags. And here you give the primary treatment and take him to the ER. Any more information, forget, we'll move ahead. How do you treat with this kind of a child?
Just one thing to add, that the patient has saturation is low. Even if the patient comes to the ER, if he wants to give nebulizations, that must be oxygen driven. That should not be given to the nebulization machine. There may be severe ventilation perfusion mismatch if you continue to give nebulization to the nebulization machine when the patient is desaturating in 90s.
Perfect. So commonly is asked whether there is any role of nebulizer. This is the one where there is a role of. He requires oxygen, that drug to be pushed through oxygen, which cannot be done through MDI. So this is a case where definitely nebulized beta-2 agonists need to be pushed. What are the further protocol, Prabhas? Once you comes this to the ER, suppose you have the facility of ER, then just 1 or 2 further protocols where after that it can be pushed to the
this is standardized protocol that you have to give nebulized inhalations of the beta-2, and definitely you have to give some ipratropium, usually first 2 doses, then 6 to 8 hourly. Then the steroids, if the patient is able to swallow orally, then oral steroid is not able to swallow, then parenteral steroid. Then definitely comes the magnesium sulfate, is very safe. You can give a magnesium sulfate. If the patient is not responding to that, then are some other escalation therapies. Patient may need a respiratory support ventilation. That's beyond the scope of our discussion over here.
Just one thing about steroid, I would like to say, somehow hydrocortisone has become the drug of choice for asthma, which is not right, and which is not, for steroid for asthma, hydrocortisone is possibly not a very good choice. Dexamethasone, methylprednisolone, hydrocortisone is not really a very good choice.
So for the emergency care, summary of asthma is when he comes with that acute distress, if you have MDI, child is not hypoxic, 2 puffs of 100 microgram salbutamol every 10 minutes in 1 hour with 1 milligram per kilogram oral prednisolone. If there is no response in 1 hour, he becomes hypoxic. You may use a continuous nebulization with oxygen. Mind you, when you use nebulization, it should be with oxygen and saline nebulized beta-2 agonist for 1 hour. If it further doesn't work, this is a time perhaps we should shift him to the ER where he may require further management. So anything else? Can you use magnesium sulfate in your emergency room or in your OPD? Mihir?
Yes, emergency room definitely, not in OPD.
Any precaution you have to take when you are giving magnesium sulfate?
Yes, we have to monitor the heart rate, you have to monitor the neurological status and the rhythm. So these are the things you monitor.
So one thing quite likely may happen is hypotension. Because they are already, this is a child who is sick, not taken any food for last 2-4 hours. He is hyperventilating, he may be hypovolemic, and this child you give magnesium sulfate, he may vasodilate and can have hypotension. So one should be careful. If you are doubtful, push a small bolus of 10 ml per kg of fluid and then give it further. I think this is part which you will be taking care in OPD or emergency care. Beyond this, it should go to the ICU. Dr. Maulik is a 10-year-old, 10 kg boy, brought with abnormal involuntary movements for 15 minutes, mild cough cold since last 3 days, no fever. On examination, his seizures, generalized seizures are going on. Distal pulses are palpable, child is unresponsive, febrile. Is this status epilepticus?
So the kid has been brought to my office with seizures ongoing. So practically this is status epilepticus.
Perfect. Why you want to know that whether it is status or not? You start treating, na? Does it really matter? There are different categorization. Can you just tell us what are the severity categorizations?
Yes, so it is important to know because status epilepticus means that the ongoing epileptiform activity is going on for quite some time and already significant cerebral injury is ongoing, and we expect a guarded neurological outcome provided that we do not intervene very fast in this situation. And if it is status epilepticus, so after the initial management of the seizure in my office, so I need to shift the patient to a hospital for stabilization and further evaluation and workup. So I shouldn't be managing a status epilepticus in the office.
So basically any child coming seizuring to the office is status epilepticus because it is, or seizure more than 5 minutes is status epilepticus because it has been proven anything lasting more than 5, there are some irreversible changes are already started in the brain. Longer it lasts, more damaging it is. At the same time, so time is money. Earlier you control, more likely it will be controlled. Longer it takes to start the treatment, more likely it may become refractory. So status is anything more than 5 minutes. Refractory status is anything more than 1 hour with primary 2 drug lines are already received, and super refractory is something which is going beyond 24 hours where already anesthetic medications are done, and in that case the chances of morbidity, long-term outcomes are going to be very poor. How do you manage this child who comes seizuring to you, to the OPD?
Yeah, so if the patient have seizure actively in there, so the first thing is that again the airway breathing circulation before giving any anticonvulsant drug, because keep the patient in the lateral position or recovery position, that is very important. If there are some secretion outside, then you have to be clear, but you don't try to open the mouth forcefully. Keep the patient, if some oxygen is available, provide the oxygen, and if you are looking the patient have very circulatory status, very poor shock, then if you have facility available, start giving some fluid to the patient in the bolus form. Then you give the midazolam or the whatever you available. I think most of the things you will have the intranasal midazolam or buccal midazolam that you can give, but before that, please remember the ABCD and check the blood glucose. So these are the minimum things you can do in your OPD, and then after safely transport the patient.
Perfect. So nasal midazolam, don't forget, that's something which is blessing in disguise. You can repeat it if the seizure doesn't stop in 5 minutes. If it goes beyond that, then you can take a IV line and can give lorazepam. So first line will be that. In an emergency room, in an office practice, perhaps nothing more than this should be done. If you have time and it's going to take long time to travel, then yes, maybe second line drugs, levetiracetam that we use and which is very safe, can be given IV, but mind the doses. And as Dr. Meher has already said, airway, breathing, circulation is most important to manage. It's not just drug, all the background things. I don't think we have much time. So what we'll do is now, we'll go extempore rather than this, because all those things are difficult to finish. Just tell us, if the child comes in shock, he falls down, he comes in hypovolemic shock, what do you look for? So get a case who is fallen down from tree, brought to you, gasping. So Prabhas, quickly in 1 minute, what's your emergency?
So first thing that I will call for help, and definitely if the patient is basically in shock and gasping, I try to secure IV cannula, give fluids, then want to secure the airway definitely.
Yeah, so most important again, airway, breathing, circulation. He comes gasping, secure the airway. Commonest cause of death is hypoxia. So ensure that he gets the breathing properly.
Yeah. So one thing just want to remember that in a trauma patient, now it is before A is the X. That means the control of bleeding. So if there is active bleeding or there is some hematoma increasing, so that you have to take care first. Okay, so
Another
that is
thing is that most of the cardiac arrest in pediatric is the hypoxic cardiac arrest.
Absolutely. So still I think the resuscitation part, let's give a clear message that ensure that the airway is taken care of, breathing is there, and then you can push water fluid, and of course in a trauma case, bleeding. So blood for blood rather than just giving boluses. There are some limitations of that management in the OPD. The child is brought, common scenario, child is brought from a neighboring house where the child drowned in the bucket, brought to you gasping. Maulik bhai.
So again, gasping child, so I have to secure my airway. So now the thing is that I am in my office, so I don't have an endotracheal tube with me possibly, maybe, so, but my ambu bag and mask is there. So with that I have to start the ventilation. Obviously parallelly my supporting staff has to try to secure the intravenous line. So the kid might have been hypoxic for a significant period of time, so disability needs to be adequately taken care of. There may be raised ICT, etc. that needs to be monitored, fluids need to be given, and the referral has to be triggered urgently after initial stabilization, that is securing the airway, ventilation, and then circulation, giving the fluid boluses and all these things. Then after that I need to shift the child urgently to an ICU setup where further management
So
can
one
be
thing
done.
just I want to highlight, don't miss the gasping child, check the pulse. If the no pulse, immediately start the cardiac,
Absolutely.
there's a CPR. Because
Absolutely.
the survival in a child with drowning depends upon the how we have managed the pre-hospital cardiac resuscitation in a patient. So that is very important.
So bottom line of all the emergencies is airway, breathing, circulation, stabilization, and then specific management, except in case of anaphylaxis where drug comes first, adrenaline, adrenaline, adrenaline. There are 5 drugs for anaphylaxis. Adrenaline, 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 and adrenaline. And then starts whatever you want to give. There is no other drug which is specific to that. So airway, breathing, circulation, specific management. In case of if you have a poisoning coming, then if you know the antidote, then give it upfront. Otherwise, if you don't know the cause, airway, breathing, circulation, stabilization, and that's all. I think we have time up. We don't have much time. One message from 4 of you about managing any emergency coming to the ER or to the office. Agni.
There is a saying that says the best time to prepare for war is during the peace time. So prepare for your emergencies when you are not facing any emergencies, and primarily have a very clear-cut, triage. Whom to call? Where will you send this patient? That should be decided beforehand. You should not decide it when you are facing an emergency. And another big step is whether you should keep some cannula and IV fluids in your, I don't know the right answer, in your chamber or not. That is a big step. I mean, whether you can do it or not, I don't know. But at least be prepared when you are not facing an emergency.
I think second is that train your staff to identify a sick child quickly. So there is in a row in a 20th number, but that should child come fast to visit you. So that training should be there with your staff.
So dedicated staff also, and to counsel the family appropriately, because they need to know what is going on and that the best efforts are being done for initial stabilization.
And I think check your equipments daily and make a note whether the equipments are working or not.
Maybe one last thing is, any emergency, give whatever little effort you can. Don't push him off. Many times he comes gasping and we feel this can't be a medical legal, let him go, I don't want headache. Your little effort can save this child. Give a simple episode. Those who are practicing in the periphery, they get a snake bite. A 10 or 12-year-old child, he comes with some early drooping of the child, and Kolkata is about 2 hours travel for him. And you write a referral that go to Kolkata and I'm calling ICH for this. By the time he reaches there, he's dead. He is a salvageable, intact salvageable child. If you intubate, give 1 dose of ASV and transfer, he can be intact salvageable. So those, any emergency, try to give whatever optimum stabilization, make a accompanying person, arrange for a good transport. This child will come back and touch your feet because he will be saved because of you, not because of the referral unit. It's because you who had taken a proper steps. With that, I think we finish the session. Thank you very much, faculty. Thank you. We had a wonderful discussion. Thank you very much.
Thank you, Mahesh. As usual, you are at your best. May I request the moderator and the panelists to go to the felicitation center, and may I request Dr. Shukanta Chatterjee to felicitate, and Dr. Joydev Rai. So now I call upon Dr. Anupam Sibal, who will be delivering the K.C. Chaudhary Memorial Oration. 3 decades of pediatric hepatology, improving access and better outcomes. Dr. K.C. Chaudhary was the doyen of pediatrics and the founder of Institute of Child Health. Over to Dr. Anupam Sibal.
Good afternoon. It's a privilege to be back in this beautiful city. In fact, it's my 3rd trip to Kolkata this year. I had the privilege of delivering the Dr. Shishir Bose oration a few years ago.
I'll ask all the audience, please take your seat. This is a decade, and we have seen Anupam Sibal speaking before, and you will have something which you have never heard before. Please take your seat.
Thank you. Thank you. So it's indeed a privilege to be back here. I was told I have 25 minutes, so now you're stressing me with 20. So change that to 25, right?
25, you can take 25 minutes.
Thank you. Thank you very much. So I'm going to be talking about 3 decades in pediatric hepatology, improving access and better outcomes. Professor K.C. Chaudhary, everybody recognizes for his amazing work. He founded the Indian Pediatric Society, the Indian Journal of Pediatrics, which is internationally recognized, and of course the Institute of Child Health, which is an institution that everyone in pediatrics looks up to. You know, 30 years is a long time, and I was just trying to remember, if we talked about Calcutta in 1996, one would have thought of the Howrah Bridge. Of course, the city was called Calcutta. But if we think about Kolkata, we will think of this Bishwa Bangla Convention Center and the gate. The world was very different in 1996. India was very different. Our currency and coins used to look like that. They've evolved. For those who are very young, it'd be hard for you to imagine that that's what computers look like. And look at what we have now. And phones in 1996, not only did it take 16 rupees, it cost 16 rupees to make a call per minute, but also 8 rupees to receive a call. And these were very heavy instruments, and look at all the fancy gadgets we have today. And we had 1 million cell phones only in 96, 1.4 million internet users, 50 television channels, and of course we didn't know what OTT was. Today we have 1.5 billion cell phones, 900 million internet users, 900 plus television channels, and of course we can't live without Netflix, Prime, and so on. But what has changed in hepatology? If we just look at one group, neonatal hepatitis, and I'd like your attention to be drawn to this subgroup, which is 35% at that point in time. And that 35% is actually zero. This was this idiopathic group that we did not understand. We didn't know what it was. And we now know that we have a large number of genetic conditions, metabolic conditions, and that 35 is now 15 and 25, and the idiopathic group has virtually disappeared. So what I'm going to do through about 10 clinical examples is walk you through our improvement in understanding diagnoses, new conditions being diagnosed, and very importantly, treatment. So case 1, 7-month-old boy. 170 years ago, the ancestor of this little boy moved from Gonda district in Uttar Pradesh to Trinidad and Tobago. This child was a very precious child. There had been several pregnancy losses. There was a sibling death, and this child developed jaundice at 2 weeks of life. The jaundice was progressive. The child, when he came to us from West Indies, had a lot of ascites. There was severe malnutrition, and we found that he had high gamma-GT cholestasis and coagulopathy. His ultrasound showed a normal gallbladder. Obviously, we were not dealing with biliary atresia. There were signs of early cirrhosis, and a biopsy showed chronic obstructive cholangiopathy. We did our genetic testing, and we found that this child had TGP2 mutation, which is type 4 of PFIC. There was very rapid deterioration. The father wanted to donate, but we found him to be unfit. The mother donated. This is this child before transplant. You can see deeply jaundiced, lots of fasciitis, severely malnourished. This is him 2 weeks after a transplant. This is when they were ready to go home. And this child is, to the best of our knowledge, the youngest child in the world with TPG2 mutation to have undergone a liver transplant. Case 2, a 13-month-old boy, 3 kilos, consanguineous marriage, developed itching at about 3 months of life, started on the face, went all over. The child was miserable, couldn't sleep at night, and then jaundice developed a couple of months later. He hadn't been gaining weight, his stool was pigmented, and if you see this child, he's got this constant itching, and there were excoriation marks over the face and the limbs. He just had hepatomegaly of 2 centimeters. He wasn't thriving. He had low gamma GT cholestasis. And because the gamma GT was low and cholestasis was present, obviously our mind works towards certain types of PFIC. We went ahead and did the genetic testing and found that this child had PFIC type 1. So we decided, because the liver disease was not very advanced, to do an internal biliary diversion. So we did a cholecystogenital colonic bypass, we did a liver biopsy, started this child on supportive medication. So this is what he looked like pre-diversion. This is what he looks like now, several years later. He's thriving, he has no itching, he sleeps well, he's going to school and has a normal quality of life, and we hope that he'll grow up well and his condition will not bother him too much. Case 3, 2 sisters, 6 and 4 years old, from Chad in Africa. Again, a history of consanguineous marriage. They were well till about 1 year of age when they developed progressive jaundice, pruritus, dark urine, abdominal distension. There was also a history of similar illness in a younger sibling. We found that this child had high gamma GT cholestasis. These are the 2 sisters, deeply jaundiced. We tested, and they have PFIC3. Both of them, and both of them, unfortunately, because of their advanced liver failure, are going to need a liver transplant. You know, when I was training, there was just one type of PFIC, and it used to be called Byler's disease. By the time I finished my fellowship, there became 3. And now we have as many as 13 types of PFIC, thanks to our ability for genetic testing. And over the last few years, out of the 13 types of PFIC, we have seen 11 types in our practice, 67 children, and we've done transplants in 30 of these children. So this was an idiopathic group where we wouldn't have known what to do, but now we know precisely what we need to do, and see we have a precise diagnosis, and with therapy we have excellent outcomes. Case 4, a 13-month-old boy from Andhra Pradesh, again a history of consanguinity, had failure to thrive, and at 9 months had rickets, also had abdominal distension. There was no history of any jaundice or bleeding or coagulopathy. He was malnourished, there was frontal bossing, beating of the rib cage, he had hepatomegaly, spleen was just palpable. And if you look at the investigations, I'd urge you to focus on the ALK phos. Obviously the child had rickets 2669, but look at the serum alpha fetoprotein, close to 2 lakhs. So when you have that, then you think of tyrosinemia. The x-rays showed rickets, the child had proximal tubulopathy, the ultrasound showed multiple nodules. And if you look at the CT, there are multiple nodules, and these are very high risk for developing a hepatocellular carcinoma. We did the urine test that showed urinary succinyl acetone, diagnosis of tyrosinemia type 1 confirmed. The genetic test also showed us what we were expecting. And again, in the old days, we would have had to do some complex enzyme assay to be able to make the diagnosis, and now we get this with a prick. So there is treatment available, oral medication, but it's extremely expensive, and it is for life. And because of the high risk of hepatocellular carcinoma, the family opted for a liver transplant. The father was the donor. This is what the child looked like when he presented to us. This is him post-transplant, and this is him growing and doing well. Simple diagnosis to make if you consider it, and appropriate therapy which changes the outcome. Case 5, a 3-kilo baby, jaundice at day 5 of life. The jaundice improved. The child was gaining weight, was exclusively breastfed, but then the child developed jaundice again, and there was persistent jaundice at 1 month. The urine was dark, the stools were pale, there was hepatosplenomegaly, and clearly when you have stools which are so pale, you think of biliary atresia, you think of obstruction, and that is what was thought. If you look at the cholestasis, there's direct hyperbilirubinemia, and the gamma GT is high. An ultrasound, a fasting ultrasound, showed a triangular cord sign. The important thing here is that the ultrasound needs to be done by someone with a lot of experience and patience, and the child has to be fasting for at least 3 hours, and that, as we know, is not easy in small babies. If you have the triangular cord sign, it is suggestive of biliary atresia, but then of course we need to confirm the diagnosis. And I would hasten to add here that HIDA scan has absolutely no role in diagnosis of cholestasis because it isn't really useful and it ends up wasting a lot of time. So we did what should be done, which is a liver biopsy, and there's bile ductular proliferation with all the bile plugs. So this is biliary atresia. And if you show you a higher resolution, you can see the bile ductular proliferation. Now, in contrast, if there was a paucity of the bile ducts within the liver, and if you look at the portal tract and there is no bile duct, this is intrahepatic paucity of the bile ducts, and in this particular case, it's Alagille syndrome. Very different entity. A clear diagnosis needs to be made because treatment is totally different. And this is a child with Alagille syndrome, has some features, broad forehead, but as she grew older, she has typical facies, triangular facies. She also has a peripheral pulmonic stenosis murmur. She has a lot of pruritus, and her brother has no phenotypic features. I've been monitoring this family for more than 20 years. She's a lawyer now, and you can see the difference of height between the siblings. And this child was referred to us for a liver transplant, and with supportive medication is doing very well. Now, looking at special stains, very different in biliary atresia to paucity of the bile duct. And of course, if we think of biliary atresia, we must do a paraoperative cholangiogram. And here there is no dye, which means that this is a diagnosis confirmed, and we do a Kasai's operation. Now, we know that the success of the Kasai operation depends at the age at which it's done, and if it's done at 30 days or less, there is biliary drainage in 70 to 80%, and after 4 months, it drops down to 10 or 20%. But another factor which is not often considered is the skill of the surgeon. So if a surgeon does this operation more frequently, the outcome is better. This is data from the United Kingdom, and only 3 hospitals are allowed to do this surgery. This is another factor that needs to be taken into account. And if we look overall, 50% of children with biliary atresia will require a liver transplant before the age of 2. 75% will require a liver transplant before the age of 20. So this is a very serious condition. The best thing that we can offer is to get these kids to have surgery early, done by a surgeon who's very experienced. Otherwise, they will need a transplant. Of course, if you are dealing with Alagille syndrome, a portoenterostomy should not be done, because then these children who otherwise would have done well will 100% need a liver transplant. So it's extremely important, and the point I'm trying to highlight is to have a precise diagnosis because the treatment changes. Case 6, now moving to older kids, 9-year-old boy, typical hepatitis A, got better, but then again the child developed jaundice and was referred to us. On examination, we found that the child had clubbing. Now, why should a child with hepatitis A have clubbing? Had pallor icterus, hepatomegaly, no splenomegaly. And when we investigated, we found that the enzymes were high, but because this was a recurrence, and sometimes hepatitis A can produce a relapse, but because of clubbing and the fact that we wanted to rule out chronic liver disease, we investigated further. We found that all the markers for autoimmune hepatitis were negative, but IgG was high. Wilson's disease, all the other tests that we did were negative. But because jaundice had persisted for 10 weeks, we decided to do a liver biopsy, which showed features of autoimmune hepatitis. So we're dealing with seronegative autoimmune hepatitis, where hepatitis A had unmarked this condition. We started the child on steroids, and the LFTs improved. Case 7, a 14-year-old boy with high-grade fever for 15 days with abdominal pain. He had tenderness, had hepatomegaly. His bilirubin was just about 2.2. His enzymes were borderline high. We investigated him and found that his IgG was high and his ANA was positive. But he also had some GI symptoms, so we decided, in addition to doing a liver biopsy, to also do a colonoscopy. Before that, we did an ultrasound which showed dilatation of the biliary radicals. We did an MRCP which showed a beaded appearance suggesting sclerosing cholangiopathy. We did a biopsy which was suggestive of sclerosing cholangitis. We did a colonoscopy which showed mucosal edema, and there was acute active colitis, and therefore a diagnosis of autoimmune sclerosing cholangitis with IBD was made. We started this child on steroids, starting to get better. I saw this child yesterday, and we plan to start this child on azathioprine. Case 8, an 8-year-old girl from Bihar, known case of Wilson's disease on chelation. Her condition deteriorated on chelation. She was actually being treated at AIIMS Delhi. A liver transplant was advised, but the family had economic challenges. Only one earning member, and he earned very little money, less than 10,000. So a liver transplant was not conceivable. Plex was done at AIIMS. The child got referred to us because of encephalopathy. Now, the timelines are important. 25th March 2022, 6:09 p.m. This is a Friday. The child was very sick. We ventilated the child, started dialysis, started Plex. Now, we know that in a child with Wilson's disease, if you develop encephalopathy, you will die without a liver transplant. Chelation cannot work because there's too much copper floating around. Unfortunately for the family, they didn't have a ABO compatible donor. So we are looking at Friday night. This child will die by Sunday. The child has no money and there is no donor. We have the ability to raise money, so we raised 16 lakhs in 8 hours, got permission from the government, did all of the authorization, and decided that we will do an emergency ABO incompatible liver transplant. So we started a transplant 31 hours after a presentation. It started at 1 a.m. on Sunday. Completed after 13 hours. The child was extubated 43 hours later, 87 hours after the first presentation, and was discharged on post-operative day 17. The key points: Wilson's disease, acute liver failure, no donor, no money. This is the child on admission. This is her 48 hours post-LT. This is her at discharge, and look at how beautiful she is. See, the liver has, as we know, 8 segments with their own biliary drainage, their own portal blood supply, their own hepatic artery and venous drainage. And it's possible for us to take segment 2, 3, 2, 3, 4, 2, 3, 3, or 5, 6, 7, 8 and do different types of liver transplants. So since 98, when we started liver transplantation in India, over the years we've been able to innovate and do many different kinds of transplants, and some of them are very high risk. For example, the smallest baby we transplanted was 3.5 kilos from Tanzania. This is her 4 years later. And look at this child who came to us from Philippines. This was really one of the most high-risk cases that we have ever performed. And we were very worried that this child is not going to make it, but then she was going to die anyway. So we decided to take the leap of faith, and the family was very supportive. Just see the ascites and see how sick she is. This is the same girl a few months later. This is her celebrating her 9th birthday very recently. Here's another very high-risk child, and this child's belly was so small that we could not close the skin. So we had to leave the skin open for a few weeks because it was just not possible to close her. And look at this child a year later. And here's another very high-risk kid who, again, as you can see, is severely malnourished with lots of ascites, and this is the same child post-transplant on follow-up. This child got referred to us from Qatar. You can notice that she's under a phototherapy machine. So she has Crigler-Najjar syndrome, bilirubin of 20 with 18 hours of phototherapy, so very poor quality of life. The family opted for a transplant, and this is her with white eyes, successful transplant. And then we wrote this as the first successful transplant for a child in India with no liver failure. And over the years, we've done 8 of these kids, and one of them, of course, wanted to spend some time with his hero, who obliged. This child got referred to us for a kidney transplant, but when we investigated him, we found that he actually had hyperoxaluria, and doing a kidney transplant would not have helped because the new kidney would also have been damaged by the oxalate. So we decided to do a combined liver-kidney transplant. Luckily for this child, he has twin sisters. One's an engineer, one's a doctor. One gave a kidney, the other the right lobe of a liver, and this is him at discharge after a combined liver-kidney transplant, ready to go back to Sudan. And sometimes we have to do a retransplant. This child came to us, he's a refugee, a Syrian refugee, who got the first transplant in Saudi Arabia, lives in Qatar, funded by UAE, who came for a retransplant, and this is her after her retransplant at Apollo. So over the years, we've performed more than 5,200 transplants, including 632 in children. The etiology has been very varied, but biliary atresia stands top. Metabolic is increasing. We did have a group of cryptogenic, which over a period of time has come down. PFIC has increased. In fact, there's a 30th we've just done. Bud Chiari, hepatoblastoma, poisoning, chronic rejection is of course rare, and so on. But whenever we talk about liver transplantation, the first question that I think is coming to your mind, but it's for the rich. Right? But what about all the people we see, the families we see who need a liver transplant and don't have the resources? So we decided 7 years ago that we are going to commit to reaching those with no resources. And I'm just going to report to you what we have learned over the years and what we've been able to do. So we know that we live in two Indias. We have an India where families can go to Disney World for a holiday multiple times a year, and then we have families where the basics are hard to get every day. We have kids who have everything, and we have kids who don't know where the second meal is going to come from. So we worked with temples, we worked with mosques for zakat, the church, gurdwaras, charities, crowdfunding, paid forward, and individual donors to raise money. And we are very fortunate that we have enough support now. The other day, a family, it was their 20th wedding anniversary, and he took me aside and he said that I want to discuss something with you. And he said, you know, every year our family will put in 50 lakhs for liver transplants for any child or children you want. And we have numerous donors like this who donate 5 lakhs, 10 lakhs on a phone call. So we are able to raise any amount of money that we know for we need for our children. I want to give you a few examples, I think a couple of examples. This child came to us from Bandipora in Kashmir near the border, the back of a vegetable truck. The family did not have enough money to pay for a bus fare from Kashmir. She, as you can see, severely malnourished, ascites, had autoimmune hepatitis. We raised enough money that not only could we do a transplant, but the family got a pakka house for the first time in their village. We had such a surplus, and this is the same child a few years later. So we've now raised 30 crores through charity in the last 5 years for our liver transplant program. And for us, this really means that money is out of the equation. We have transplanted children from families where the father is a mason, is a painter, drives an auto rickshaw, or works as a helping hand in the farm. Money is out of the equation. If the family has a child that needs a liver transplant and there is a parent who's willing to donate, we will organize the money. And all this has happened because India has changed. We have such magnanimous donors. And if we hadn't become such a big economy, I don't think we would have been able to pull off these transplants. Calcutta plays a very important role, has played a very important role in our program. This is the second child we transplanted, and I will never forget when Professor Subir Chatterjee from Park Hospital, a very renowned pediatric surgeon of Kolkata, called me and he said, Anupam, I have this child, partially successful Kasai. Will you do a transplant? And we took up this child, and he was 5 years old at that time. This child was transplanted in 1999. The family immigrated to Canada. This child works as an accountant now in Alberta, and you know, he'll be completing 28 years post-liver transplant. Of course, I would like to end with Sanjay. Sanjay was the first child we transplanted. He came to us from Kanchipuram, 20 months old, biliary atresia, unsuccessful Kasai. You can see very malnourished, extremely irritable, deeply jaundiced. We had a very traumatic and very stormy course. This child needed 5 laparotomies for repeated perforations. He was on a ventilator for 8 weeks, had TPN for 7 weeks. And I'm talking about 1998 when it was very difficult to do all of that, not today when it's so easy. So we were delighted when this child finally went home at 100 days of age. This is him a year later at the All India Transplant Games. This is him 3 years later, 6 years later, 9 years later, 12 years later. He's playing basketball and got hurt, and that's why he has this sling. This is him on the cover of the Week magazine 15 years later, and that's when the government of India issued a postage stamp marking 15 years, and this has our hospital on the stamp. Sanjay then decided to become a doctor. He went and completed his MBBS. He is currently pursuing his MD. We celebrated 25 years of liver transplantation, and we intentionally invited Ms. Dimple Kambadia because for those who remember the movie Dil Chahta Hai, she died of liver failure. So she said in the press conference that, listen, if that movie was made again, they would have to change my character because I would have received a successful liver transplant. Sanjay got married and is now a dad. So that is the story of liver transplantation and how it all started. So if a baby with biliary atresia was born in 1950s, he had a 0% chance of survival till Professor Kasai in Japan, in Sendai, developed the Kasai procedure. So in the 1990s, when liver transplantation was not established in India, a child through Kasai would be able to have a chance of 20% survival. But if a baby is born today through a combination of Kasai's portoenterostomy and liver transplant, a child has a 95% survival rate. And we recently reviewed our experience, and our survival figures are now 97%. So from 0% to 95%, that is the journey of pediatric hepatology. That is the journey of improved access and success. And I just want to end with this, which has been really very important for us. And Gandhiji had said, when you're in doubt or when the self becomes too much, recall the face of the poorest and the weakest man, woman, whom you may have seen, and ask yourself if the step you contemplate is going to be of any use to him or her. For us, it's not the numbers, it's not the success rate of 97%, but it's the fact that any child who needs a liver transplant can get it now, irrespective of their economic situation. And for us, the greatest satisfaction has been that money has been removed from the equation, and a liver transplant can now be offered to anyone who needs it. Thank you very much.
Thank you, Dr. Sibal. Please be there. May I call our director, Dr. Apurva Ghosh. We'd like to give you a small token.
It's a mistake actually. Normally,
So now we'd like to start our felicitation ceremony. I hand over the mic to Dr. Shrupa.
Can we welcome on stage Mr. Rohit Singhania, please? Mr. Rohit Singhania. Mr. Rohit Singhania is a director of Empress Group. He has a very long association with ICH and has greatly supported in the construction of the new building. Rohit came to us when the building was only in an idea form. We are now slowly coming up. The roof of the 8th floor has already been casted. So we've had Rohit since it was only an idea. He engaged CREDAI so as to donate the first 5 lakhs for the building. And then he engaged our architects, Mr. J.P. Agarwal and Kunal Bhattacharya, who have been designing this project absolutely free of cost. So on this podium, I would like to say that Rohit has again donated 50 lakhs, which is now has been utilized for purchasing our new CT machine. So ladies and gentlemen, yes, he deserves a big round of applause. Mr. Rohit Singhania. So we would now like to formally inaugurate the CT machine, which you see behind in the screen. So if we can just have the formal inauguration of the CT. Ladies and gentlemen, this is a new CT machine in ICH, which is going to be operated 24/7. Dedicated in the name of Mr. Srilal Singhania, donated by the Singhania family members. Can I hand over the mic to Rohit to give a few words to us?
Actually, I'm really grateful to Dr. Apurva Ghosh and his team of ICH to give us this opportunity. I think it was their vision that he approached me, and it was his, I'm grateful to him that he approached me for the building, and it is a great honor to help in any way that we can.
Thank you so much, Rohit. Thank you. Thank you for your generosity and taking care of children of ICH.
So now, coming back to the scientific session, our next speaker is Dr. Sushil Kumar Kabra, and he'll be talking about the new diagnostic and treatment of pediatric TB. May I ask Dr. Parthaprati Maldar to introduce Dr. Sushil Kumar Kabra.
So, welcome, sir. And I think he needs no introduction, teacher of teachers, and we always like to hear his presentation over different seminars. Okay. So, please, over to you, sir.
Thank you. Friends, I'll take you through the existing and newer test as well as therapy for tuberculosis in children. TB is very common, important cause of morbidity and mortality. Though we as a nation failed to achieve the target of eliminating it by 2025, and why this happened, I leave it to the policymaker that they see how we have targeted it, why we did not achieve it, revise, and then work towards achieving it for the next target. Okay, but as a pediatrician, as a practicing pediatrician, what is our duty? That we should know about what is the diagnostic criteria, how to confirm the diagnosis, how to utilize the available resources, and how to manage them effectively. And we contribute towards achieving our next target of eliminating the TB. So I start with this case. This is a 9-year-old girl, resident of Delhi, presented to on 10/7/25 to Indraprastha Apollo Hospital, where I am working currently. And she had a fever for 3 months, family history, no TB, no distress, clubbing was plus minus. There was bronchial breath sound, left intraclavicular memory and axillary region, and sputum gene expert was positive, CB0 was positive, and she was, resistance to rifampicin was not detected, on anti-TB drugs for last 3 months, and she is improving, no fever, gaining weight, and no breathing difficulty. And why she came to me? Because there is no appreciable difference in the X-ray, and treating physician told that there may be a drug-resistant TB and need a further investigation like bronchoscopy, EBUS, and CT scan to rule out drug TB. And as you can see that X-rays, 3 X-rays done at interval of 2 to 6 months. And you can see that the last X-ray is showing significant improvement, but interpretation of the treating physician was that it is not improving, and that's why the child may be having a drug-resistant TB. So, compatible history with examination and imaging, diagnosis is easy, gene expert is positive. Radiological improvement may take some time, and there is no need to repeat X-rays every 2 months or every month. That will create more problem like this child. I reassured the family, sent her home, and after that she is now much better. Now the other child, this is a 7-year-old, fever, pain, abdomen, and constipation for 45 days, no contact with TB patient, loss of weight and appetite present. Systemic examination is within normal limit, and you can see that the X-ray is showing a subtle changes in the right paratracheal soft tissue. And because this thing fever was persisting, so CT scan was done, and in a CECT you can see there are mediastinal adenopathy conglomerate nodes with some necrosis and perilesional enhancement. So how to go about it? There is no lung parenchymal lesion, and his gastric aspirate for gene expert was negative. So how to go about it? So we decided to perform, okay, this is not showing. So we decided to perform the sampling of this node, and by using a transbronchial IBUS, and we could identify the cause, and it was a TB was confirmed, started on anti-TB drugs, and the child is cured. So here there was no parenchymal lesion, but there was a lymph node, and we could aspirate by using a newer technology, that is the IBUS. Similarly, this another girl presented to Indraprastha Apollo Hospital on January this year, fever for 1 month, cough for 7 days, no loss of appetite, no contact with TB patient, recurrent cold cough was positive in past, and received 2 courses of antibiotic for sinusitis and no improvement. And X-ray, she was carrying this X-ray, this was reported as normal, and if you see carefully, then there is again a right paratracheal soft tissue, and there is some soft tissue in the right upper lobe. So I thought that it is not like a sinusitis alone, and incidentally this patient was referred to me by a pediatric pulmonologist from PGI, Chandigarh. And I got a CT scan, and CT scan again shows that there is a lymph node enlargement in the upper part, and there is a subtle parenchymal lesion. And now how to go about it? TST was 12 millimeter, induced sputum for CB0 or gene expert was negative. I consulted about the bronchoscopy and IBUS, but parents were reluctant, and they said that we'll go for anti-TB drugs. Following that, if she doesn't improve, then you go for these bronchus all investigations. And within a week's time of starting anti-TB drugs, she improved. X-ray at 6 months, as you can see, this X-ray is showing normal X-ray, that shadows have disappeared, but I decided not to go for a repeat CT. So highlights of these 3 cases is, if there is a significant lung parenchymal lesion, you can use a CB0, and which is likely to be positive. Only lymphadenopathy with minimal parenchymal lesion, CB0 is likely to be negative. CECT chest may be helpful in selected cases, so imaging. Repeated imaging is not required. Careful interpretation may give a clue regarding the TB. If responding well and X-ray is fine, no need to repeat a CT scan. So what are the part of diagnostic algorithm? These diagnostic algorithm, you can see that imaging, X-ray, CT scan, and sputum, gastric aspirate, gastric lavage, induced sputum tested for CB0, TrueNAT, MGIT, and LPA. These are the established tests, and that is part of our algorithm by National Tuberculosis Elimination Program. And newer tests in pipeline are these: Expert Ultra, PCR-based test to detect MTB and DST for multiple drugs, bronchoscopy, and others. I'll discuss some details of these. So X-ray, in our office practice, if interpret the X-ray properly, take the proper X-ray, interpretation is proper. So those which suggest, the findings suggest that it is more likely to be TB, not confirmatory. These are mediastinal lymphadenopathy, subcarinal lymphadenopathy, paratracheal lymphadenopathy, miliary shadows and cavities. If there are non-specific infiltrate, these are not suggestive of TB, but give antibiotics, and if doesn't clear, then you may think of tuberculosis. So you can see that what are the CT findings. X-ray showing some shadows, CT is showing these are the hypodense lesions along with that perilesional enhancement, and after the treatment it may completely clear. But it is not required in all, only in selected cases. Now how I can get a major issue in pediatric TB diagnostic is how to get a biological samples, which may be gastric aspirate, induced sputum, or others. So gastric aspirate or gastric lavage, earlier we used to hospitalize the patient, tube is placed, and then you take the sample, and then you send it for treatment, for the diagnostic test to the lab. Now Our group has generated data and it suggests that even you can do it on an ambulatory basis. We call the child 6 hours nil per orally, tube is inserted in the stomach, take out the stomach content. If it is less than 10 milliliter, then put some saline or aspirate the fluid in different posture. So it is important that you take a appropriate sample, send it for the laboratory test. Earlier, we used to say neutralization is required of a gastric aspirate before sending it to the lab. The studies carried out by our group suggest that it will not help anyway, rather it may cause more contamination and the yield may be poor. And this is important. Even in our earlier first or second edition of our book, we had written that neutralize it, but now we have changed it after our observation. Another thing which is coming up is an induced sputum, which can be carried out in a office practice also, emerging method. You put a hypertonic saline 3 to 5% by nebulizer. After priming with salbutamol, sputum nasopharyngeal secretions are collected and may be performed in young infants, may be performed on ambulatory basis. Because of time shortage, I am not showing the, this video, but it can be seen on a YouTube. So, based on these existing tests, what we suggest is, it is part of the National Tuberculosis Elimination Program, that suspect TB if a patient is having a unremitting fever, unremitting cough for more than 2 weeks, and weight loss or not gaining weight for more than 3 months, with or without contact with TB patient. And upfront you will get a X-ray film of the chest, interpret the X-ray properly, and then you do a gastric aspirate or induced sputum, and then if it is positive, then microbiologically confirmed. If it is drug sensitive, DSTB. If drug resistant, DRTB. If this CB0 is negative and X-ray is highly suggestive, repeat a gastric aspirate or go for these investigations like CT scan or aspirations or bronchoscopy. And so here there will be use of these advanced tests. What are the newer tests? Another test is Expert Ultra. Gene Expert or CB0 has a sensitivity of 116 CFUs or organism per milliliter, while Expert Ultra, it has a sensitivity of 16 CFUs per milliliter. And obviously it is more sensitive and it may be more useful for our patients who have a paucibacillary disease. It is available commercially, approved by WHO, but not yet included in our national program. Probably you will see it in next few years. So you can use it wherever it is possible. PCR-based tests to detect MTB and DST drug sensitivity to multiple first and second line drugs. They are not yet part of NTEP, available commercially, but be careful that their performance is not consistent. So use it with caution, not in all the patients. Then I discussed about the bronchoscopy, BAL and IBUS, transbronchial mucosal biopsy. All these are targeted sampling and you can send it, use the molecular biology. And these investigations require expertise. If you have that, go for it. If the gastric aspirate and initial tests are negative, not upfront, you will not do these things. So if you do all these three things, then if you have done a gastric aspirate or induced sputum in 100 children, you will be able to identify 34 children who are microbiologically confirmed TB. If broncholar lavage is done, then you will add 35 more. That becomes a 54. And if you do a IBUS or other things, then you may be able to identify 75% children microbiologically confirmed. So provided that you are able to use it. So other tests are lipo and arabinomenin antigen in mycobacterium in urine. It is relatively easy to collect and it has been approved by WHO, but not yet included in National Tuberculosis Control Program. Other is CTB, which is similar to that of a tuberculin skin test, but has a specific antigen, ESET and CFP, and as compared to PPT, it is more specific. And it is cleared for use in children about 12 years of age, available in our program. IGRA-based tests are similar to that of a CTB, and it doesn't differentiate between the infection and disease. That's why they can be used for identification of high-risk patients who are infected but not having a disease. Then biomarkers, these are just to know that there are some blood tests based on various cytokines, small molecules done on blood as well as urine, and may give some evidence. The initial results suggest that they have a reasonable discriminatory value between the TB infection and disease progress and their outcome. Now we come to the therapeutics regime. Over a period of time, over last 3-4 decades in India also, there is a single, now we have come to a single regime. That is 2 months of intensive phase, 4 drugs, followed by 4 months of maintenance phase. And in our regime in India, it is ethambutol is added to the maintenance therapy or continuation phase because of the very high chances of isoniazid resistance of 10 to 14%. That's why it is being given along with the 2 drugs. And we extend it to continuation phase to 9 months, so total duration becomes 12 months if it is a CNS TB, bone and joint TB. And we add systemic steroids in CNS and pericardial tuberculosis. The drug dosage has been revised based on the pharmacokinetic data generated in India and abroad. And now you can see that the doses are increased. Isoniazid, now it is 10 milligram per kilo, rifampicin 15 milligram per kilo, ethambutol 20, and pyrazinamide 30 milligram per kilo. So that should be kept in mind. Now what are the short duration? Can we reduce the treatment duration? So there is one trial which is called SIGN trial, in which non-severe tuberculosis were treated with 4 months with a successful rate. WHO has suggested, but in Indian circumstances, it becomes very difficult to differentiate what is the non-severe or severe, and that's why it has not been included in our national program. Then there is another shorter regime, that is a 6 months of isoniazid, rifampicin, pyrazinamide and ethionamide for CNS TB. Because CNS TB is difficult to treat, you give for 1 year, 1.5 years, 2 years, and sometimes people are giving it for years together. This has been shown to be very successful in South Africa, but in India still it is not included, though approved by WHO, but it may come over a period of time when we have our own experience. There is another 4 months regime in which 2 months of isoniazid, rifampicin, moxifloxacin and pyrazinamide intensive phase, followed by 3 drugs. Pyrazinamide is stopped, but we continue with the rifampicin, INH and moxifloxacin for another 2 months. So this is approved in our national tuberculosis program over the 12 years of age, not below that, and over the 40 kilogram of weight. So these are the shorter regime still in pipeline, not included in our program. You may see these in near future. So this case 4 is a 9-year-old from Gwalior, diagnosed as TB based on the clinico-radiological CB0 positive, treated with appropriate regime, improved, but X-ray showed a significant worsening. You can see here progressive loss of the lung volume. X-ray, CT and bronchoscopy revealed that there was a severe stricture of the left main bronchus with bronchiectasis in the left lower lobe. And you can see here, this is a X-ray showing a, though clearer, clinically better, but there is a significant loss of lung volume, collapse, and there is a significant stricture. So it improved with the balloon dilatation. Challenges are, could we have prevented the stricture formation and complete loss of the lung volume? Yes, if we are aware about it. So a pediatrician's role is not over just prescribing the medication, decreasing the fever, improving the weight, but to see that what is sequelae which we can identify early, prevent it and treat it early. So this is very important. So this is one which will cause a significant lifelong problem of disability because one lung is lost. So this is a data collected at AIMS that out of 52 children who had a pulmonary TB, 11 had some impaired lung function. So even if the X-ray is okay, no respiratory problem, but if you do a pulmonary function and clinically evaluate the patient, then almost 1/5 of the patient may have an impaired function. So that is not gaining our attention, despite the fact that these may have a significant problem later on. So this is a new aspect that Once you have identify a child, give appropriate treatment, but don't leave it at that stage. Try to find out whether they are having a sequelae in form of a physical problem in the lungs. In addition, there will be a lot of psychological and societal problem that is also required to be taken care by pediatrician, that there is a discrimination in the school, child is not going to school, he has been left from the school, those things should be taken care. So when to suspect DRTB, drug-resistant TB? A contact is with the diagnosed DRTB, irregular treatment, person died in the family due to TB in last 2 years, the child is exposed to anti-TB drug in past 2 years for more than 4 weeks, comorbidities, and there is a clinical response, but no clearance of lesion is not a reason to suspect that it may be a DRTB. So another thing is upcoming is treatment for prevention, TB prevention. Earlier it was prophylaxis, now it is a TBT, and this is a big program of a WHO as well as Government of India in tuberculosis elimination program, that any person in the family who is suffering from drug sensitive or drug resistant TB with a open tuberculosis, they should be given a prophylaxis, and that may be 6 months of isoniazid or 3 months weekly isoniazid rifampicin above age of 2 years. So this is very important that prophylaxis is given so that we can reduce the pool of patients with a tuberculosis which may have a reactivation tuberculosis. And for drug-resistant TB, you have to give a 6 months of levofloxacin. So to summarize, proper sampling and use of molecular test, all children with presumed TB should be investigated properly. Newer tests like I have already discussed, short regimes are not yet approved, and follow-up of relapse and sequelae is very important and part of us. So all the pediatrician, I request that this is our responsibility to identify, utilize and treat children with tuberculosis and contribute to the TB elimination program like we have contributed to the polio elimination program. Thank you very much.
Thank you, Dr. Kabra. May I request Dr. Atul Gupta, please kindly hand over the memento to Dr. Kabra in the Felicitation Center. So, now I call upon for the felicitation ceremony. After that, Sham will start this. After that, not now, after this.
Continuing with the felicitation program, may I call upon stage Dr. Somnath Chatterjee. Dr. Somnath Chatterjee needs no introduction in Kolkata. He is the chairman and joint managing director of Surakha Diagnostic Limited, bringing over 32 years of leadership excellence in the medical diagnostic center. A very global thought leader of Bengal, a man of true spirit of Bengal who has helped us and is helping ICH to diagnose very difficult cases. Thanks for your advice, Dr. Chatterjee. Thank you. May I next call upon stage Mr. Deepnath Rai Chaudhary. Mr. Deepnath Rai Chaudhary is the founder of Strassenberg in Kolkata, which is a manufacturing unit, and now has become a national market leader in gastrointestinal and surgical segments. May I request Dr. Apurva Ghosh and Dr. Kundu to felicitate Mr. Deepnath Rai Chaudhary. Ladies and gentlemen, rounds of applause, please. May I next call upon Dr. Probir Bhaumik. He requires the introduction on this stage. Renowned pediatrician, esteemed alumnus of Institute of Child Health, Dr. Bhaumik. He has donated substantially to the cause of ICH. A big round of applause, please. Can we now have Dr. Chandrakanta Ghosh on stage, please? Dr. Chandrakanta Ghosh is a celebrated pediatrician from Hooghly, widely respected for his exceptional service and compassionate medical practice. He has made generous financial contributions to ICH, donated 50,000 rupees last year, and now will be donating again a sum of rupees 25,000. Ladies and gentlemen, please, a round of applause for Dr. Ghosh. Thank you so much. Thank you. Dr. Das has donated 50,000 last year. Now he's donating a sum of 25,000. It helps ICH in a very big way. Thank you. Thank you.
So now we come to our next very important Dr. Shishir Kumar Bose Memorial Oration, and I call upon this on stage Dr. Sham Kukreja. He'll be talking on changing landscape of CNS infection in the last 4 decades. Dr. Sham. Just a minute. Middle. ওর নাম কি কিসের নাম Sumanta Bose. May I call upon Saugata Bose and Mr. Sumanta Bose to kindly hand over the medallion to Dr. Sham Kukreja.
I'm most grateful to Dr. Sham Kukreja for coming down from Delhi to deliver the Dr. Shishir Kumar Bose Memorial Oration of the Institute of Child Health. We are gathered here on Independence Day, and so I think it is pertinent to mention that Shishir Kumar Bose was a freedom fighter. His Ranga Kaka Babu, his radiant uncle, Subhash Chandra Bose, called him to his side in early December of 1940 and asked him, "Amar ekta kaj korte parbe?" And that kaj, that work, was to help plan and execute the Mahanishkraman, or the Great Escape of Netaji Subhash Chandra Bose from India. So they had left on the night of 16-17 January 1941, and Shishir Kumar Bose reached Subhash Chandra Bose up to Gomo station. And that was the first stage of the transformation of Subhash Chandra Bose to Netaji. Shishir Kumar Bose spent long years in British prisons, in Presidency Jail, in an underground cell of the Red Fort, the Lahore Fort, and finally Lalpur Jail. He then returned to his medical studies at Calcutta Medical College, and of course he also trained at the Great Ormond Street Hospital for his DCH, in Sheffield, in Vienna, in Bern. My first visit to Harvard was with him and our mother, Krishna Bose, in 1958-59, when he went as a Rockefeller Fellow to the Harvard Medical School, and there he did advanced training in pediatric radiology at the Boston Children's Hospital with Ed Newhouser. If you visit the Children's Hospital today, you will see a beautiful oil painting of Ed Newhouser with his international fellows, including Shishir Kumar Bose. He established 2 great institutions in Calcutta, the Netaji Research Bureau, and with K.C. Chaudhary, whose picture you see on that side, and you have Shishir Kumar Bose's portrait on this side, they helped build the foundation of the Institute of Child Health, the leading teaching hospital for children in India. And I'm delighted that his student, Dr. Apurva Ghosh, is leading ICH to great heights, and there will be a new building that will come up by early 2027. Thank you again, Dr. Shyam Kukreja, for being here with us, and we look forward to listening to your oration. Jai Hind.
Good afternoon, all. And I tell you what I'm going to speak. Before that, the Sisir Kumar Bose, Dr. Sisir Kumar Bose, you have heard such a remarkable personality. And he was first editor-in-chief of Indian Pediatrics. And he was pioneer of pediatric radiology. And you heard about it. My talk is sort of a carry forward his legacy of pediatric radiology. So this incidental. And my disclaimer is, I'm no pediatric neurologist. I'm a just simple ID specialist. And it's not a comprehensive review of CNS infections. I'm taking you on a journey. I think many people of my generation will relate what I'm talking about. Through the eyes of my generation, a lot of things changed. And how our understanding of CNS infection evolved, a lot of invisible diagnosis became visible with the technology and science developing. And see, when I was a house surgeon in G.V. Pant Hospital, I think Dr. Mangalik will relate with that because he's from my hospital. I'm from Maulana Azad. These were the 6-7 diagnoses where I could fit in any infection, CNS infection. Pyogenic meningitis, aseptic meningitis, encephalitis, encephalopathy, brain abscess, tuberculomeningitis. Life was very simple. You can put it in these categories and you can manage the cases. Now, whenever there was a patient of suspected brain abscess, the only way to diagnose was carotid angiogram. And this was supposed to be then a non-invasive procedure. So you used to put the needle in the carotid artery, a lot of blood used to gush out, a stream of blood used to gush out, and you are very sure I'm in the carotid artery. Then you put the contrast and you look for a mass effect. This is how we used to diagnose brain abscess, and it used to fail in deep and posterior regions. And it was supposed to be very minimally invasive. And I've seen with own my eyes carotid spasm. I've seen cerebral ischemia, stroke, seizures, not seen carotid dissection, neck hematoma invariably, contrast reactions, transient blindness was not uncommon, and considerable cost in terms of patient discomfort and risk. And I used to feel really for the patient whenever this carotid angiogram was done. And today, it is invasive. Why it was supposed to be non-invasive? Because the reason was, if you don't do this, the other possibility was you explore the brain. So that's the reason it was supposed to be non-invasive. Now, whenever the star comes, it's an inflection point in our history. The things changed after that. The CT in 1980 came in AIIMS. And soon after, we started seeing these small single enhancing lesions in CT scan. And this became very common. And this is a paper by Dr. Tandon and Dr. Bhargav. I've heard lectures of Dr. Tandon in AIIMS. And they were labeled as small ring disc lesions, immature tuberculomas, or they are large lobulated lesions, which are mature tuberculomas. And they were being treated with ATT. And then Wadia et al. Also said, if there's a simple partial epilepsy, 26% have similar lesions, particularly children less than 15 years. They were managed with ATT. And then something drastic happened. And they said, Dr. Sethi et al., Bansal, and then Dr. Natarajan from Neurology Institute, Dr. Chopra, other several groups, they started reporting that these lesions disappear without any intervention. So then it was a very surprise why it disappears. And then we heard lectures of our neurologist friends and neurosurgeons. It depends on the shape, it depends on the size, it depends on the enhancement pattern, it depends on amount of edema, presence of calcification. And if this is transient post-actal edema could be there, it could be vanishing non-specific lesions, and there could be microtuberculomas. And then suddenly the maze got cleared. And this is a very good research by Vellore Institute. And in this, Raj Shekhar was the main person who did stereotactic biopsies of these lesions and told the world, these are NCC. So this is how we learned about NCC. And then I think I was a editor of Daily Pediatrics those days, and we wrote an article, if you give albendazole in these cases on a mass scale, some cases will develop seizures because of that. So that is a question we raised. Possibly it causes degeneration, and you know NCC in degeneration is a manifest. NCC without degeneration is not manifest. Okay, anyway. Then came MRI in 1987 in NMAS in Delhi. And then we could easily see, MRI could know what is NCC like. We could see the scolex also. And CT revealed the lesions, MRI revealed the disease. Now, this disease was not known before MRI. We had good number of cases where there was this type of a presentation, and they were named as viral encephalitis, post-infectious encephalopathy, toxic encephalopathy, early MS, unexplained ordered sensorium, all those things were explained, but this disease was not known. But as soon as the MRI came, we came to know about this disease. And this was something like this. We could see white matter demyelination. This was multifocal in the subcortical region, bilateral, symmetric, asymmetric, and they were absolutely poorly marginated. And we could see in T2 weighted and flare sequences. And this was the images like this. And suddenly we found what we used to name as encephalitis. We give methylprednisolone or IVIG, and these patients improve. And this is the first time this happened. And then I tell you a very interesting story. My niece, she had a delivery about 6-7 days before this incident of press occurred. And she rang me up and tells me, I'm having a lot of headache. On phone, she tells me I'm having nausea, severe nausea. And then she tells me, I am having a very blurry vision. And on that she says, I can't see. And within minutes she had a seizure and collapsed. And she was brought to the hospital. Immediately this MRI was done. You could diagnose Press syndrome and could manage properly. And then new era starts. After that, the era starts of PCR. And PCR era, you know, Carrie Mullis was the one who received Nobel Prize for this. And before that, PCR used to take something like weeks because it was generated in bacteria. And he could do this in the lab. As a result, we could see PCR in 2 hours. You have witnessed this in COVID and all that, how PCR works. And a lot of people in biology believe there are 2 eras. One era before PCR and one era after PCR. Before PCR, our diagnosis was on the basis of clinical syndrome, CSF cell count, glucose, protein, cultures, serology, and imaging. This was the combination we used to use. And before PCR, empirical acyclovir was started in practically every patient of encephalitis. Confirmation was very difficult. Brain biopsies sometimes was the only modality to confirm the diagnosis. After PCR, HSV PCR became the gold standard. Early confirmation was possible, and it led to dramatic fall in mortality. Now we know, you will say MRI was there before PCR. The people could have diagnosed HSV because of MRI. No, it is something like this. The large case series of PCR positive were correlated with MRI patterns. And then they established classical MRI signatures pattern of HSV encephalitis. And we know now temporal lobes, insula, and limbic structures are affected. Now, BioFire came in 2016 and 17. I think this is where we started using a lot. I think 3-4 years before this, we started using HSV in our practice. PCR allowed us to do direct detection of viral DNA, RNA in the CSF within hours. We have a machine, we get the report within 2 hours. And imagine this. This is a child, 8 years old, presents with fever of 3 days, severe headache, repeated vomiting, photophobia, neck stiffness. On examination, the child is conscious oriented, no focal neurological deficit, no seizures, no altered sensorium. And this is the picture. 180 cells, 90% lymphocytes, protein is slightly raised, 65, glucose, gram stain negative. So what we used to do, we used to say this is CSF pleocytosis. There's a negative bacterial culture, so it is aseptic meningitis. Now, once you say this is aseptic meningitis, so there's no need to give antibiotics. But most children had received antibiotics before that. And the doctor always used to believe this may be partially treated meningitis, although it's not. But for the sake of confidence, all of them, all aseptic meningitis, I'm telling you before this era, used to receive antibiotics. Now what happens today? I do a CSF panel. Invariably, these cases are enterovirus. Rapid turnaround time, avoids unnecessary antibiotics, gives you a lot of confidence that I am dealing with this, and allows early discharge in stable patients. Now, PCR is able to diagnose large number of diseases. So, including, as Dr. Kabra told you in the last lecture, gene expert and now ultra. Anyway, PCR has few challenges also, but we are learning how to manage this. And now NGS metagenomic sequencing is going to change all, because you are going to solve encephalitis of unknown cause, identify emerging pathogens. Now this is another era. In this, we used to have patients with seizures, altered sensorium, psychosis, movement disorder, reduced consciousness, and fever sometimes absent. And this emerged as viral encephalitis or post-infectious encephalitis. And then, landmark study in 2007, they said these features they saw in young women having psychiatric symptoms, seizures, dyskinesias, autonomic instability, and they were ovarian tumors. So after this, they came to know there's a anti-NMDA receptor encephalitis. And other antibodies were also diagnosed. And they started reporting in different institutes like PGI, AIMS, NIMHAMS. In 2009 to 2011, these cases were being reported. But antibodies were being sent outside India. And routine testing we started doing in the major centers after 2015 onwards. And the formal diagnostic criteria for autoimmune encephalitis were made in 2016, which we use in our practice today. Possible, probable, definite. And we do this clinical features, see, do MRI, EEG, CSF. Don't wait for antibody results, because they can be some seronegative also. And then we start the treatment, and we have a very remarkable results. So what cases of encephalitis were there? Now there are many of them autoimmune encephalitis and treatable. So these are the different type of presentations of autoimmune encephalitis. Now early empiric immunotherapy is justified when suspicion is high. We treat with steroids, IVIG, plasma exchange, and sometimes rituximab and cyclophosphamide. Now, Dr. Sabharwal, who was in practice, R.K. Sabharwal, in pediatric neurologist, first generation, we in our generation, we had first generation super specialist. And he used to ring up everyone in those days. I'm getting cases of recurrent ADM. If anyone else is getting, please send the cases to me. I'm doing a study on these cases. And this puzzle was again taken care. We came to know when there's a recurrent ADM, it is usually ADM is a monophasic. But if it is multiphasic, it doesn't fit into this criteria. And it was MOG-associated disease. So we started knowing what is MOG-associated disease. Large proportion of multiphasic ADMs were MOG positive. Recurrent ADM, this phenotypes, strong MOG clue, and these are recurrent ADM. We know that most of them are MOG-associated, but some may not be. Other possibilities could be MS, NMS, OSD, etc. And classical thing about MOGAD is it begins in younger children. There's a persistent or recurrent MOG IgG positivity. MRI, there's a fluffy, extensive lesions. Recurrence may manifest as ADM or may manifest as optic neuritis or may manifest as myelitis or in combination. And the response, these all episodes are steroid responsive. Now I tell you a case we managed, and if I look back, I feel so sorry. This is a case we managed 8-9 years ago. 23 months old girl, high-grade fever, seizures, tonic-clonic, loss of consciousness, aborted with midazolam. CSF is normal, MRI is normal. We managed, improved. Fever and some irritability persisted. And after 48 hours, started having recurrent seizures, repeated seizures, altered sensorium, and loss of speech. We were totally lost what it is because we investigated and found there is HHV6. We thought it must be part of roseola infantum, and it can happen. If there's a HHV6 in the CSF, one possibility is acute roseola infantum. In that period, what happens in viremia, the lymphocytes which are infected, they cross the blood-brain barrier and you get positivity. Or it could be reactivation because it becomes a latent virus, and it could be just a bystander. So if the patient is okay, then we don't worry in these two conditions. And third is HHVS encephalitis. And we knew this, this child is not immunocompromised and very unlikely to have HHV encephalitis. Now after 48 hours, repeated focal seizures, altered sensorium, loss of speech, and we treated this as HHVS6 encephalitis. A small child, it could be encephalitis. And then 2014, 2024, this paper came. It opened the eyes of many of us. And it told us, no, it is ITIS. ITIS means infection-triggered encephalopathy syndrome. Now, infections acts as a trigger without brain invasions. It can be triggered by many viruses. Common clinical and imaging features may be there, very common, even flu, all those things can lead to similar features. Excessive innate immune activation is there, a lot of cytokine storm is there. So basically it is a host reaction, it's not the bug reaction. Now it's not a single disease, and there are a lot of entities being found under ITIS. Now this patient was classically, this was viral associated HHV6. Early febrile seizures are there, then there's a transient recovery, then there's a secondary deterioration. Repeat MRI on day 3 to 9, there was a symmetrical subcortical restriction diffusion is there, and bright T appearance comes, which is very classical. And this is the illness which has to be managed as ITIS. So, HHV6 can be fourth presentation also. It can be infection-triggered encephalopathy syndrome, and it may present as, I'll tell you about these terms, It may present of the either. And these terms are ANEC, acute necrotizing encephalopathy. It could be AESD, acute encephalopathy with biphasic seizures and late reduced diffusion. This was our case. It could be MERS. We have seen a lot of typhoid cases. This is mild encephalitis, encephalopathy with reversible splenial lesions. I was talking to my adult neurology friend. He was not totally aware of this, just 2 weeks ago. And he says, कि we see a lot of splenial lesions, पता नहीं लगता reason क्या होता है इसका. I gave him this paper, मैं कहा read this paper, because this is so latest. Now, the other can be these acute fulminant cerebral edema or acute shock with encephalopathy and multi-organ failure. So this was, we should have managed as a host response. I come to the treatment later, and we managed as encephalitis. Now, this is 4.5-year-old girl, high fever, cough, coryza. This is the very latest patient. Poor intake, similar illness to family members, nasopharyngeal swab, PCR is influenza, generalized seizures, progressive drowsiness, GCS is 8 to 10, no meningeal signs, no focal neurological deficit, and I get this. I get this symmetrical bilateral thalamic hyperintensities. In case of JE, they are patchy and basal ganglion and substantia nigra are involved. In this, they are not involved. So, this is symmetrical, absolutely symmetrical. And this is known as ANEC. And what is the pathophysiology of these? There is a cytokine storm, blood-brain barrier breakdown is there, and there is a symmetrical thalamic necrosis, rapid encephalopathy. Answer is neuroprotection, early methylprednisolone, IV or IVIG, and some cases you have to give tocilizumab. So you have to treat the host response here. So this is MERS, the patient I was talking about. With this patient we treated as encephalitis, which was actually MERS, and this was a host response, it was itis. And there are signature imaging syndromes in this itis: ANEC, bilateral thalamic necrosis, AESD, subcortical diffusion restriction, MERS, splenial lesions. So we learned there are 3 types of encephalitis syndromes. First is viral. There is a direct neuroinvasions, which happens in HSV and JE. The second is autoimmune, which is post-infectious autoantibody mediated. And in this, there's no necrosis, there's a synaptic dysfunction. Okay, the treatment is again different. Now, last is itis, infection-triggered encephalopathy. This is a host response and cytokine related. So, what we had an umbrella of AES. Under AES, now we have MRI phenotypes, we have got PCR etiologies, you have got autoimmune antibodies, it's not itis. So no more dumping. You can have to diagnose with these, either of these. During this phase, I'll take 3-4 slides more. During this phase, while new CNS diseases being unraveled, 2 dreadful CNS diseases of our generation disappeared. This is one. I was in Kalavati Hospital and I was posted in polio ward. There were large number of patients in those days. In mid-80s, there were 2 to 4 lakhs polio cases per year in India. So, at a first glance, you may think that polio and tetanus are basically peripheral nervous disease. No, they are central. So both of them are CNS diseases. Now, when the limping child in OPD was an everyday affair in Kalavati, and anyone in the Kalavati who has worked will remember this, and we used to see large number of polio, limping child, polio, sciatic nerve palsy. Why sciatic nerve palsy? Those days, IM injections were given in the gluteal region. Unrecognized trauma could be there, transient synovitis, septic arthritis. Provocation, poliomyelitis was also quite common. Now, bulbar weakness, quadriparalysis, and respiratory failure is there. The commonest cause those days was polio, not GBS. And this is iron lung machines, the first generation ventilators, where the head was out and the chest was given a negative pressure by these. Okay. And now we have won the polio war. And we have seen last case in 2011, certified in 2014. Current status till 2016 is no indigenous case. So we are having a good surveillance so that new cases do not appear, and we are having immunization drives, pulse polio, so that we do not allow the virus to take a foothold again. India has eliminated tetanus also. There's less than 1 case per 1,000 live births in every district. Polio can be eradicated, tetanus cannot, because the Clostridium tetanus spores are there in the soil and they will not, impossible to eradicate. So for my generation, in next 2 slides I summarize. For my generation, the changing landscape was not about discovering new diseases. It was about watching old dreadful diseases disappear. So we learned in 4 decades, we learned to see the brain by CT and MRI. Carotid angiogram was out. We learned to identify the pathogen by PCR, multiplex PCR, and now metagenomics, NGS. We learned to recognize the immune response by autoantibodies. We learned to understand the host response through ITC. And we also learned to prevent these dreadful diseases. And they used to cause a lot of handicaps, paralysis, disability, lifelong handicap, and they have disappeared. And so rare, I can tell you many pediatricians who encounter them are not able to diagnose these cases, because this is something very good. They have not to see this. This is what vaccination could achieve. Thank you very much.
Ask Dr. প্রিয়ঙ্কর পাল, তুই বলবি কি বলবি?
I think everyone is leaving for lunch, but can I request 5 minutes of your time so that we can have a look at, so this was the 70th year of the Institute of Child Health, and sort of a report at what we did, what our students did. So we all know that we had 6 MD seats. Presently, we have 16 MD pediatric seats from 2023. We have a fellowship program running successfully in nephrology, rheumatology, neonatology, PICU, gastroenterology, and infectious diseases. There's a PhD program initiated in collaboration with the Presidency University, and we also have a nursing college. So this was our last MD batch with 6 students. So we had a DCH, so we are not having a DCH anymore. So present batch will be appearing, the 2023 batch will be appearing this year, the 16 MD seats. Regarding publications, so over the last year we had about 45 publications. So all of us, you can see Dr. Parthapratim Haldar, he had 6 publications. Dr. Bhashwati Acharya, she's a gastroenterologist. She also had a couple of publications. She presented in ISPAGAN, her study, original study, which got the best abstract recognition. And our fellow, gastro fellow, Dr. Pritha, she got the travel grant with oral presentation at the Asia Pacific Society of Pediatric Gastroenterology. So this was Team PICU. Team PICU is a very vibrant team. They had 3 publications, and they of course organize the state conference on the intensive care chapter every year. The level 3 NICU. So this was actually what we consider as a success. So this was a primey. This was a preemie baby of a 20-weeker, 940 grams, who stayed with us in our NICU. And you can see that this child, this Miss Aradhya Kundu, she won the gold medal in March 2026 at the Muay Thai World Championships. So I think that is an achievement.
we had two fellows passing out, Dr. Shishendu, Dr. Shomu Gain from NICU, and these are a few of the publications of Dr. Khea and team from NICU. In between, Institute of Child Health received the Anando Shastho Shrestho Shanman Award of 2025. So you can see Professor Ghosh, myself, and Professor Rai over there, at the stage over there. Professor Joydeep Chaudhary delivered two orations. So he delivered the IIP infectious chapter oration, Dr. Tapan, very prestigious Dr. Tapan Kumar Ghosh Memorial Oration in Jaipur 2025, as well as the East Zone Academy of Pediatrics oration in Manipur in 2025. Joydeep also organized the first IIP Pariksharthi Award, PG Pariksharthi Award, which was initiated this year, 2026, and it was also a very successful program at ICH. So it was, the zonal program was at ICH. So as we say that the cup came home, so Pedicon 2026 was in Kolkata, and I think almost all the faculties of ICH participated somehow in some form or the other in this Pedicon 2026. And a lot of our students, they received prizes. Dr. Anupama, Dr. Shreya, Dr. Natasha, they received all first prizes in the e-poster presentations. Division of Pediatric Nephrology. A whooping number of 24 publications over the last 2 years. And they have a lot of ongoing research. You can see 6. And Rajiv and his team, you can see they presented in Sri Lanka, Bangladesh, a lot of international conferences. And these were the publications. 3 of the publications were jointly with the pediatric nephro-rheumato team. So we'll run a pediatric nephro-rheumato clinic together. So I think this is a very unique clinic, which is, I think, very few institutes will be having a joint pediatric nephro-rheumato clinic. And we also run the SLE Lupus Nephritis Registry, which is a pan-India registry, and that registry had a lot of publications. Our quizzes, our 2 students, Dr. Shubham Kunti and Dr. Ritodip Nondi, made us immensely proud. So they received, so at the Pedicon PG quiz, they were the runners-up. And also, they were the runners-up at the National Pediatric Rheumatology Conference. So this time, we had the first time a PG quiz for, and at CMC Vellore, they again became the runners-up. This is something close to my heart, team rheumatology. So my first fellow, Dr. Jigna Bhatia, she received a very prestigious fellowship, the Pediatric Rheumatology European Fellowship, 2024. So last year, for a couple of months, she spent time in Italy getting some training. So our second fellow was Dr. Ravali Pratima. Dr. Anindita, she appeared for this year for her exam. So she also received a lot of presentations about papers. This was in NCPR 2026 this year, where Dr. Payal Kundu, she received the second best oral presentation. Dr. Ria, she also presented in the challenging cases. So overall, we received a lot of awards, and these were our publications from the department of, from the unit of pediatric rheumatology. But a very important publication was the 10th one, the Cooper syndrome, so which was a journey of a girl who had recurrent neuromyelitis optica. And then she went on to develop ANCA vasculitis. So we could not correlate what is happening. And then the genetics did the trick. So she was a Cooper syndrome, which is a very, very rarely reported syndrome. And this got published in Kidney International, which has a whooping impact factor of more than 21. And this is our team. We organized a lot of important conferences. So Dr. Jigna organized the West Bengal Pediatric Rheumatology Society conference last year. And this year we organized the Pediatric Immunodeficiency Disease National Conference in Kolkata. So that was our team. Last year we had attended the Pediatric Rheumatology European Society Congress at Helsinki with a lot of posters. And
recently we got also, the institute got the, this recognition as a DIRO, recognition of scientific and industrial research organizations. And we all know that our Vision 2027 remains the new building, so we are all waiting with bated breath for the building to come up. So why ICH matters? It's the only non-governmental pediatric teaching hospital offering fully integrated healthcare facilities at a highly subsidized rate in Eastern India. So this is our team. We continue to walk step by step while challenging miles, and we dream in light years. Thank you.
Thank you, Priyankar. I think we break for a very, very quick lunch. And we will reassemble at 2 and start the sessions from 2. So please do assemble at 2. We will start the session.
No otitis issue or hearing issues, chronic dry cough with occasional wheeze, sneezing attacks, and mild facial eczema. And there is bad family history in the form of allergy, and environmental history is also very bad. So diagnosing a case of allergic rhinitis, the initial treatment with oral fexofenadine and intranasal corticosteroid was started. There was partial improvement in the symptoms, but the cough persisted. So on further investigation, flexible nasoendoscopy showed enlarged adenoid pad not obstructing the postnasal space, and the FEV1 was 62% of the predicted with reversibility, And the FeNO was 25 parts per billion instead of 20 parts per billion, suggesting the diagnosis of concomitant bronchial asthma with allergic rhinitis. So the treatment started with low-dose inhaled corticosteroids with low-dose SABA, SOS, and the child improved. So the take-home message from the first case is that 78% of the asthmatics are having concomitant allergic rhinitis, and 38% of the allergic rhinitis patients are having bronchial asthma. So if we do not treat both, we cannot get the optimum result. So if we are not getting satisfactory result while treating one condition, think of the concomitant other condition. Coming to the second case, a 10-year-old girl presented with persistent nasal congestion, sneezing, and frequent headaches for the past 6 months. So the important point is persistent headache. The patient's mother reported that the patient had a feature or clinical features of allergic rhinitis, but for the last 6 months, she is complaining of headache in the frontal region with heaviness around the eyes. It is mainly seasonal, though last 6 months, the child encountered 2 attacks of this heaviness of the head. The symptoms seem to be worsened during spring and fall. There is also an issue of nasal stuffiness and decreased sense of smell. And she often misses school and her school performance is affected. So that clearly indicates that this child is suffering from severe variety of allergic, moderate to severe variety of allergic rhinitis. Now the past medical history is suggestive of the child was suffering from atopic dermatitis. Though there is no history of bronchial asthma, the family history is bad as well as the social history is not very conducive. So examination showed that pale boggy nasal mucosa with clear rhinorrhea and bilateral nasal polyps. The other systemic examinations are almost within normal limits. Now the diagnostic test, I have deliberately omitted a test that is done for allergic rhinitis is an epicutaneous allergen-specific immunoglobulin E. So that is not done in our routine day-to-day practice. So I am deliberately avoiding that part of the investigations. The other investigations left are nasal endoscopy that confirmed the presence of nasal polyps with mucosal swelling, and the sinus CT showed mucosal thickening with opacification, suggestive of sinusitis, and the endoscopy suggesting rhinitis. So it is a case of allergic rhinitis with rhinosinusitis. Now the question is, if we get a case of sinusitis or rhinosinusitis in a case of allergic rhinitis, are we justified to give antibiotics or not? So usually in each and every case of sinusitis, we give a dose of antibiotics. What is your opinion? Do you give routine antibiotics? No. Ideally, one should not, because even in the nasal scraping of this rhinosinusitis patients show eosinophilia instead of neutrophil, suggesting it is an allergic etiology. And even if there is a purulent secretion from the nose, that doesn't mean that the child is suffering from bacterial rhinosinusitis, because most of those purulent secretion are sterile on culture. And if we treat the patient for allergic rhinosinusitis, the child improves. The sinusitis component include. So the take-home message from this case is that in all the cases of rhinosinusitis associated with allergy, one should not go for antibiotic in the first line of therapy, because only treating allergic rhinitis is sufficient. Coming to the third case. Sorry, Vasudeva. Hey, microphone ta dao na.
Hello. Vasudev Patra Khali.
Now the adenoid is a different issue altogether. Pasudha pore bolbo, ঠিক আছে. So the third case, the next case is, I'm sorry. This is a 10-year-old overweight male presented with persistent nasal congestion, sneezing, itchy, watery eyes, snoring during sleep, daytime fatigue with difficulty in concentration. So signs and symptoms of allergic rhinitis in a case of overweight child having sleep disturbance, snoring and daytime sleepiness. The first case was there was difficulty in breathing, there was snoring, but there was no daytime sleepiness or nocturnal awakening or sleep apnea in the first case. But here it is there. So on clinical examination, the positive finding is pale and swollen turbinates. There is no inflammation. The pale and swollen turbinates are very classical of allergic rhinitis. Clear nasal discharge, posterior pharyngeal wall cobblestoning, that indicates post-nasal drip, and enlarged tonsils. So here the additional investigation done was this polysomnography, which shows there is an index called apnea-hypopnea index. That is normal for children. In 1 hour it is 1 to 1.5, but this child shows that index to be 3. That is, there is more of desaturation in 1 hour during sleep with frequent arousal and snoring. So that is significant. If it goes beyond 1 to 1.5 in children, that is significant. Other investigations are normal, excepting bit lipid alteration. So in this case, we will treat with like allergic rhinitis in the form of oral fexofenadine, intranasal corticosteroid, with environmental control. Plus, here we have to take care of the weight of the child also, because weight management is important in the form of weight loss, physical activities, and nutrition, as well as lifestyle modification. This is a very popular term nowadays it is used. Now, so we have discussed the 3 conditions with allergic rhinitis plus. Now we will try, we have 6 minutes time to go through some common questions in the medications of allergic rhinitis. Why fexofenadine? I have mentioned fexofenadine and intranasal corticosteroids. Why fexofenadine? Because of comparable efficacy for histamine-mediated symptoms, virtually no sedation, and due to negligible CNS penetration, there is no effect on cognition or school performance. Most importantly, the excellent cardiac safety with almost no QT prolongation, minimal cytochrome P450 metabolism, so the drug interactions are very less, and of course, the most important part is good long-term safety and tolerability. Next important question is whether Montelukast, yes or no? Because nowadays we are having preparations on the market, alpha M, beta M, delta M, always an M is there, Bonnie M. So there are a number of M's in all the allergic preparations, and we do not think once or twice before prescribing that whether we should add that Montelukast, whether it is at all required, the Montelukast, in the day-to-day practice of antihistaminics. So let's see what is the status. In 2020, US FDA has added a black box warning on Montelukast. It reported adverse effects on neuropsychiatric symptoms. Have we ever asked the patient after prescribing Montelukast whether he is having irritability, sleep disturbance, nightmare? We have never asked, because we are writing Montelukast along with antihistaminic in a combination right and left. So probably it is not fair to write this Montelukast inadvertently, because it can cause nightmare, anxiety, irritability, aggression, sleep disturbance, depression, and though very rarely there are suicidal thoughts. So you are liable to get prosecuted if there is certain these things happen. Now, the clinical recommendations are not for mild allergic rhinitis. It is not recommended. You have to discuss the potential neuropsychiatric risks with the caregivers before prescribing a Montelukast. And monitoring the changes in mood, sleep, or behavior is important. You have to inform the caregivers beforehand, writing Montelukast. And Montelukast is to be discontinued if neuropsychiatric symptoms develop. So there are few indications where Montelukast can be used. They are allergic rhinitis plus asthma, predominant nasal obstruction, exercise-induced bronchospasm, inability to do some children, they are unable to tolerate this intranasal corticosteroids, poor adherence to nasal sprays, and intolerance or inadequate response to antihistaminics. There it can be tried. Now, role of decongestant. Though they provide very quick relief of nasal stuffiness or blockage, this decongestant, there are two types of decongestant. One is a local decongestant in the form of nasal drops, and one is an oral decongestant. So yes, if there is severe symptom, we are justified to use nasal decongestant for a very short period of time, not more than 5 to 7 days. That causes relief, but that doesn't diminish or decreases the inflammation that is caused by the allergy. It is a purely symptomatic decongestion and relief, not a permanent solution. So it can be used temporarily. The topical decongestant in the form of oxymetazoline or xylometazoline can be used. Oral decongestants, practically no, because pseudoephedrine that has been used in different combinations are not to be used preferably because they can cause systemic manifestations like insomnia, irritability, tachycardia, and hypertension. So there is probably no substitute for intranasal decongestants. The last point of discussion is whether intranasal azilastine versus oral antihistaminics. It has been shown that the intranasal azilastine produces faster symptomatic relief, achieves greater reduction in the reduction scores, provides superior improvement in nasal congestion, improves quality of life more effectively, and has similar overall safety with bitter taste being the main limitation. So if we go by the head-to-head study, intranasal azilastine is a good alternative in allergic rhinitis, but for mild intermittent allergic rhinitis, oral fexofenadine is still the drug of choice. And if it is a moderate to severe or persistent allergic rhinitis, if symptoms persist after giving intranasal steroid, we are justified to use intranasal corticosteroid plus intranasal azilastine combination. So that is there. And definitely fexofenadine is a drug of choice when there is associated ocular symptoms in the form of conjunctival irritation or itching along with allergic rhinitis. There, fexofenadine is a drug of choice. So with that, I would like to conclude my talk. Thank you very much.
Thank you, Dr. Arunal Bhattacharya. May I request, please come down and take your memento.
Thank you. We don't, but bilastine lacks the long-term effect. Fexofenadine is being used for a pretty long time, so the long-term safety has been proved for fexofenadine, not for bilastine. Yes, bilastine is a good substitute for fexofenadine. Yes, sir.
Thank you. So now we start our next session. Our speaker is Dr. Chokhani. Please come. Dr. Rajesh Chokhani, he will be speaking on pediatric anemia and over New Horizons management. May I call Dr. Sneha Agarwal? Sneha Agarwal is here? No, she's not there. Please, yeah. Dr. Chokhani.
A very good afternoon, friends. So in the next 15 minutes, we'll be discussing pediatric iron deficiency anemia, which is a topic which is extremely well aligned with the theme of this conference, which is office pediatrics. So friends, at the outset, I would like to say that this session has been sponsored by CIPLA or Inspira, the makers of Taciron. Now let's quickly look at iron deficiency anemia. We all know iron is an extremely essential mineral required for hemoglobin, oxygen synthesis, and a lot of enzymes in the body. The worldwide incidence of anemia is tremendous in children. Even in the world, in developing countries, it's as good as 40–50%, and so also in India. And our National Health and Family Survey says that as high as 67% and as high as 59% of children in India are anemic. The question that arises out of this is, in your and my clinic, this should translate into every second child being anemic. Are we picking that up? That's the question. So we all know that anemia in mild to moderate cases is pretty asymptomatic. So it is our job to look at pallor in all those children who come for their myriad complaints and pick up anemia and address it. Anemia will be symptomatic in very vague ways, which of course are non-specific symptoms, which we may not, give enough justice to. And severe anemia, because this is chronic anemia compensated, it doesn't come with all those major effects all the time. That's very unusual. So it is our job to pick up the mild to moderate asymptomatic anemia, right? Now there are a lot of factors which are risk factors for iron deficiency anemia, right from premature newborn to low birth weight to multiple pregnancies to mother not having enough iron. If erythropoietin is given in the newborn period, there may not be enough iron to match that erythropoietin requirement as a raw material, and so on and so forth. And in our clinics, we all have seen that excessive milk intake is one of the biggest factors, coupled with either delayed introduction or inappropriate introduction of iron-rich food in complementary foods, besides the fact that cow's milk may have been introduced earlier. So therefore, the key mechanisms that cause iron deficiency anemia as a thought process, first and foremost is reduced iron supply, which is almost always there. Second, of course, is increased demand, which is in the early ages and of course in adolescence when girls start menstruating and even otherwise. Iron absorption has its issues because of lot of dietary inhibitors as well as various salts having their own individual problems. And finally, blood loss, which can be occult due to worms and obvious either due to polyps, etc., or even in menstrual losses. So therefore, friends, what we need to do is how to diagnose iron deficiency anemia. In clinics, obviously we would just look at pallor, look at a compatible dietary history and call it iron deficiency anemia by default. We need not even poke the child for a test. If we were to do the test, obviously we'll have a low hemoglobin and a low mean corpuscular volume and a MCH. We all know that the closest differential to this is thalassemia trait, for which we will look at the RDW. If the RDW is high, it is iron deficiency anemia. If the RDW is normal, it may be thalassemia trait. We need to screen that child. The important thing is many times this is dimorphic anemia. There's B12 deficiency also. So the MCV will get averaged out and you may not get a low MCV, but then your dietary history is something which will easily tell you that this is a dimorphic anemia. So now how do we prevent iron deficiency anemia? As pediatricians in office practice, we have a lot of role here. So during pregnancy, our obstetrician friends do talk of mother supplementation, but the unfortunate fact is 74% of women do not receive that iron as per the National Family Health Survey. Obviously, at birth, delayed cord clamping has been proved to improve iron stores. But because of these various emergency situations, we are all in a hurry and we skip that step of cord clamping many a times, delayed cord clamping. During infancy, exclusive breastfeeding has an edge over a cow's milk because we know that though the iron content in breast milk is less, but it is very bioavailable. and therefore it is very useful for the baby. So we must promote exclusive breastfeeding as much as possible. Then as the child grows older, this is our key role in office practice, anticipatory guidance at the third DTP shot for what complementary foods to start. This is our biggest role in preventing iron deficiency anemia. Of course, later for each subsequent vaccine that the child comes, we should monitor the child for anemia, and we should keep re-emphasizing on the dietary measures and specially monitor the high-risk children that come to our clinic, like a preterm or for any other reason if he or she is high risk for iron deficiency anemia. Because these situations are so prevalent, that is, a diet which is not good enough, the need for iron, even WHO as well as IAP have recommended that we should start supplementing iron right from 6 months of age as soon as we start complementary food. Of course, the supplementary guidelines are weekly, but you and me in our practices can give a small dose daily or alternate day. That is up to us how we choose to do it, but we should do it. So we should be giving iron to many of our children, even prophylactically as a supplement. Coming to management, all the factors of which were risk factors for prevention we have to address. So we have to see that if a baby is on formula, it should be iron fortified, right complementary food, reduce milk intake, and minimize consumption of inhibitors at the same time as iron-rich food. The inhibitors have their own value in diet, that's a separate issue. So coming to the pharmacological management, we have oral iron and parenteral iron. Parenteral iron is used very rarely, so let's look at oral iron. As we all know, we have a lot of iron preparations in the market. Most of them are, the original ones are ferrous, so ferrous sulfate, ferrous fumarate, ferrous ascorbate. Because of the ferrous salt in this, it is directly absorbed, as in it doesn't have to be converted from ferric to ferrous. So that's an advantage. But the disadvantage is that there's a huge amount of ferrous in the intestine. This gives to the effect of free radicals on the intestine. That's why all the side effects of iron are more in ferrous salts. And of course, there is a risk of toxicity. So ferrous sulfate is the cheapest, it is the most widely used, but it has these problems. IPC on paper, iron polymaltose complex, seems to be a good molecule, but in results, in studies which were done to find whether it really converted into a good hemoglobin rise, there are lots of conflicting studies, absorption issues, etc., etc. Colloidal iron is very cheap, but again there's a huge amount of iron. It works in some, it doesn't work in some, and where it works, there is also a risk of toxicity. Carbonyl iron is a metallic, like a only iron which is micronized. It needs an acidic pH in the stomach for it to be absorbed well. And thus you have these salts which are chelated. Iron is chelated with either EDTA or an amino acid to bypass the effects of these dietary inhibitors. So the point to remember is that in all these salts, one, their content may be anything, but you have to look at the elemental content when you are prescribing, and also the bioavailability varies from salt to salt, and it's an estimated bioavailability. So considering all this, a lot of side effects of conventional iron may be there may be poor adherence, there may be treatment failure. Effort was made to make new iron formulations. So there's a clinical dilemma for you and me. Which is the best iron preparation? Actually, standard treatment guidelines of IAP say a very good sentence that there's nothing best. Just see to it that he or she takes it long enough. For which it has to be compatible, the child has to be willing to take it long enough. And what to do when there is no response? You and me feel like investigating for celiac disease or this or that, but often it's just an issue of compliance. So let's look at absorption of iron. What is conventional iron? It is usually in a ferric salt, which is converted to ferrous, and then it is absorbed in the enterocyte. It is taken up by a divalent metal transporter. Now the problem is here in the lumen, all those phytates and tannins and all those form insoluble complexes with the iron, so they inhibit absorption right at this level. Here, this will compete to all the divalent ions like calcium, copper, zinc, others may compete at this level. And then when it comes in, a part of it is stored as ferritin, rest is transported out as a ferroportin. This is a protein called ferroportin, which again brings it out. It is again converted to ferric from ferrous and then taken in by transferrin, which is our protein in the blood. Now, what is the role of hepcidin? Hepcidin is increased in inflammatory states infection and it is decreased in iron deficiency. So, in iron deficiency, hepcidin will be quiet and will allow absorption. But when in inflammatory states, hepcidin makes this ferroportin go inside the cell and destroys it. So, hepcidin prevents iron absorption in inflammatory states. So, now what is liposomal ion? Liposomal ion is a novel formulation where there are two layers, one is hydrophilic, one is hydrophobic, and the ion is kind of incorporated as a micronized thing within these two layers. As a result, it is prevented from gastric degradation, oxidation, and interaction with all the inhibitors in the diet. So, if you look at this absorption diagram again, these are M cells. M cells are microfold cells which are present in the intestine. They are specialized epithelial cells. Their normal job is to pick up microbes and other such agents and present it to the lymphatic and the immune system. Now, because those also have a cell wall of phospholipid, because this also has a phospholipid, this directly is taken up by the M cells, transported without exposing the iron to any mucous membrane. It comes in the lymphatics. From there it is transported to the liver where the lysosomal enzymes break it down and the iron is available. So therefore, initially what is done is encapsulation, then protection in the GI transit, then the intestinal absorption that we just talked about, lymphatic transport and release in the level of the liver. So, these advantages are that it has an enhanced bioavailability, better gastrointestinal tolerability because there is no free iron there, and reduced oxidative stress. So, there are different studies who have said that the bioavailability compared to conventional salts is approximately 3 times more. So, we may need 1/3 of the elemental iron if we are using liposomal iron. There have been various trials to try and support this. So this is a trial in breastfed infants 4 to 6 months. They were checked at 2 months and at 6 months. If you notice the p-value for all the parameters, at 2 months some of them are not great, but at 6 months all the p-values were significant. So the conclusion is that we did get higher hemoglobin, higher serum iron, higher MCH, etc. with liposomal iron in these breastfed infants. Second study is in older children, 295 children. Here again, there was significant improvement in all the parameters, and therefore the conclusion is that liposomal iron does work in older children as well. And finally, this is a study which compares liposomal iron with iron polymaltose complex. And here again, you will look at the two groups, you will find that the results show that the various parameters like hemoglobin, serum iron, etc., the liposomal iron was as good or better than iron polymaltose complex. So it has a better tolerability profile, and therefore it is worth using where children cannot tolerate conventional iron. So now the advantages, as we have already said, are enhanced absorption, improved bioavailability and better GI tolerability. Parenteral iron preparations in office practice we need rarely. We need it only when there is severe iron intolerance, or there is a chronic kidney failure disease child, or there is something where there is very poor absorption of iron like intestinal inflammation, etc. So we will not talk much about that, but it is interesting that there have been trials in such subsets of patients also. So there have been reports of different kinds. So some reports said that it has a dramatic effect on chronic kidney disease patients. Other trials said that statistically the difference was not significant, but nevertheless, this as well as the other trials which said that liposomal iron is not as good as conventional iron, did say that in terms of tolerability, GI side effects, compliance, etc., it did score even in those trials where the other results were believed to be not statistically significant. So friends, to summarize, liposomal iron is definitely more gentle on the GI tract, and it is definitely worth considering when your conventional salts are not helping you for some reason, or even upfront in some of your patients. We can talk about the cost, but the point is even the previous conventional preparations have a wide range of costs. And secondly, the issue of cost is relative, in the sense that if I am sure, as our standard treatment guidelines say, that if by taking a particular form of iron, if a child is likely to take it for longer period and continue taking it, then in the long run I have won the race, so that cost will kind of nullify itself. So in short, friends, do consider liposomal iron whenever you next see a child with pediatric anemia. But more importantly, please pick up every second child with pallor. Thank you very much.
Thank you so much, sir. I would like to invite Dr. Atul Gupta on stage to present the memento to Dr. Rajesh Chokhani.
Yes.
Dear audience, Khabor ICH presents to you the news of the hour. Eminent pediatrician Dr. Jaideep Chaudhary has been accused by a parent of a 9-year-old girl child. Doctors, to be more precise, pediatrician, who is supposed to protect the health and well-being of a child, has been found administering 2 doses of HPV vaccine instead of 1. HPV vaccine, which you know is commonly known as cervical cancer vaccine. All of you know the government has launched this prevention of cervical cancer module where only single dose of HPV vaccine is given. And he himself, the accused himself, has accepted that he has administered 2 doses of HPV vaccine instead of 1. Is it due to some financial profit, or we don't know? The investigation is on trial, and this matter has been taken up by the Justice S.G. Kasi. So His Honorable Justice S.G. Kasi is going to see, and we, Khabor ICH, we are grateful to His Majesty that he has given the permission to live telecast the court proceedings, where the public prosecutor Ritobrata Kundu will cross-examine the accused, Dr. Jaideep Chaudhary. As you can see, already the honorable judge has taken his seat. The public prosecutor is ready to start the cross-examination, and the accused, Dr. Jaideep Chaudhary, has been brought to the dock. So just relax, sit back, and listen to the court proceeding.
So, Your Honor, with the permission of your Lordship, may I start the proceedings?
Yes.
So, Your Honor, you can see Dr. Jaideep Chaudhary, who is a postgraduate pediatrician having highest degree in pediatrics, that is DNB. He's a professor of pediatrics in a very reputed Hospital Institute of Child Health, and he has given a dose of HPV vaccine to a girl child of Mrs. Shen, who is sitting behind. The first dose was given in end of January 26, and the second dose was given at the end of July 26. 2 doses, 6 months apart. Am I right, Dr. Chaudhary?
Yes, sir.
9 years.
9 years.
Yes, sir.
So, Dr. Chaudhary has given 2 doses in a context that he never knew that 1 dose will suffice. It is in April 26 when the ACVPI recommendation was published in the Journal of Indian Pediatrics, which all the registered practitioners receive free of cost every month, both a soft copy and those who call for it, a printed copy also. And it is a very, what to say, it's a very dishonor that how can such a learned person who is a teacher of a teaching hospital is not aware of the proceedings, of the developments which are going on in the fast changing scenario of the medical science. So with this, Your Honor, I'd like to first present the scientific evidences. It was in April 22, first a Kenshi trial was done in Kenya, where they have given 1 dose of 4-valent, 1 dose of 9-valent, and a placebo of meningococcal vaccine to girl childs above 9 years. And they followed it up for quite a long time, and it was seen that the antibody levels of both the quadrivalent and the nonavalent vaccine was comparable. Then the Tanzanian study, also known as the DORI study, was done. And this is a very robust study which involved more than 1,000 girls. They received 1 dose of quadrivalent vaccine, 2 doses of quadrivalent vaccine, 1 dose of nonavalent vaccine, and 2 doses of nonavalent vaccine, and 3 doses of quadrivalent vaccine 6 months apart. So in other words, they have received both single vaccine and multiple vaccines. And they were followed up for certain limit of time. And it was seen that those receiving 3 doses of vaccine, be it nonavalent, be it quadrivalent, and those receiving a single dose, be it nona or be it quadra, has almost same antibody levels. And in fact, the single dose vaccine has shown a very much comparable, and in certain cases even higher than those given twice or thrice. So that proved that single dose vaccine is good enough for the children. Finally, our own Indian IARC study was done. And it was done in India itself, where they have a follow-up period of 12 years. And they have all sorts of cases. Children between 9 to 15 years receiving 1 dose, receiving 2 doses of both quadrivalent, nonavalent, everything. And they followed up for 12 long years. And it has found an excellent result. And besides that, numerous trials by that time has come. And my question to your Lordship, how a person who is being a teacher, who is being an MD teacher, who is going to train the nascent minds, is not aware of the major change which has occurred in the vaccinology field. He is accused of giving 2 doses only, while 1 dose would have been sufficed. So this is the scientific evidence. You want to ask anything to Dr.?
Yes. Dr. Jaideep, you have been accused of giving additional dose of a vaccine, 2 doses where 1 would have sufficed. Do you have anything to say in your defense as to why you did it?
Me, Lord, I am quite distressed and shocked to stand in front of you. But it's fact, yes, that I have given 2 doses in good faith. I have been practicing for about 40 years. I practice in a very remote Sundarban area. And I try my best to keep updated with whatever is happening, sir. And I do attend conferences. Well, in January, I attended conferences, and there I received the guidebook on immunization, which were the latest and my Bible. So I swear in the name of these guidebooks that I tried to follow it. Then this accusation came. My Lord, I went through the product inserts also. You can also take it from me. And there also, sir, I did not find any alteration of the doses that has been mentioned. And these are all DCGI licensed vaccines. Sir, with good faith, I followed all this. I am sorry, in my practicing area, the internet connection is not stable. I do not get any hard copy of the journals, and it's not possible for me to always look into the soft copies. So I followed. So the practice that was valid in January, where children used to receive 2 doses of HPV vaccine. Sir, with due respect to your chair, I beg to appeal that how can it cause harm in February? Because we have been giving 2 doses since then. Yes, sir, I am aware that DCGI has approved single dose. But sir, again, DCGI approves 2 + 1 dose of pneumococcal vaccine, whereas ACVIP discourages the practitioners to follow the 2 + 1. So I am confused, sir. My Lord, with good faith and following the last publication and recommendations from our esteemed academic body, I followed. And I beg your honest justice in this matter, sir. That's all my disposition.
Anything else the defense would like to ask?
The second aspect which I would like to point it out to your lordship is what is the social impact of such a misgiving. You all know cervical cancer is one of the most common cancer death in women. Every 7 minutes in this country, India, 1 woman is dying. It is equivalent to every day a Boeing 707 with only lady passengers are crashing. So much so is the burden of the disease, and unfortunately is the disease in middle and low income countries. And this is a disease which is almost 100% preventable. One of the ways of preventing the disease is to do a cervical screen. But unfortunately, the cervical screen is almost non-existent in our country. So many doctors sitting in the audience, lady doctors, I can vouchsafe that a very few of them might go for cervical screening. So it is almost non-existent.
Objection, my lord. The screening doesn't come for a 9-year-old girl, sir.
No,
Yes.
I'm
So
telling
I think
about
we are
the disease itself, not a 9-year-old girl. Screening is done at the age of beyond 30s and again at the age of 40s. So the only way to prevent this is by giving a vaccine, because screening is not here. That's the thing I wanted to tell. And the vaccine, why the vaccine is not that much popular? Because it is not being advocated by Government of India. It is not still included in the NIP, National Immunization Program, but it is available in the private market. The only deterrent to taking the vaccine is its cost.
Milord, I think the council is not well prepared. I have already told you that, confessed that this is being given by government, and our question is not that. Kindly understand the gravity of the situation and let us stick to the point, sir.
Thank you. I have heard the accusations of the...
No, what I want to say, because 2 doses has been given, it costs round about more than 20,000 rupees or nearly 20,000 rupees. So, the prevention which could have been done by spending only 10,000 rupees has been done with 20,000 rupees. What effect it has on the mind of the parents? The parents, when Mrs. Sen came to know that 1 dose could have been sufficed, the question will first come to her mind, on whom I have given to take care of my child's health. Is this a doctor or a shark? Has he come to serve my children, to protect my children, or to mint money? Not only that, if you give such sort of thing happens, the population or the parents' faith in the vaccinology also diminishes. They always see vaccines with a little bit skewed view. They will see these vaccines are not that necessary, but these vaccines are mainly promoted by the doctors and the companies to make money rather than protecting the health of the child. So this is the very important social impact, my lord, and I'll come to my next topic after that.
Okay. Having heard the accusations by the prosecutor and the defense of the accused, we now have a situation where a doctor who claims that he cannot be up to date because of his location of practice and lack of internet connection to know the latest, has followed a recommendation which is not current. We must remember that vaccinology is an ever-evolving branch. Recommendations change, and as practitioners, it is our duty to be up to date in the recommendations so that we can offer the best to the child who is brought to you specifically for preventive medicine. Now, the accused has administered 1 extra dose. The implication says a second time pain for the vaccinee, extra expense to the parents, the effort and time lost in leaving their work, coming to the clinic and having the injection taken, all this has to be taken into consideration. With this in mind, the court now pronounces a judgment.
Sir, before pronouncing a judgment, I have another argument, if your lordship allows me.
I would request the public prosecutor not to interfere when the judge is speaking. You now have permission to continue, please.
So, if you see Mrs. Sen, who is sitting at the back, is a working lady. She toils hard so that her family runs well. She works hard, going out from his house at 8 o'clock in the morning and coming at 8 o'clock in the evening. Because of only one simple thing, that her house runs well. Her children get good education and they can enjoy an enjoyable life. It is not something to wonder if I think taking a second dose of vaccine, she had to forego one good dress for herself or her family. She had to forego one good dinner at a good restaurant to take this second dose. But she had spent so much money in something which was not at all required. And moreover so, you know, as the Honorable Judge has rightly said, vaccination in adolescence is a very tedious process. Their fear psychosis is much higher as compared to others, and that's one of the reasons syncopal attacks during vaccination in adolescence is so common. They have fear, they have panic. So, not only the economic thing, but also this psychosocial problem is also there. So, I'd ask His Lordship to consider this crime on three aspects: scientific aspect, social aspect, and economic aspect, and then give his judgment.
I think we have heard enough of arguments. It's time to deliver the judgment. Already the prompt has come from someone in the audience. Okay. As I said earlier, it is essential to be up to date. The accused has put forth a point in his defense that the product insert still states that 2 doses have to be given. We must remember that a product insert will never change unless the company themselves do a study for altered schedules. And that's never going to happen. So that does not absolve the accused of the responsibility of being up to date in the practice of vaccinology. With these in consideration, I hereby pronounce my judgment. The accused is guilty of administering an extra dose, causing unnecessary pain and additional expenditure to the parents. Considering his long years of practice, unblemished practice, the court will not take a very serious view of this aberration that has occurred in his career. The court directs the accused to apologize to the parents and the girl. If necessary, compensate the parents for the additional expenditure. And the court also hereby orders the accused to attend at least one CME every month in vaccinology. And after 6 months, he should come here and give a lecture on recent updates in the practice of vaccinology to all of us. The case is now closed.
I accept, sir.
So thank you, dear audience. You have seen the court trial directly. The judge, the Honorable Justice has given his verdict.
I hope I can remove this now.
The Honorable Justice has given his final verdict that the accused has been found to be guilty, but of course, he had certain problems. He could not get the updated knowledge. So it's a thing to all the doctors that everyone should have an updated knowledge. And so this entire court proceeding was brought to you by Khabor ICH. Follow us at Khabor ICH to get all the latest news on child health. Thank you. News channel.
So thank you so much.
News
With this, as Honorable Dr. Kasi has told you, we must all remain updated. So the next 40 minutes of our vaccine session will be quiz-based, interspersed with some questions. So may we have the Mentimeter QR code and the Mentimeter number, and I request all of you, you please log into the Mentimeter and let's update ourselves so that the next summer CME or the next office practice CME, you don't have to stand here. So there are 66, I think there are hundreds, so please come on. Sir, you may sit here, no problem.
It's all right?
Yeah, no problem.
Sir, you can sit.
Let's be in the center, sir. That's intentionally we can. People can see. So are you ready? We will come. I think many people are joining. So by that time, people join. I would just like to ask Dr. Kundu, If you can just have one question, and then we will continue with the Mentimeter, because people are joining still. So Dr. Kundu, HPV is a vaccine which is often called a cervical cancer vaccine. And it's mainly used for girls and women, as you have told. It's for a long time. And recently, the male vaccination has been introduced. So what's the rationality of male vaccination?
So if you see the prevalence of HPV infection in men, is it much higher as compared to women? Number one. Number two, woman who is infected by HPV on sexual debut, by the time she reaches 30, 35, 40 years, most of them, they are going to clear the infection. But in men, persistence of the infection goes on for a long time. So number 2 point is persistence. Number 3, very few of the men after natural infection do seroconvert. That means they develop antibodies. Very few. And even if they develop antibodies, the antibodies are of very low level. So much so, even the seroconverted men can have another infection with the same HPV. This is number 4. Number 5 is that the transmission of HPV from men to women is much lesser than women to men. Number 5, we have screening program for cervical cancer, for breast cancer, but we don't have any screening program for oral cancer, anal cancer, penile cancer or rectal cancer, which is caused by HPV. And thirdly, the infection spreads from men to women and women to men. To break the cycle of this infection, if you give gender-neutral vaccine, that means both to male and females, then you are going to prevent the spread. So these are the 5, 6 or 7 important points why the vaccine should be given in boys also.
So can we have the first question, please? So now that you have been primed that male vaccination is essential, so let's face the first question. A 14-year-old boy has come for HPV vaccination. Which is the correct answer? The quicker you answer, the more points you get. You are all familiar with Mentimeter. I'm not reading the answers. One is, should I read? Okay, number 1 is not licensed in males. Number 2, single dose. Number 3, 2 doses, 0 and 6. And number 4, 3 doses, 0, 2, and 6. You have 5 seconds more. Ha. Well. Yes, Dr. Kasi?
Yes. This is what I said, you have to be updated. Okay. Now, the world is moving over to a one-dose schedule. The ACVIP in 2025 has come out with a recommendation of single dose for girls between 9 to 15 years. But for boys in our country, the recommendation is still for 2 doses for boys between 9 and 15 years. Above 15 years, it's 3 doses. Immune compromised, above 9 years, it is 3 doses. So the correct answer is 2 doses, 6 months apart.
Well, Dr. Kasi, the single-dose HPV vaccine recommendation for girls by ACVIP does not specify any particular HPV vaccine. And are we justified in using single dose for all HPV-4 and HPV-9?
Well, this is a question which needs a lot of thought. All the studies that have been conducted with 1 dose are on vaccines which have proven efficacy studies. The WHO has come out with a position statement that vaccines which have been licensed based on non-inferiority to another HPV vaccine which have an efficacy can be eligible for a single dose administration only if they demonstrate sustained non-inferiority for at least 2 years. Okay? So now coming to the practical issue, we are talking about the Serum Institute vaccine. Can we give it in a single dose? They do not have any published data about the non-inferiority, but what I'm given to understand is the first year they have demonstrated non-inferiority. The second year study is almost going to come to an end. The WHO pre-qualification process is on. Once WHO pre-qualification occurs, it will be eligible for 1 dose. So strictly speaking, from a technical point of view, as of now, the 1-dose schedule should be used only for the Gardasil 4 and Gardasil 9 of MSD and not for the Serum Institute. This may be the situation only for a couple of months. Once the pre-qualification occurs, even that vaccine can be used in a single dose.
Thank you, sir. Again, another confusion is that regarding the scheduling of HPV vaccine, there's recommendation of ACVIP, FOXC, DCGI, CDC, product insert. It all differs.
Yes.
So, are we justified in using any of this schedule, or we should select a particular one as pediatrician?
As pediatricians, I think we should follow the ACVIP schedule for uniformity across the country. And we just told you, the schedule is girls 9 to 15 years, single dose, boys 9 to 15 years, 2 doses, 0 and 6 months. The minimum interval between the 2 doses should be 5 months at least. Above the age of 15 years and immunocompromised, it is 3 doses, 0, 2 and 6. The minimum interval in a 3-dose schedule, the minimum interval between dose 1 and dose 2 should be 4 weeks. Between dose 2 and dose 3 is 12 weeks. And between dose 1 and dose 3 should be at least 5 months. I think we should all stick to this particular schedule.
Thank you, sir. So now a lot of discussion has been going on a vaccine which is yet not available, dengue vaccine. We are getting information from the social media and from the media. But let us get something cleared. Can we have the second question, please, Mentimeter? So the Q-dengue vaccine, which has been licensed by DCGI, which of the following is the licensed age group as per DCGI? As per DCGI. These are the choices. Four seconds more. Yes, sir, 4 to 60 years.
I think the audience is really very eager about the vaccine and have done a lot of reading. The vast majority have come out with the right answer. In our country, the DCAG has approved it for use between 4 and 60 years of age.
Absolutely. Dr. Kundu, do we really need this dengue vaccine for India? Because there is a lot of variation regarding serotype across the country and also seasonality. Recently, we did not have many cases in our part.
Dengue is such a disease which occurs across India, excepting perhaps in those places which are above 5,000 feet height, because mosquito is almost everywhere. And dengue is a seasonal disease. So what happens when a dengue outbreak occurs? It overwhelms the medical system. And everybody knows that there is no medicine against dengue. So all the parents, they want their child to get admitted. And this causes an acute crisis of bed. And the parents run from pillar to post to find a place for their children, even if they don't require. This is number 1 point. Number 2 point, as I've told you before, it does not have any therapeutic medicine. Only prevention of mosquito can bring down dengue. But prevention of mosquito would not be possible in the very past, near future also, because Wherever there is water, there will be mosquito. Number 3, not only we require a dengue vaccine, because the serotypes, the 4 different serotypes varies from place to place in the same country. The serotype 4 is common in South India, but not that much seen in Eastern India. So we need a vaccine which will give cover to all the 4 serotypes. So it is very important to have a dengue vaccine, which is a felt need. Parents often ask you proactively, even before you talk about dengue, do you have a dengue vaccine? So that's the reason why you definitely need a dengue vaccine.
So why can't we just combine the 4 serotypes of dengue vaccine? Just like, say, the pneumococcal vaccine, we have 10, 13, 14, 20. So why we can just combine the 4 serotypes?
Attenuating the 4 serotype does not remove their speciality. If myself, Joydeep, Dr. Kashi and Kukreja is kept in the same room, giving the same food and giving everything same, but still we differ among each other. So this is known as serotype interference. One will thrive more than the other, number 1. Number 2, there will be always an imbalance between the antibody produced. And you know, in dengue, the protection is homotypic. That means the antibodies to a particular serotype will occur against that serotype. So if you want to have equal amount of antibodies to these 4 serotypes, it won't be possible because one is going to interfere with other. But if you don't ensure that the antibodies level must be same, then again we can have antibody mediated enhancement in dengue as we have in the natural infection. So it is never possible to simply attenuate and combine the 4 vaccines.
In fact, in 2011, there was an experimental dengue vaccine by Aventis Pasteur. This was again 4 attenuated strains joined together. And in the trial, they found a very high incidence of fever, rash, thrombocytopenia in the vaccinated cohort. And that was because there was a very high virium dengue serotype 3. So then, of course, that vaccine was given up. Now, when you have a chimeric vaccine, the attenuation occurs of the base. So all the 4 serotypes have the same degree of attenuation. You don't have to attenuate each individually. That's the reason why the chimeric vaccine is now the preferred platform for all dengue vaccine. But having said that, other platforms are also being investigated.
So I'd like to ask Dr. Kasi a very important question. Currently, there are 3 dengue vaccines in the world. One is Denvaxia, which is manufactured by Sanofi, which is licensed in some countries, not in our country. Another vaccine, which is produced in Brazil, Butantan. And another, which is produced by Takeda, Qdenga. So may I ask Dr. Kashi, the first 2 vaccines has been fallen into disrepute, how they are prepared and why this thing has happened?
Okay. Let's come to the first vaccine, Denvaxia. That was a vaccine by Sanofi. In that, the backbone was the yellow fever 17D strain. They removed the PRM and M proteins and inserted of dengue 1, 2, 3, and 4, and then you had a tetravalent live attenuated dengue vaccine. 2 large phase 3 studies were done in Asia and Africa, the CYD14 and CYD15. In that study, they noticed an increased incidence of hospitalization due to severe dengue, especially 3 years after the vaccination. It was most obvious between 2 and 5 years of age, but also to some extent till 9 years. In fact, the risk of hospitalization was almost 7 times higher in those between 2 and 5 years. So that's why that vaccine came for recommendation for use above 9 years of age. Remember, this vaccine in the phase 3 studies did not study what was the differential efficacy and adverse effect profile in the seropositives and seronegatives. Only 13% had serology data. Subsequently, Sanofi developed an method to differentiate the NS1 induced by the vaccine and the NS1 induced by the infection. They went back and looked at all the samples that they had. And what they found was that irrespective of the age, there is an increased incidence of hospitalization in all seronegatives. Based on that, the WHO came out with a recommendation that only this vaccine should be given only in those who are seropositive or where there's a recent population survey which shows at least 70% seroprevalence. You know, the public health utility of this vaccine plummeted. And in fact, now Sanofi has stopped manufacturing the vaccine. It's no longer available today. Now, the Butantan vaccine is something that is a little newer, compared to even the TAC 003 or the Qdenga. That is also a chimeric vaccine, but slightly different. In the dengue 1, 3, and 4 have mutations. The dengue 2 is a dengue 4 backbone in which the dengue 2 PRME and M proteins have been inserted. In phase 3 studies done in Brazil, it showed good efficacy even against the seronegative. Subsequently, it was licensed for use in Brazil. Over 500,000 doses were given. In the post-marketing surveillance, they found that there were about 42 cases of dengue, of which 4 were severe, of which 3 died. Based on this data, they have now just withheld the utility of the use of the vaccine in the National Immunization Program, pending investigation. See, because it occurred does not mean by definition it is an AFI. It is temporally related. It has to be established whether it is causally related. So pending further investigations, the use of the vaccine has been kept on hold. So this is the status of the other 2 vaccines. Fortunately,
in this respect, I would just like to put a corollary. I mean, now
Yeah.
you'll be explaining the Qdenga. So what was the DCGI stand about inclusion of giving license to Qdenga? The studies in India specifically, if you can add also.
See, as far as any vaccine is concerned, the adverse effect profile also varies according to geographic location also. So the DCGI has approved Qdenga for use with the caveat that extensive post-marketing surveillance has been done for safety and efficacy for 6 months to 2 years. That's a caveat, and that will have to be done by the vaccine manufacturer.
Okay, so can we have the next? We move on to another vaccine, and there's a lot of discussion, lot of scope for discussion on the pneumococcal conjugate vaccine. So the next question in Mentimeter I would like to put to the audience. Yes. Which PCV? We have PCV 10, 13, 14, and then 20. Which PCV does not contain serotype 6A? Your answer, please. Glass tin. Yes, more answers, please. Faster finger. 8 seconds more. Which does not contain serotype 6A? Because most of the discussion is based on 6A when we have any controversy. Yes, 113 people have PCV 14, but again, 68, they have answered PCV 10. So, Dr. Kasi.
Yes, the correct answer is PCV 14.
So, how important is 6A?
Yes. Now, if you take the structure of 6B and 6A, only one hydroxyl atom, OH atom, is in a different position. There are a lot of structural similarity. Antibodies, anti-6B antibodies neutralize 6A. Even the OPA induced by opsonophagocytic antibodies of 6B also neutralize 6A. but you require 6 times higher titers. So when you have a 6A containing vaccine, you're going to have much higher titers. So that is as far as the lab, immunology. What has happened following rollout of the vaccine? USA began with PCV7, which did not have 6A but had 6B. The incidence of 6A reduced by 91% by 7 years. Even the herd effect was to the extent of almost 58%. That means it worked really well. Similar data has come from Germany. European countries which use PCV10 of GSK, 6A almost disappeared. But this may be even geographic specific. South Korea reported an increase of 6A. Brazil reported an increase of 6A. Certain states, areas in Spain also reported an increase of 6A with a 10-valent vaccine which did not have 6A. So we are not very sure that protection will definitely be there. Ultimately, I think in 2024, there was a large meta-analysis called the Serenade study, which looked at the impact reduction in IPD overall, and they found that the reduction was almost similar in both the PCV10 and the PCV13 using country. When I'm talking of PCV10, I'm talking about the GSK, not the Serum Institute. Okay. Now, so I think the balance is almost like as if 6B works pretty well against 6A. But this 6A and 6B have got two not very well-known siblings. They are 6C and 6D. 6C also causes IPD and antibiotic resistance. Countries using 6B containing vaccine reported a definite increase in 6C, whereas countries using a 6A containing vaccine did not demonstrate any increase in 6C. So the corollary is that 6B cross-protects against 6A but not 6C. 6A cross-protects against both 6B and 6C. So taking all these things into consideration and the fact that direct protection is always superior to indirect protection, it is desirable to have 6A in a vaccine because 6A causes pneumonia, otitis media, IPD, and is also responsible for a significant number of antimicrobial resistant strains as well. So it's good to have 6A in a vaccine.
So I think that summarizes all regarding the controversy of pneumococcal conjugate vaccine. And definitely we are looking forward to the 20-valent vaccine maybe next year. Can I have the next Mentimeter question again for the audience? So please be fast. This is the last Mentimeter question of this session. A child on vacation gets scratched by a wild monkey, and it's such a place where immunoglobulin or monoclonal antibody is not available. So how do you manage? Yes, 10 seconds more. Yeah, I think it's fantastic, Dr. Kasi. Your comments.
Wonderful. The textbook answer is start ARV. RIG can be given up to 1 week after the first dose, provided he can go to a place where RIG is available. But in case RIG is not available, then even the other option of giving 2 doses on day 1 at 2 different sites also is a alternative which one can consider.
So the first option that monkeys do not transmit rabies is false. Because all the mammals, they do transmit except the domestic rats, guinea pig, all they transmit rabies. So that we cannot accept. And well, if RIG is not available, then definitely we have to start the vaccination. So Dr. Kasi, now WHO recommends post-exposure 4 doses, pre-exposure 2 doses, ACVIP, and also the recommendations in India is that 5 doses of post-exposure, 3 doses pre-exposure. So, I mean, why this discrepancy?
Okay. A 5-dose post-exposure prophylaxis was the standard for many, many years. Subsequently, USA had a very severe shortage of rabies vaccine. I mean, the concept of 4 doses began from there, where they investigated, and subsequently WHO also entered into it. And they found that the protective efficacy and the increase in antibody titers between the 4th and 5th dose is very negligible. So they came out with the recommendation that a 4-dose post-exposure prophylaxis is sufficient. That is day 0, 3, 7, and 14. 28-day dose is not necessary. In fact, looking at the WHO recommendation, the ACVIP also in 2018 recommended a 4-dose. But ultimately, there has been a lot of hue and cry. The National Regulatory Authority, which is the NCDC recommendation, still stands at 5 doses. They have stuck to 5 doses because they do not have sufficiently robust data from India to vouch for the 4-dose schedule. Now, to synchronize with the national schedule, the ACVIP also has changed back to a 5-dose schedule. And I am given to understand that NCDC is also looking into a 4-dose schedule, and maybe in the very near future we may have a 4-dose schedule. But as of now, we should follow the National Regulatory Authority, which says 5-dose schedule. And especially for a condition like rabies, which is invariably fatal, 1 more dose doesn't matter too much, but it should not be 1 dose less.
That's right. So my question to Joydeep, those who have pets in their house, especially if they have children too, they often get frequent licks and bites. So how frequently do you need to administer re-exposure prophylaxis?
No, there is no consensus on this. Number 1, the pet should be regularly vaccinated. Number 2, children having pets should be given pre-exposure prophylaxis. Regarding re-exposure prophylaxis, now if the pet is confined, doesn't come into contact with stray animals, then they are relatively safe if they are given proper vaccines. If the pets are coming in contact with the stray animals, then it's a difficult situation. Then you do not know, because the pet vaccines do not give 100% protection to the pets. So they can transmit rabies. But considering the fact that it's a very tricky situation, maybe, say for the animal handlers or who are working in the zoo, there either the antibody titer is done regularly, maybe yearly, which should be above 0.5 international unit per ml. That's not practical for all the household pet owners. So there the recommendation is yearly vaccination. But maybe, as some of the experts opine, every 3 to 5 years, 1 booster may be given if you have pets. Any other opinion, Dr. Kasi?
No. There is no recommendation. There are definite categorization of rabies exposure risk. And households having pets is not considered as a high risk at all. Of course, these recommendations have come from the US CDC, which is actually a country which has a very low incidence of rabies. India is hyperendemic for rabies, so we got to have different standards. Now, if the pet, as Dr. Jaideep said, is completely supervised and has no contact with other dogs, stray dogs, I think one can be quite confidently say that repeated re-exposure prophylaxis is not necessary. But in a condition like rabies, where there is even an iota of doubt, we have to stick to the rules and give every re-exposure prophylaxis after every exposure, if it is more than 3 months since the last vaccine schedule. And when we talk about 3 months, it is 3 months from the date the schedule began, not from the day the schedule ended.
So there are a lot of scopes of discussion on
Yes,
rabies. Let's
yes.
not go into further. It's never ending. I would like to go to another vaccine for Dr. Kundu. There is a never-ending conflict between the acellular and wholesale pertussis vaccine. It's like who controls the Hormuz Strait. Now, what happened in 2010 and 11 to raise the storm about pertussis resurgence, Dr. Kundu, And what's the TH1, TH2, TH17 response that is discussed so much? And what's the controversy of IgG2, IgG4 response by acellular vaccine? And also, is ssRNA in IPV containing acellular pertussis combination vaccines acting as adjuvant to skew the AP response? And what's your final say about hexavalent vaccine? In very brief, if you could explain.
It was in 2014 who reviewed 19 high and middle income countries about the resurgence of pertussis. And they found there was not a widespread resurgence. But there was some increase in the number of pertussis cases, but these are not due to vaccine relation. Number one, people became more aware of the pertussis. Number two, the diagnostic methods has improved drastically. Previously, it was impossible, almost impossible to diagnose pertussis. Now, pharyngeal swabs can be done, PCR is easily available, and you can diagnose pertussis more. So that was one of the reasons why it has increased. But looking at it further, very closely, there was some increase in 5 of the 14 countries, namely USA, UK, Australia, and Portugal. All these countries has used acellular pertussis. But there was also increase in another country, Chile, where wholesale pertussis was used. Now, in case of acellular pertussis, what you are using a highly purified antigen bound to an aluminum adjuvant. Because the antigen is highly purified, it is not recognized by the dendritic cells as other PAM. PAM means pathogen associated molecular pattern. So what the dendritic cell recognize is the adjuvant. And this causes slight skew in their response. When these dendritic cells goes to the T helper cells, they develop into TH2 and TH17 cells. The TH2 is mainly for parasitic infection. So instead of having more macrophages, the eosinophil they have. And number two, in those TH17 cells, they produce an IgG, which is neutralizing IgG. But when a wholesale pertussis was given, the germ contains PAMP, which is very easily recognized by the dendritic cells, and they give rise to TH1 and TH17 response. And there, the antibodies, G1 and G2 antibodies are made. These are all opsonizing antibodies, high quality antibodies. And the macrophages were stimulated so that they can engulf the pathogen and destroy it. But again, these studies were mostly done in animal models. The net effect that if you give a wholesale pertussis vaccine, a acellular pertussis vaccine in an animal, the animal is protected, but the animal, though himself will not suffer the disease, but he can pass the disease to others. Then came another study in the mouse, where they have combined acellular pertussis with IPV, that is injectable polio vaccine. The injectable polio vaccine contains ssRNA, and this ssRNA can stimulate the dendritic cells and make the response instead of TH2, TH17 into TH1, TH17. So the whole thing changes, goes just like wholesale pertussis. But the ultimate point is that no matter whether you take wholesale, acellular, or you have a natural attack of pertussis, after some time the antibody starts declining. So the only way to ensure prolonged protection against pertussis is to take the vaccines in right time in the second year, before school entry, and at the age of 10 years. It is to note that none of the countries who has used acellular pertussis has switched to wholesale purchases, even though there are so many reports flooding the market that the wholesale acellular purchases, the decline in the antibody occurs much faster and much to a lower level. So the ultimate take-home point about the hexavalent vaccine is that the countries who are using acellular, let them use acellular. Countries who are using wholesale, let them take wholesale. And you as a private practitioner, I think you should offer both the vaccines and explain the parents the importance of taking all the vaccines right in time. That will ensure proper protection, no matter whether you take wholesale or you take acellular.
So any brief comment from Dr. Kasi?
Yeah. See, we must remember that acellular vaccines came into existence because of the perceived reactogenicity of wholesale purchases vaccines, and not because wholesale purchases vaccines were inferior in protection against pertussis. Immunologically, the wholesale pertussis vaccine is far superior to the acellular. Right from stimulation of the innate immune response, wholesale vaccines have lipopolysaccharides that get attached to TLR4, and that skews the response to Th1 and Th17. Acellular, as I said, is highly purified. It needs an adjuvant. Adjuvant is alum. Alum works through something known as the inflammasome, and that skews it towards a Th2 response. Even if you look at the subtype of IgG antibodies, WP produces both IgG1 and IgG2. Even acellular does the same. But with every subsequent dose of AP, IgG4 becomes more and more. And IgG4 is a tolerogenic. It does not help in any way in protection. That's why the protective efficacy of acellular pertussis vaccines reduces with every dose administered. And one other thing is about the tissue resident memory cells. These are the first line of defense in the lungs. WP vaccines, very potent stimulant of TRM17, and they persist almost lifelong, whereas AP vaccines do not. Even talking about reactogenicity, the Western world was using a 2, 4, and 6 schedule. England was using a 3 months, 5 months, and 11 months, and WP was far more reactogenic than AP. They were using both. Then they changed over to a 2, 3, 4 month schedule, and when they, with this shortened schedule, they found that the reactogenicity was almost similar for both. And in our country, we're using a 4-week schedule, which should reduce the reactogenicity. So I think even from the reactogenicity point of view, considering our schedule, the difference should not be too much.
Okay, sir.
So now we have a very important vaccine, that is the typhoid conjugate vaccine. May I ask Jaideep to start with ACVI recommended 2-dose schedule. Why did it change to 2 single dose and now 2 doses? What is the ideal time to give a booster dose if at all we need it?
See, the Pediatype was launched in 2008, and then ACVIP or IAPCOI at the time recommended 2 doses of typhoid vaccine. And then the TT conjugate vaccine came, which is the Taiba TCV. And they had sufficient data to show that the immunity persisted beyond 3 and 5 years in different cohort. They had cohort from 6 months to 23 months, and then from 2 to 45 years. So there the persistence of immunity was good, 3 to 5 years. That's why the recommendation of a single dose came. And then there was the discussion about the natural boosting in countries like India. But recently the SAGE has come up with a recommendation of booster typhoid vaccine, especially those who have received the first dose before their second birthday. So there is a need for a booster. And the recommendation is booster is given better at a gap of 2 to 3 years. And there are some studies which has shown that, yes, there is definite reduction in the antibody titer, and Indian study also by Krishna Mohan and all, where there is decreased antibody titer. So that's why the reason. So the first dose being the endemic country has to be in 6 years, but 6 months, I'm sorry, and the second dose at a gap of minimum 2 to 3 years. So I would like to briefly go to another vaccine, Dr. Kasi, just to end with, that meningococcal vaccine, which is mandatory in most Western countries for special university admission. Is it time we should advocate for all in our practice?
In the Western countries, especially USA, they have two peaks of meningococcal disease. One is between 1 and 3 to 5 years, and the second peak is in adolescents. There is a significant burden of the disease, and hence the recommendation for adolescent dose, especially between 11 to 18 years. That's why most of our kids who go to US for studies take a meningococcal vaccine. Coming to India, the baseline incidence of meningococcal disease is around 0.76 per 100,000. The WHO has said that unless you have a level of at least 3 per 100,000, there is no need for regular meningococcal vaccine administration at the population level. Most of our meningococcal disease occur in infants. During outbreaks, it occurs in a little higher age children, but rarely do we have significant cases in the adolescents. So I don't think the recommendation for a routine adolescent dose in our country has any merit at all.
So my
last question and
question to end up the session.
Brief answer.
RSV, monoclonal antibody, nirsevimab, is it specifically meant for the preterm infants, or should we give in all infants?
Okay. The standard recommendation is for all infants, but the need is much more for preterms. Now, almost around 25 to 30% of hospitalized RSV is in preterms. But about 65% of all hospitalization is in term newborns and those who don't have any comorbid conditions. The rate of hospitalization in preterms is about 14.5 per 1,000, goes as high as 39 per 1,000 in those who are around 28 to 30 weeks, and goes almost to 100 per 1,000 in those who have BPD also. So as far as preterms is concerned, I don't think we should have any reservations about administering monoclonal antibodies, RSV. The issue is, what about term infants? It's very expensive. It works only for 6 months. In India, we don't have that strict seasonality as far as RSV, like influenza. When are you going to give the vaccine? Are you going to give it at the time of birth, or will you give it a few months before the peak incidence of RSV activity, which is during the monsoon months? We don't have much data about peak hospitalization. In fact, one study called the Mahan study done in Maharashtra showed that more hospitalization occurred in the second half of the first year compared to the first year. We also have a significant burden of RSV hospitalization in the second year. How much is it going to protect? These are all ifs and buts. So that is why the ACVIP has recommended all preterm, yes. Full terms, the need is not so acute, but one can consider giving it on a one-to-one basis after discussion. Remember, it costs around 40,000.
So thank you so much. Sir, please stay back. So vaccine session is never ending. Maybe we will have on some other occasion. But let's get the result of the Mentimeter quiz, and please, yes, the first prize goes to Aniruddha Ghosh. Aniruddha, please come up. Second prize goes to Prashanjit Mondol, and the third to Shumon. So please come up. First prize. So, Aniruddha. Aniruddha, may please come. If you are not there, you miss the prize. So may I request Prashanjit Mondol to please come? Yes, great, sir.
Oh.
And also Shumon, also please come.
Hello, good. Come. Come, sir. Come.
Aniruddha কোথায়?
Sir, please give it to him.
Are you here, Aniruddha? So with this, I must thank Dr. Kasi. So he has been enlightening us since ages, and Kia, you may also come. Since ages, and
Thank you. Congrats.
it's a pleasure to. It's a pleasure to have Dr. Kasi with us. Again and again and again, we myself updated. And with this...
Aniruddha has come.
Oh, yes.
So at last, Aniruddha has felt the need of getting a prize.
Come. Yeah.
We will go out. Thank you. So we will go out for the memento session, and let's we will remove this and and you please start the next session.
Next session start.
Next up, I would like to request moderators Dr. Rajiv Sinha and Dr. Deepanjana Dotto to kindly come up on stage and moderate the session on rare but real cases of nephrogenetics. And presenters for the session are Dr. Shakil Akhtar, Dr. Deblina Dasgupta, and Dr. Shangjukta Poddar.
I hope I am audible. So because we are running late, and secondly because we will be dealing with nephrology, which many people don't like it. You see, half of the hall is leaving. So I will start quickly.
Can we have the slides? Can we have our slides?
So basically, like what we thought, and for that I am grateful to Apurva sir and the ICH leadership for giving us the opportunity for showcasing few cases from nephrogenetics. As soon as we have the slides, we will start. But again, as a background, we all know that we cannot really run away from genetics. There are people running away, but actually they should be knowing that we cannot run away from genetics. It is everywhere. Can we have the slides here? Yeah. So why nephrogenetics? Primarily because, as I said, that genetic is something in the last decade which has really made a big impact. I don't know any other specialty has made a bigger impact than genetics. And now we have moved on to from the era where we were like waiting maybe even 2 to 3 years to come to a diagnosis. We can get a diagnosis if we want within 2 to 3 days. And we are moving to an era where we are going for a precision nephrology. And in nephrology, pediatric nephrology per se, it is much more important. Why? Because as shown in the slide, almost a third of the cases of CKD, almost more than 50% of tubulopathy, stones, cystic kidney disease are all having underlying genetic disease. And number of studies as well as reviews have emphasized that genetics, like integrating genetics right at the start of nephrology, is not only useful for technical efficacy, diagnostic accuracy, and therapeutic efficacy, but it improves patient outcome as well as it is cost effective. At ICH, we have been running a nephrogenetic clinic now for quite a few years with an average footfall of 70 to 80. We are hoping to increase it, and it has shown that that it does make some difference. When I say nephrogenetic clinic, we have a pediatric nephrologist who are interested in genetics, as well as we have a geneticist and a genetic counselor. So we could, believe me, we could have the whole day speaking about the various case scenarios that we have seen, but we will be just going through quickly 3 of the case scenarios that we have seen in the last few years. So for the first one, I would request Dr. Deblina to explain this case.
So we had a 2-year, 7-month-old male child who was born out of non-consanguineous marriage, and there was a history of polyhydramnios. That child had presented to us with severe dehydration due to diarrhea and vomiting for the last 3 days, and the child also had failure to thrive. So when the child got admitted, we did the investigations, and we found that initially the child had dyselectrolytemias. The child had hyponatremia, hypokalemia, and also the chloride was a little higher, and there was a high anion gap metabolic acidosis with elevated lactate. But the odd thing was that the child continued to have polyuria even when the child was having severe dehydration. So we were not very sure what we were dealing with initially, and we started the child on dehydration correction. And as we corrected the dehydration, we found that the metabolic acidosis gradually improved, the dyselectrolytemia gradually improved. But then the child developed a metabolic alkalosis which was persistent, and the child also started developing hypernatremia, and the polyuria continued. So we did a plasma renin-aldosterone activity which was elevated, and we also thought, are we dealing with an NDI, and is the metabolic alkalosis because of a contraction alkalosis? So we did a water deprivation test followed by desmopressin, and we found that the urinary concentrating ability was impaired and it did not respond to desmopressin also. But then, so we have features of Bartter, but then this hypernatremia is not matching with it. But again, we are also having features of diabetes insipidus nephrogenic, but then we were not able to explain the metabolic alkalosis. So we went ahead for a genetic testing. So we had seen this child in 2015, and at that point of time, genetic testing was not very widely available in India commercially. So we had to send the samples to UK, to Great Ormond Street Children's Hospital, and this is what it revealed. So I would request Dr. Dipanjana ma'am to discuss the genetic finding in this child.
Yes, thank you. So what we got over here was two variants in the SLC12A1 gene, and this was exactly fitting into what we were looking into the child, because what we were getting was hypokalemia with a persistent metabolic alkalosis, and we know that this is basically a sodium potassium chloride co-transporter, which if it gets mutated can cause this. If you look at here, the variants at that time in 2015, it was reported two variants, one was likely pathogenic and one was VOUS. Parental segregation studies showed that this is in trans, which means the parents were carriers, and this is an autosomal recessive condition. As of now, 10 years down, both these variants have been upgraded, and these are actually pathogenic and likely pathogenic, and hence I'll request sir to conclude.
So, in brief, what we had was a child who was showing both features, Bartter syndrome and NDI. Keyword, Bartter and NDI, obviously confusing, and genetic helped it. And what I always say, what the mind doesn't know, the eye doesn't see. And when I had contacted my mentor in Goss in England, he replied back saying that usually when you are having NDI, one of the genes, we look at the NDI genes, but the next common gene are the Bartter gene. And Bartter syndrome can present sometime even with NDI. So something very strange at that time to me. We move on to the second case, and I would now request Sakil.
So this was an 11-year-old male child, came to us with polyuria, polydipsia, acanthosis nigricans that you can see here in the armpit and the around the neck. The weight was okay, but then the BMI was on the higher side. What you notice here is the HbA1c that was very high, urine showing glycosuria, and the fasting blood sugar level was high. So considering this, we diagnosed the case as a case of diabetes mellitus, and we started on metformin. Now this child also had polyuria and polydipsia even after the treatment of diabetes with metformin, and that was persistent. So we thought, are we dealing with something else, maybe diabetes insipidus? So we did a water deprivation test followed by the desmopressin challenge, and what we found out that it was suggestive of central diabetes insipidus. So we started on desmopressin and for the diabetes insipidus. Now what was puzzling was that this child also had some urinary symptoms like dribbling of urine and frequent urinations, for which we did the USG, which revealed bilateral hydronephrosis, and it also showed thick bladder walls. So we did MCUG and DDPA, which were both normal. And considering diabetes insipidus as well as diabetes mellitus, we initially thought, are we dealing with a case of Didmot syndrome? So thinking about that, we also did an eye examinations, which revealed that there was a bilateral retino-optic dysfunctions. So this was a case of optic atrophy also. So considering the triad of diabetes insipidus, diabetes mellitus, and optic atrophy, we considered it was a case of Didmot syndrome or Wolfram syndrome.
So what is surprising here was that, like, I don't know how many of you have seen Didmot syndrome, you might have seen, but Didmot syndrome with bladder dysfunction, at least I accept, at that time I didn't know about it. So what we did was we asked Google Baba, and the Google came up that in Didmot syndrome, sometime you can have, yeah, Sakil?
So in Didmot, you do have certain anomalies of the kidney, renal tract abnormalities are there. So we checked for the minimal criteria required, and we found that either two major criteria or one major and two minor criteria would set up a diagnosis of Didmot syndrome. So in our case, we had both the major criteria like diabetes mellitus as well as atrophic atrophy. Also, we had two minor criteria as well. So this all points towards the diagnosis of Wolfram syndrome or Didmot syndrome. So we did a genetic test for the child as well as the father. So Dr. Dipanjana, can you just share your insight on this?
Yeah, so again, as you can see on your screen, this is a, the gene matches what we were thinking about. But the problem with this is that, see, this is a gene which can both present as autosomal recessive and autosomal dominant. Now, what is important over here is not the gene, but how the gene functions, like the mutation. If I can draw your attention to the variant, you can see it is a missense variant. So when we see autosomal recessive, it is basically a biallelic loss of function, which means that it needs to be where the protein is not produced, and we need two variants in trans, one from the father, one from the mother for that. In this case, it's a missense variant, and we tested the father, and the father was actually also positive for the variant. And because it's a missense variant, if we look at the protein itself, it is in the C terminal, which is a hot spot for autosomal dominant VFS1, and it has incomplete penetrance. So we looked into the father, and what we found was also that the father had thickened bladder walls and with normal prostate. So it was fitting autosomal dominant VFS1.
So here again, like it was because of the teamwork and a bit help from the Google Baba, but I would say more of a teamwork that we were able to come to the diagnosis. This family was practically running from pole to pole, finding out what is the underlying etiology, and it was quite interesting enough for it to get published in Pediatric Nephrology. The whole case scenario of a Didmot syndrome presenting in this way, along with having a significant bladder abnormality, which again I say I didn't know about it, but apparently 1/3 of them do go into end-stage kidney failure. So kidney is important, you accept it or not. So now we move to the last case scenario, and it is for Dr. Sanjukta to elaborate on it.
So we got this 12 years old girl at our OPD initially. So, but the child started her illness since 3 years of age. Initially, she was having features of neuromyelitis optica, for which she received azathioprine and steroid. For the next 6 years, she was having a relapsing course and was receiving 6 monthly rituximab injections. Luckily, she was doing fine from 9 years to 12 years on only steroid and MMF. At 12 years of age, she presented with a diffuse alveolar hemorrhage along with rapidly progressive glomerulonephritis. When we did a biopsy, we found that the child was having features of crycentric GN. But what was the odd point, usually in these children who, on further investigation also, we found that the child was having ANCA positive, P-ANCA positive significantly, complement levels and ANA were negative. So in such a case where it is a vasculitis associated nephritis, there the immunofluorescence is usually negative. But here there were significant deposits of IgG, C3 and C1q. That was an odd point for this child. We treated her in the line of RPGN, but on further getting the family history, we found that there was a significant history of arthritis on her maternal side. The mother, maternal grandmother, all were having features of arthritis from very young age, though there was no history of any kidney disease in these children. In these people. So we thought that whether we are dealing with separate disease entities or we are dealing with a interferonopathy which can lead to such condition. So we sent an interferon stimulated gene score which also came elevated for this child, and next we did a genetic workup. So this is the genetic report of the child. Would like to ask Dr. Dipanjana to elaborate on it.
Yes, thank you for that. So as you can
before she says again, so what was the confusing factor here? Confusing factor was that if you are having a P-ANCA positive, as Sanjukta said, you should be having IF negative. In biopsy, Priyanka positive GN should be IF negative, immunofluorescence negative. Here we have a immunofluorescence positive, and that triggered off that, like, what are we dealing with? Or is it something else or not?
So if you look at the gene, so if we understand what this gene does, so this gene actually interferes with the ER trafficking, and that abnormal ER trafficking leads to cellular stress, which can actually cause an abnormal sting or interferon pathway, which actually can cause this autoimmune disease. Now, if we are looking at it, you can see over here, we have tested the father, the mother and the index child. The mother and the child is positive, the father is negative. Again, this was a pathogenic report, but this was a novel pathogenic one. Before us, there was no other family that was reported for this, and we test, and you can understand if you remember the 3-generation family history, that the mother's side of the family had a very, had similar symptoms of arthritis. Another thing which was important for this was that SCOPA gene is normally associated with interstitial lung disease and arthritis, and in some cases, in some variants, we get a kidney disease. Previous to this, this was not really reported for this particular domain, and we could say that this was an expanded phenotype. So this was perfectly matching, and we could give a diagnosis to the patients who normally thought that this was probably a completely autoimmune condition.
So thanks to the family and thanks to the rheumatology unit, I can't see Priyanka around, but thanks to them, we got this publication. We got this publication in Kidney International, as which has an impact factor of 21.7. So among the highest, one of the highest impact factor journal I have published in, at least, and it was all because of like a teamwork and thinking beyond and trying to link the dots. So nephrogenetic per se, and we in pediatric nephrology, ICH, we have always tried to be academically active. In nephrogenetic, we have initiated number of studies, like this one was a tubulopathy study. Then we have got the COL4 where we found the sRNS genetics, both from the Eastern India, both published in high impact journal, and we have just concluded a pan-India study of looking into genes in cystic kidney disease. We do have a tie-up with as a International Society of Nephrology Sister Renal Center with Birmingham Children's Hospital, and we have recently been accredited by the International Pediatric Nephrology Association for IPNA fellowship. So for the juniors, if any around, you can contact any of our faculties if you want to do this pediatric nephrology training, and it is sponsored through the IPNA. You will be getting good amount. Thank you very much.
So thank you, the moderators and the panelists. May I request all of you to come and take your mementos in the felicitation counter. Now I have the honor to call our two senior nurses who have served us for a long time, Mrs. Shima Ganguly and Reena Ghosh. Please, Shima Ganguly and Reena Ghosh.
মেন্টিমিটা
আছে
আমি মেন্টিটা লগইন করছি মেন্টি মেন্টি মেন্টি
রিনাদি কোথায় রে আসেনি
দেবো
আসেনি ওটা দিয়ে দেবো না তো দিয়ে দেবো রিনা এলো না কেন রিনা তো বলা হয়নি So now our one of the day-to-day problems we face in our day-to-day practice, common dilemmas in office practice, I request Parthopratim Haldar, Aniruddha Ghosh, Hridoy De and Rohit Kapoor. Please come, take your seat and start.
Screen ta dao. So, good afternoon. We are running very late. So, this is a...
You have your 45 minutes time. You don't have to
Okay.
hurry. Full 45 minutes.
So, this is a gray zone. In medicine, most of the things are not white or black. Most of these things are gray. So, I have selected few cases that we face in our day-to-day practice. When to investigate, when not to investigate, how much to investigate. And we will have a Menti quiz. You can join on this. Yes.
Hegde and Hegde lottery, I'll just announce the price and let... ওখানেই stop রাখো টাইমটা. Come.
So, in between you can join with this code.
The number is 312. Can you please tell me the doctor name? Yeah.
I am not. Dr. Tushar Kanti from Bardhaman. Dr. Tushar Kanti Mondol from Bardhaman. Is he here? তাহলে আরেকটা তুলি যখন নেই আরেকটা কি পরে দিয়ে দেবে একটাই থাকুক পৌঁছে দিও
Okay. So, we are starting. I have my panelist, Dr. Hriday, Aniruddha and Rohit. So, let's, is full screen? No. So, first case, 18-day-old term male, mother noticed small pit over the lower back, baby feeding well, active, passing urine and stool. Normal neurological examination, single midline sacral dimple, 3 mm diameter with visible base. Within the gluteal cleft, no hair tuft or skin lesion. So, what will you do? How will you investigate, or do you really investigate? So, you reassure, ultrasound spine, MRI spine, or refer to neurosurgery. একজন একটু আসবে Okay. Yes. So, you will reassure, you will do ultrasound spine, you will do MRI spine, or you will refer to neurosurgery. Okay. So, majority will reassure. Now, suppose the dimple is 8 mm, 4 cm above the anus, hair tuft present, base not visible. Would your answer change? Most likely, yes. So, I would request any of the panelists just quickly go through which sacral dimple we will investigate and which we can reassure.
So, there are two types of sacral dimples. One is the simple sacral dimple and another is the atypical sacral dimple. If the dimple is shallow, you can see the base. The size is below 5 mm and it is within 2.5 cm from the anal verge. Then most likely you have to reassure and it is not associated with any kind of neural tube defect. But on the other hand, if the base cannot be seen, the size is more like the second case, and there is tuft of hair or hemangioma, any skin-like appendages, tail-like appendages, any kind of scar like aplasia cutis, then that is a definite indication for going for further neuroimaging and timely referral to your neurosurgery colleagues.
Okay. Next, 5-year-old boy, intermittent abdominal pain for 3 months. Periumbilical lasts 5 to 10 minutes, 2 to 3 episodes per week. Child resumes play after the episode. no fever, vomiting, weight loss, sleep disturbance. Now, I would like to know from the panelists what additional history would you like to know, and would anyone order ultrasound at this stage? What is the opinion of audience? Will you order an ultrasound at this stage? Okay. So any additional history?
So this is a very common scenario in our day-to-day practice, where we get a child who is otherwise well, growing well, active, but complains of intermittent pain abdomen, and otherwise the child is well and the pain abdomen does not require any medication, it subsides on its own. So here the important history points will be the onset of the pain, any relationship with the food, the location of the pain. Here we have to keep the Apley's rule in mind that states that the further away the pain is from the umbilicus, the more sinister pathology it is supposed to be. And apart from this, any history of loose stool with blood, any vomiting with projectile vomiting, any weight loss, any fever. And apart from this, we have to ask the parents whether the child gets up every day for this pain, due to this pain at night, and how does the child pass stool? Is there any history of constipation?
Okay. So the child pass irregular stool every 3 to 4 days, occasional painful defecation, bladder habit normal, growth normal, no organomegaly on exam, and somebody orders a USG. And USG shows this. This report we get every day in our chamber. Mesenteric lymph node along roots, size is around 8 to 9 centimeter. So what is the most likely diagnosis? Functional constipation, acute mesenteric adenitis, inflammatory bowel disease, or intestinal TB? So majority is in the opinion of functional constipation. Okay. So what are the red flags in case of periumbilical pain abdomen or any pain abdomen?
If the child gets up from sleep due to the pain abdomen, if there is any growth faltering, if there is any associated blood in stool or any GI bleed, if the child is having fever, joint pain, if the child is having any rash, then we have to think of some other cause other than functional abdominal pain or constipation.
Okay. So this is from Indian Pediatrics. You have some red flags in history and red flags on physical examination. Most of these things are mentioned. So small mesenteric lymph nodes are incidental. Constipation is far more common cause of recurrent abdominal pain, and imaging should always be interpreted in the clinical context. 7-year-old girl complained of mouth breathing for 8 months, snoring during sleep, frequent cold. Parent comes with X-ray, enlarged adenoid. So what would you like to know before advising treatment? Any of the panelists?
So first thing is we have to ask, is there is any disturbance in the sleep? Is there any snoring, any apnea noticed or not? Any daytime sleepiness? Any poor weight gain or not? And recurrent otitis media? And we have to ask that if there is any sign and symptoms of allergic rhinitis.
Okay. So further questioning, snoring every night, no apnea, no daytime sleepiness, no poor weight gain, no otitis media, but there is history suggestive of allergic rhinitis, mouth breathing, allergic salute, and enlarged turbinate. So what will you do? Intranasal steroid, refer for adenoidectomy, nighttime CPAP, or sleep study? So you'll go for steroid, adenoidectomy, nighttime CPAP, or sleep study. Okay. So most of us will go with intranasal steroid. Now, father says ENT doctor has already advised surgery. Mother asks, can medicine reduce the adenoid? And grandmother comes during the next visit, and the child stays with grandmother at night, and grandmother says he snores every night, stops breathing for some time, sweats while sleeping, and has become sleepy in school recently. So that history was incomplete from mother. So you have 3 things: a mouth breathing child with an enlarged adenoid on X-ray, and you have a nasal endoscopy showing the enlarged adenoid. Now, in this situation, what will you do? You will continue medical treatment, you will go for ENT referral, you will do sleep study, or you will do hearing assessment. Okay. Many people are in the opinion of sleep study first, and many people will do ENT referral. Okay. So, when we can plan for conservative management and when we should go for surgery?
So, your intranasal steroid will only work if the patient has any symptoms of allergic rhinitis or not.
Yes.
But if there is no such symptoms of allergic rhinitis, and if there is a significant history suggestive of sleep apnea, there is sleep disturbance, and the child is waking up from the night with sweating after stopping breathing, then you have to go for surgery most likely. But the sleep study in polysomnography in children is pretty much difficult to do. What we can do is overnight we can observe by just by pulse oximetry. We
Yes.
can watch about the SpO2. If it is dropping, then it is suggestive of sleep apnea. And also to keep in mind that if there is a history of recurrent otitis media
Yes.
also, then also you have to go for surgery, I think.
So, sleep study is little bit difficult because there are very few labs who does sleep study in smaller children. Next, 8-month-old male, high-grade fever for 3 days, no cough, no diarrhea, urine culture 10 to the power 5, CFU, E. coli, sensitive to ceftriaxone, 8-month-old male, improves after appropriate antibiotic. So before discharge, what investigation would you advise? None, USG QB, MCU, DMSA scan. What investigation would you advise? Okay, so majority of people will advise USG and a very few response regarding MCU. Okay, now suppose everything remains same. The urine culture glows, Klebsiella pneumoniae. All other thing is same. Has your investigation plan changed? So we'll do USG, none, USG, MCUG both, and DMSA. So here, what investigation will you advise? Initially we had E. coli. Now suppose we have Klebsiella, 8-month-old male. Okay. So majority people will do USG along with MCUG. So, opinion from the panelists regarding E. coli UTI versus non-E. coli UTI. How these things differs and what would be the approach of investigation?
So previously the guidelines suggested that we treat all the same, but in 2023 the ISPN guidelines stated some things which were not previously there. The first of among those things were typical UTI and atypical UTI. Typical UTI means it is by the commonest pathogen, that is E. coli, and most likely, commonly they have seen that E. coli is not associated with any kind of structural pathology or any kind of reflux disorders. Most often, the other organism like Klebsiella, Proteus, Pseudomonas, Acinetobacter, these were associated with most of the congenital anomalies or structural anomalies. It was seen that in case of renal stone, the UTI were more commonly caused by Proteus. Now, there are certain differences that are seen in E. coli UTI and the UTI caused by other organisms. The bacteriuria might be little less in case of the atypical UTI. The nitrite and other results might be little bit different in the atypical UTI also. So, they have suggested that USG now holds indication in 2 places. USG is now indicated in all the patients below 2 years of age with first febrile UTI. But the next step, previously what we did, that first we did USG QB, then after 2 to 3 months we waited and we went for an MCUG, and after 4 to 6 weeks we went for an DMSA scan. If the child was below 1 year, we had to do all these things and kept the child on prolonged antibiotic prophylaxis. Now that has changed. They have said that MCUG is reserved only for febrile UTI in less than 2 years old child with atypical UTI, like other organism causing UTI, and recurrent UTI. These are the two indications where you should go for MCUG, because MCUG is an invasive test and there are certain risks involved when you put the catheter. You can see that there are sometimes post-catheterization infection itself, and it is not very comfortable for children also. So compliance is also poor. When you call them up after 2 to 3 months, you see that they don't turn up.
Okay.
So another thing I want to impress, that previously the MCUG was suggested after 2 to 3 weeks. But now they have said just after subsidence of infection and just after completion of IV or oral antibiotic therapy, you can go right away for MCUG. You don't need to wait. And DMSA is now reserved only for higher grade of refluxes and recurrent UTI. That is grade 3 to grade 5 vesicoureteric reflux and the recurrent UTI patients. You should go for all those threes. Another thing they have mentioned, that all the patients should be inquired about BBB. What is BBB? It is bladder bowel dysfunction. So from the beginning, we have to inquire whether this patient is only having a simple UTI or this patient is associated with bladder bowel dysfunction. So that will lead to recurrence of UTI if you don't treat the bladder bowel dysfunction.
So the bottom line is non-E. coli UTI has a higher chance of having associated renal anomaly. So the guideline says if you have a non-E. coli UTI, you will do USG and MCUG both in less than 2 years, and if you are 3/4 or recurrent UTI, you will do a DMSA. So not every first UTI needs an MCU, but every non-E. coli UTI deserves a closer look. Okay. 6-month-old girl, mother says, doctor, this small red spot has doubled in size in 1 month. Baby is otherwise well, no bleeding, no ulceration. What would you do? Observe topical timolol, oral propranolol, oral steroid. 6 months girl. Okay. So observe an oral propranolol is, many people will go for oral propranolol and some people also favor topical timolol. Okay. Now, you have seen this child. Now another child comes with this. 2-month-old girl, baby is otherwise well, no bleeding, no ulceration. So you can see the hemangioma? Okay. So what you would do here? Same option, observe topical timolol, oral propranolol or oral steroid. First, most of us will observe, and that is the right approach. Now here, what will you do? Will you go for oral steroid, oral propranolol, topical timolol, okay, and some people still observe. Okay. So majority are in favor of giving oral propranolol at this point of time. Now, I'd like to ask the panelists about low risk and high risk hemangioma and where we should consider early propranolol therapy.
So low risk hemangiomas are like the first case where it is very small. It is away from any vital structure. It is superficial and there is no ulceration and no bleeding tendency. And in these cases, we have to counsel the parents that most of these cases, in the first 6 months of life, the size of the hemangioma will increase, and in the next 6 months, it will decrease. 50% of these hemangiomas, they decrease on their own without any therapy till 5 years of age, and 90% of these hemangiomas will decrease on its own without any therapy till 9 years of age. So in low risk hemangiomas, the superficial hemangiomas, we will only counsel the parents. We will tell them to keep a watch that the child does not scratch the lesion, tell them to trim the nails of the child, tell them to avoid any trauma. And in any high risk hemangiomas, like in the second case, it was on the bridge of the nose. So it was, if it increased in size, there was a chance that it can obstruct the visual field and can cause amblyopia in the near future. So in that case, we have to start oral propranolol therapy.
Okay.
Now
the second twist, you notice 6 additional small hemangiomas over the trunk. So would this change your evaluation?
Yes, so multiple small hemangiomas over the trunk can be associated with internal hemangiomas, mainly liver hemangiomas. So we have to do an ultrasound of the whole abdomen as well to look for liver hemangiomas. Side by side, we also have to check for the thyroid profile.
Yes.
Because this can be associated with hypothyroidism as well. The propranolol might be started by admitting the child. Initially, we have to do the ECG as well as the blood sugar monitoring, because propranolol therapy can be associated with bradycardia as well as hypoglycemia. So propranolol we should always give just after meals or with meals. And initially, we just give a low dose, that is 1 to 2 mg per kg per day. And after that, we increase it to 2 to 3 mg per kg per day, and to continue till the regression in size of the hemangioma is noted.
Okay. So which hemangiomas worry you? Around the eye, nose, lips, beard distribution, very important. Possible airway hemangioma association, ulcerated, rapidly enlarging, or causing functional impairment. Now, these are the areas where we should treat. Functional impairment, high risk of scarring, high risk of bleeding, and you can see multiple hemangiomas in trunk. You should look for hemangiomas anywhere internally. Okay. 6-year-old boy, very common. Mother says, doctor, I have seen worms in his stool 3 times this year, intermittent abdominal pain, appetite growth normal, no fever, diarrhea, already received 4 times albendazole in the first year. So, before prescribing another dose, what do you want to know? Question to the panelists. You would like to know anything else?
So first thing is what about the hygiene?
Yes.
It is the most important thing that we should ask about. That hygiene is important, and also if they are noticing any worm in the stool, what type of worms they are noticing, and also that their siblings or the family members,
yes,
if they are also having worms in the stool, then also we have to ask about that. So
Okay.
just
So here worms are small, white thread-like, child scratches repeatedly, and younger sibling has similar itching, child bites nail, no weight loss, no anemia. Now, what is the most likely diagnosis? Ascariasis, enterobiasis, giardiasis, hookworm. So the poll is uniformly in favor of hookworm. Okay. Hey, sorry, enterobiasis. Sorry. So mother says, but I have already given albendazole 4 times in a year. Why does it keep coming back? So what is the most likely explanation? Drug resistance, immunodeficiency, reinfection or autoinfection, or is it a wrong diagnosis? Yes. So it is most likely the child is having auto-infection. The history suggests you auto-infection, repeated scratching of the back. Okay. So for suspected pinworm, consider perianal tape test when confirmation is needed. Treat appropriately, repeat treatment after 2 weeks. Treat household members simultaneously, hand washing, proper hygiene, daily bathing. And how many of you will send a stool routine examination in this patient? Will you or not? No. Because if you suspect pinworm, the perianal tape test is the useful for diagnosis, but most of the time we can see the visible worm in blank eye also. So when should we investigate further? Do we really need to investigate further? If the child is coming repeatedly with worm and hygiene is okay, then still anything is, are we missing?
yes, you should investigate further when there is a growth failure, that means
Yes.
there is a poor weight gain or not. If there is a persistent chronic and diarrhea, and there is a even if you are giving iron therapy, after even giving iron there is a persistent anemia or not. If there is a blood in stool, if there is significant abdominal distension or pain, and even after giving proper treatment and maintaining proper hygiene, if there is a repeated infections and this thing, you have to further investigate.
So you have to look for red flags like poor weight gain, anemia, diarrhea, these things. Then you have to think of alternate diagnosis. 7-year-old boy, mother says the swelling in his neck has been there for almost 2 months. No fever, weight loss, appetite normal, playful, active upper respiratory infection 2 months ago, received antibiotic twice. Single left cervical node on examination 2 into 1.5 centimeter, mobile, firm, non-tender, non-matted. Now, for audience, what would you do? Reassure, ultrasound, CBC inflammatory markers, TB evaluation, FNAC or biopsy. Okay, so most of the people will reassure and observe. And some will do CBC and inflammatory markers. Okay. Now, the pediatrician did an ultrasound. It shows 2.2 into 1.3 centimeter oval lymph node, preserved fatty hilum, no necrosis, child remained completely well. So is this ultrasound reassuring enough to stop investigation? All of you will mostly agree that, okay, we can wait. Now, same child, but present little differently. Node is 4 centimeter, hard and fixed, supraclavicular, increasing in size, night sweat, and you have history of weight loss of 2 kg. So here, observe, reassure, antibiotic, ultrasound, urgent specialist evaluation or tissue diagnosis. Okay, majority will do favor for tissue diagnosis and some people will try with antibiotics. Okay. Okay. So what are the red flags in case of when we should think beyond reactive lymphadenopathy?
So the question is whether this is a reactive lymphadenitis or there is some sinister pathology. So among the causes causing the sinister pathology, heading the list is tuberculosis and malignancy. And there are other causes like infections and lymphoreticular disorders and also. So what is the clinching factor in the first, can you go back to the first slide? If you see the first description, you see that it has been there in the history. We have to see that there was a upper respiratory tract infection 2 months ago.
Yes.
The mother noticed the swelling since then. And currently there is no fever, there is no history of weight loss. Patient already received antibiotics twice, judicious or non-judicious, that is another thing. But there are 2 things in the description of the lymph node. That is, one is size, 2 into 1.5 centimeter, and another is firm. So according to the new Nelson, if you go through it, you can see the significant lymph node size. It should be significant when it is more than 1 centimeter in axillary and cervical, more than 1.5 centimeter in inguinal, and more than 0.5 centimeter in case of epitrochlear lymph node. Also, the chances of getting sinister pathology in supraclavicular and the lower cervical region is more. Whenever you get a single lymph node or a discrete lymph node, you should look at whether this is the only lymph node in the body or it is part of a generalized lymphadenopathy. Whether there are more than 2 contiguous sites with lymph nodes with significant size over there. So if the lymph node is normal in size, it is soft, it is non-tender, it is moving, it is not attached to the underlying structure or the overlying structure, it is persisting but gradually decreasing. So these are the signs whether you can consider that it is a reactive lymphadenitis. But if it is otherwise, then you have to go for a detailed workup.
Okay. So think beyond reactive when you have supraclavicular hard fixed node, rapidly enlarging, progressive node, generalized lymphadenopathy. The key point is size alone should not determine your decision. So well child, small, mobile, improving node, observe, persistent or enlarging node, CBC along with inflammatory markers, USG you can consider TB, depending upon the contact history and epidemiology, and suspicious node, the most important, don't keep prescribing antibiotic. So second situation that I have shown, it's suspicious. The child is having night sweats, weight loss, hard lymph node, fixed. So don't biopsy too early, but don't reassure too long. The trajectory and clinical context matters more than the ultrasound measurement alone.
One thing I would like to add is we have to check for the dental caries as well.
Yes.
In such cases.
So dental caries will cause more anterior triangle lymph nodes more. Okay. 6-year-old girl, mother says she wakes up crying because both legs hurt, pain for 3 months, 2 to 3 nights per week. Both cuffs in area, usually evening, night, gone by morning. Plays normally during the day, reduced by massaging, and no fever, no weight loss. So, what will you do? Reassure CBC, ESR, vitamin D, X-ray. Okay. So majority people will reassure and some people will do vitamin D. Now that's a very controversial area. I think we have Hriday with us, pediatric endocrinologist. So he will answer. But before that, let me show you something. Okay. Now my question to the panelists, what single finding would make you uncomfortable calling this growing pain?
So growing pain is usually bilateral. It happens during the night times and it will be relieved by next morning. But if it is still there in the morning, is there is any morning stiffness, is there is any tenderness in the joints, is there is any difficulty in the daytime activities, then you have to investigate further for the growing pain.
So the classic pattern, bilateral, 3 to 12 years, evening, night predominance, and child should be pain-free by morning. So if the child is limping on the next day morning, then before labeling it growth pain, you should be very cautious. Suppose now the same child, pain is only on right leg, morning stiffness, limping, localized tenderness over tibia, and pain is becoming progressively worse. So this is not growth pain. We need to investigate. Okay. So red flags, limping gait, daytime pain, unilateral persistent pain with residual morning stiffness, localized bony tenderness, fever, weight loss, weakness, abnormal examination. Now comes the vitamin D dilemma. Mother asks, should we check vitamin D? So do we routinely need to check vitamin D in children with typical growing pain?
So for growth pain, vitamin D testing is not required or it's not recommended to check vitamin D in every child with growth pain. But many a times practitioners send vitamin D levels and obviously most of the time it comes as decreased vitamin D level.
Yes.
Now, when we should treat or when we should not treat, we have to follow the guidelines we have from the IAP.
Okay.
Now, 20 to 30 is called as normal vitamin D. More than 30 is sufficient, 20 to 30 is insufficient, and less than 30 it is low. And if it is less than 12, we have to treat as a vitamin D deficiency as per the protocol. But if it is more than 20, and even if if you feel that you should give vitamin D supplementation, you can give maintenance dose. Like for less than 1 year, 400 IU, and more than 1 year, 600 IU. But in common practice, in our common practice, many of us prescribe vitamin D frequently.
We tend to prescribe mega dose, 60K weekly for 6 weeks, 8 weeks, 3 months, like that.
Yeah, but thing is, vitamin D toxicity is not very much common, even if someone is taking much more vitamin D, because our kidney deal with vitamin D pretty well. Even if I had seen that one of my patients had taken vitamin D 60K once daily for 2 months. Even after that, vitamin D was normal. So don't worry, because before 3 to 2 years, we were discussing everywhere in every platform that how we can treat vitamin D deficiency. And now we are very much fussy about that vitamin D toxicity, but it is not that much common.
So the classic presentation with normal growth and examination does not automatically require extensive investigation or routine vitamin D testing. And as Sridhar rightly said, 3 years back we are discussing vitamin D deficiency, and probably from 1-2 years down the lane we will discuss vitamin D toxicity. So growing pain, classic history, normal examination, don't investigate the typical child, but don't call atypical pain the growing pain. And this is the last case, 10-year-old girl, recurrent headache for 3 months, 2 to 3 times per week, frontal throbbing pain, occasionally associated nausea, vomiting, no fever, visual symptoms, weight loss, but there is family history of migraine, diagnosed as migraine by pediatrician and prescribed paracetamol and rizatriptan. No improvement after 6 weeks of treatment. So, what will you do next? Increase anti-migraine medication, order MRI, prescribe different triptan, refer to neurology, or you review the diagnosis. Okay. So, many people will review the diagnosis. And we probably need to review the diagnosis at this point because child is getting anti-migraine medication and not responding. Nobody will refer to neurology now and nobody will increase the dose. So there is a dilemma whether to order an MRI or whether to revisit the diagnosis. Okay. The child attends hospital emergency with severe headache and intermittent blurring of vision. After a few days, you measure the blood pressure 160/100 and repeat BP after 10 minutes is 154/96. So for last 6 weeks, the child was getting anti-migraine medication, but probably that was not the correct diagnosis. So re-evaluation, normal neurological examination, but there is papilledema, no focal neurological deficit, but height is 5th percentile, weight is 25th percentile. And no edema, femoral pulse is palpable. So what would you investigate next? Renovascular disease, coarctation of aorta, endocrine hypertension, or primary hypertension? Okay. So renovascular and endocrine, and some people have mentioned coarctation, primary hypertension. Okay, so what is the opinion of our panelists from this history?
So for any headache is a very important thing that comes in our clinic, and we see patients day to day. So we have to keep the danger signs of headache in mind. Any headache that wakes the child up from sleep, any headache that is associated with early morning vomiting, any headache that is associated with any change in the behavior, any headache that is associated with any seizure, any headache with neck stiffness or torticollis. And these are basically the warning signs. Along with that, in older children, we have to see the gait as well, because ataxia can also be associated with headache. So 2 important things that was missed in this case, we have to do if a child comes with headache in our clinic. One is blood pressure monitoring, obviously, and one is the eye examination, because the headache can be because of a eye problem as well, and papilledema is also to be seen by doing a ophthalmoscopy.
Okay.
And I just want to add that...
growth parameters, any comment on growth parameters?
Yes, so you have to see growth parameters as well, and there was an option and many people voted for endocrine hypertension.
Yes, yes.
So for endocrine hypertension, pheochromocytoma, there will be some features which will lead to your diagnosis for pheochromocytoma, like excessive sweating, palpitation, and etc. And I just want to mention one thing for the general audience, that for pheochromocytoma evaluation, please don't send VMA, because VMA is not specific for pheochromocytoma. We have to see plasma metanephrine or urinary metanephrine. And you can see norepinephrine or epinephrine in the spot urine sample. And also for other things like hyperaldosteronism, You have to see the plasma renin activity and aldosterone, because sometimes you can get apparent mineralocorticoid excess syndrome due to 11 beta hydroxylase hydroxysteroid dehydrogenase deficiency, and glucocorticoid remedial syndrome as also. Some patients already in our institute admitted with hypertension and hypokalemia for that. You should look for the electrolytes also when you are evaluating for the hypertension.
So, headache in children, before diagnosing migraine, every child with recurrent headache should have blood pressure measured, growth parameters plotted, vision assessed, and a complete neurological examination. So what did these 10 cases teach us? Start with the child, not with the investigation. Recognize the typical presentation. Always look for red flag. Try to avoid over-investigation as well as delayed recognition of danger signs and symptoms. And common things are common, but serious things should never be missed. The art of pediatric office practice lies in knowing the difference. Thank you.
Thank you very much, Partho, for giving us some time. May I request all the moderators
I have finished 5 minutes beforehand.
Okay, that's enough. Moderates and the panelists, please come down.
So I request the audience to stay for some more time, because our PGTs are going to show very interesting cases, and they have prepared.
Please take your memento from the memento corner. Memento corner. Hey, Jaydev Rai, please give our students the memento.
So PGTs who are going to present cases.
Now we have our best of ICH. Partho is going to conduct.
No, I'm not. So PGTs who are going to present cases come one by one. I think we have Karthik.
Also, there is a very important announcement.
Yes.
We are very much invited to Dr. Shati Chakraborty, who has given us a donation of 1 lakh rupees. Thank you, Shati Di, from the core of our heart.
So, Karthik, come here. Fast. I have saved 5 minutes for you.
Good evening for everybody who stayed. I've come here to talk about hydrocephalus in children and our role as surgeons in Institute of Child Health, Kolkata. So these are our little warriors. Whom do we operate on? Number 1, number 2, or number 3? We should have operated on everybody, because everybody has shown significant clinical signs and also growth retardation and deterioration. Unfortunately, the third case, we could not operate, but the child presented to us at an age of 8 years. So my objective today was to talk about all the whole of the hydrocephalus in toto, but I'll cut short due to the time constraint. So by definition, it is the progressive accumulation of CSF with the association of ventricular dilatation, raised ICT, and neurological dysfunction. Not all ventricular dilatations are going for surgery as such. So there are two important aspects for this too. There are arrested hydrocephalus and also hydrocephalus ex vacuo. Arrested hydrocephalus is one thing where the child is lucky because the alternate pathways for which the CSF is absorbed kick in. Whereas in hydrocephalus ex vacuo, it is not hydrocephalus in true sense. It is because the brain parenchyma itself has degenerated, causing the ventricles to look apparently dilated. So this is a good picture I've taken from Netter to show the flow of CSF. If I had a pointer, it would be fine, but as such, the CSF starts from the choroid plexus in the lateral ventricles and then goes into the third ventricle. From there, through the foramen of Monro. From there, the aqueduct of Sylvius and the fourth ventricle, in which the both foramen of Lashka and Magendie enter. From there into the basal systems and into the CSF through the arachnoid villi. So any obstruction in between the CSF flow from the ventricles is called an obstructed hydrocephalus, and if it is not there or if it is beyond the ventricles, it is called a non-obstructive hydrocephalus. So I've covered that up. So the clinical features that we have to see keep it in mind were the emergency ones that came to us with rapid increase in high head circumference, vomiting, seizures, neurological symptoms, and Cushing's triad also. But in OPD, we rather see people with delayed milestones, macrocephaly, poor feeding, irritability, headache, and diplopia. We hope people don't come with diplopia because that is a very late presentation. So the examination we see for the head circumference, anterior fontanelle, split sutures, the McEvans or the sign or the cracked pot sign when you do on percussion. The sun setting sign that is we see in the eyes due to the the orbital gaze palsy and papilledema definitely in fundoscopy. So the diagnosis can be made by an ultrasound or an MRI and also a fundoscopy. That would really help. And we can see the dilated ventricles, and there are different ratios to actually comment on the severity of the ventriculomegaly. So for us, where we enter, we do a temporary CSF diversion or a permanent solution. But we do temporary CSF diversion in case where there is an active infection through which we do a serial taps through the anterior fontanelle into the lateral ventricle. And we can also give intraventricular antibiotics also. And we have also got subgaleal shunts or the reservoirs through which we can tap in for serial testing. Medical management, as you know, we give antibiotics. We choose taxim and vancomycin at double dose or the meningitis dose, and acetazolamide as such also. And management of metabolic acidosis and diuresis also has to be done. So these are the different types of shunts we have: VP shunt, ventricular atrial shunt, pleural shunt, ETV or the endoscopic third ventriculoscopy. And the MRI that is shown is a cyst. We can do a cystoperitoneal shunt also. So different types of shunts we can elaborate later once I finish the presentation. And this is a small video of the surgery we do. It is completely aseptic and sterile. We drill a hole in the parietal area, and this is the a tunneler that we put in from the abdominal end to the I'm sorry. I missed that. This is the post-operative X-ray where we can see that the shunt is in the third ventricle and also into the abdomen. Considerably elongated extra length of it is present to accommodate the growth of the child. We have to assess the child post-operatively also, and this is how we do it. We should assess the child first before assessing the shunt. Any child with vomiting and irritability, think of shunt blockage. Complications as such, I will not go into delve into that, sorry for that. And the one thing we want to try to tell you is that we always consider 3 operations for a child with hydrocephalus once we are doing a shunt operation, because all these complications make things worse. But for us, our experience, we have done 56 shunts in this 6 years of my experience in ICH. We need 7 were meningomyelocele patients. 2 of them had abdominal pseudocyst and 4 of them had shunt blockage, but no wound infection could be seen in us. So we are safe. Thank you.
Good afternoon, everybody. I'm Shahrukh Nawaz, first year PGT of ICH. I'm going to present a case of severe hypercalcemia and multifocal osteolytic bone lesion in an adolescent. So, a 16-year-old boy presented to us with complaint of pain in the lower abdomen, bilateral flank and back for last 7 days, and non-projectile and non-bilious vomiting for 4 days and decreased urine output for 2 days. So there was no significant birth or family history or past history, and on examination the child was well built but was in debilitating pain, unable to get up from bed, conscious, alert and moderately dehydrated. Tenderness was present over right hypochondrium and no organomegaly or any lymph node or any evidence of subcutaneous calcification was noted. So the investigation on day 1 revealed a very high level of serum calcium of 19.8, and suppressed parathyroid and low vitamin D level and deranged renal function. And ECG also was suggestive of hypercalcemia, like increased PR interval, first degree heart block, and so we managed the child with protocol for hypercalcemia management with hyperhydration with normal saline and IV bisphosphonates and calcitonin with loop diuretics, and we brought down the calcium level from 19.8 to 9 within normal level within 4 to 5 days by aggressive management. And serial monitoring was done, which is shown here. And as there is a clinical picture suggested a rather a malignant disease underlying, so the tumor lysis marker was also elevated, so we managed that with raspberry and other medication like allopurinol, and there was 48-hourly monitoring of all tumor lysis markers, and child was shifted to PICU during the hypercalcemic crisis period. And we did the NCCT of chest, abdomen and pelvis, which revealed multifocal lytic lesion involving vertebra, sacrum, pelvis and bilateral femoral heads. No cortical destruction, collapse or sclerosis of soft tissue was noted. So then we went for the PET CT scan, which showed metabolically active lytic lesion throughout the axial and appendicular skeleton, likely neoplastic, but there was no soft tissue or organ involvement. So we have a case of multifocal lytic bone lesion with severe hypercalcemia. What can be the causes? So with suppressed PTH and low vitamin D. So first thing we have come in our mind is hematological malignancy like any leukemia or lymphoma. Another is Langerhans cell histiocytosis and chronic recurrent multifocal osteomyelitis. But CRMO doesn't show this much hypercalcemia and the course is not so acute. Multiple myeloma is one cause, but unlikely in this age group. And we also did serum protein electrophoresis, which did not show any monoclonal spikes. And sarcoidosis was also ruled out, but also unlikely in this age group, and the clinical picture was not like sarcoidosis. And another is metastatic solid organ tumor like neuroblastoma, sarcoma. So on further workup, we did bone marrow aspiration and biopsy, which was not suggestive of any malignancy, but immunohistochemistry was suggestive of early T cell precursor lymphoblastic leukemia, but that was CD117 positive, but CD34 was negative, and histiocyte cell was positive for CD68, but S100 Langerhans were negative, so Langerhans cell histiocytosis was also ruled out. So finally, we did CT guided bone biopsy from the femur head, so direct CT guided biopsy from the lesion, which showed, which was consistent with T lymphoblastic leukemia. So this was a case of T lymphoblastic leukemia with severe hypercalcemia, which is not seen very likely, and it is not found generally. And case studies also have shown one case of lymphoma with severe hypercalcemia, but that was of a 54-year-old patient, and there was no case of reported in pediatrics age group of lymphoma with so much calcium level in serum. So take home messages: severe hypercalcemia with suppressed PTH warrants an urgent search for occult malignancy, and a single non-diagnostic marrow aspirate does not exclude malignancy. We have to do tracing biopsy and targeted biopsy from the lesion if needed. So, thank you.
Good afternoon, everyone. Today my topic of presentation is resurrection of kidneys in a case of atypical HUS. A 12-year-old male child at A 12-year-old male child admitted in ICH on 8th of February 2026. Child was a known case of atypical HUS. Initial symptoms started on December 2025 with fever followed by gross hematuria, oliguria, facial puffiness. No history of diarrhea or pneumonia was present. Child was admitted in an outside hospital on January 2026, where the initial investigation revealed anemia, thrombocytopenia, AKI, LDH was high, and cystocyte was 3% on the peripheral smear. So it was failing the HUS triad, that is microangiopathic hemolytic anemia, thrombocytopenia, and AKI. As it was a non-real HUS and C3 was also low, anti-CFH antibody was sent there, which came out to be negative. So subsequently renal biopsy was done, which showed subacute thrombotic microangiopathy. So child was finally diagnosed as a case of complement-mediated hemolytic uremic syndrome, antibody negative. Child received 6 cycles of hemodialysis here. Child was discharged on risk 1 for that hospital and advised to continue hemodialysis, which parents continued for about 2 weeks. So the child presented to us very late, after almost 2.5 months with pallid edema and hypertensive emergency. Here the initial evaluation showed the persistence of feature of atypical HUS. As per ISBN guideline, in a case of antibody negative atypical HUS, we should start plasma exchange as soon as possible. So in our case, thinking that there may be defective complement proteins, we started plasma infusion, which is equally effective to plasma exchange. But there was not much improvement clinically and hematologically. So in such scenarios, we should think of giving eculizumab injection. So we repeated the renal biopsy, which showed persistence of thrombotic angiopathy with no chronic changes. So the kidney was still salvageable. Now, what is eculizumab? Eculizumab is a newer monoclonal antibody which acts on the terminal part of the complement pathway and inhibit the formation of membrane attack complex, which is the main culprit in case of atypical HUS. But it is very costly. Though it is a wonderful drug, we should be very cautious about it. Before starting it, one would be immunized against the encapsulated organism like meningococcus, and monitoring would be done very closely. So in the meantime, we sent whole exome sequencing, which showed CFH gene mutation along with complement factor H deficiency, which was initially classified as variant of uncertain significance and subsequently reclassified as likely pathogenic. So we decided to give eculizumab in that patient, and I am proud to say that our pediatric nephrology team first pioneered the use of eculizumab in any pediatric atypical HUS patient in Eastern India. So child received the initial 3 doses of eculizumab at ICH, and thereafter we initiated the process of transferring the child to AIIMS New Delhi, as the child would get the eculizumab injection free of cost to rare disease program there. So the current status is child has received total 7 doses of eculizumab till now, and as you can see, the serum creatine level gradually decreased after starting eculizumab injection. Urine output has also increased gradually, and cystocytes has become less than 1%. So child is off hemodialysis since April 2026. Hematological remission has already achieved. Urine outputs increased dramatically to 1.5 liter per day. Serum creatine came down to 1.2. Now he has been registered at SSKM for receiving further doses of eculizumab through the rare disease program. So my take-home message is high index of suspicion is required for early diagnosis of atypical HUS. Atypical HUS is a life or kidney-threatening disorder. Eculizumab is the drug of choice for complement-mediated atypical HUS. Genetic testing helps identify complement effect, assess relapse risk and guide transplant planning. Though very costly, it can be severe for the kidneys. Long-term follow-up is essential because relapse can occur even after clinical remission. So we achieve the resurrection of kidneys in our patient. Thank you.
I'll ask everybody to stay back so that we can have a group photo. Is there any more presentation? Oh, yours presentation. Please stay back, we'll have a group photo here.
Good afternoon, everyone. Today I'm going to present a case on bilateral non-responsive pneumonia, a diagnostic challenge. 5 years old male child, resident of Bihar, presented to us with history of insidious onset of low-grade fever with cough and documented weight loss for last 3 months with leukocytosis and elevated CRP. He received oral and IM antibiotics at home with transient clinical improvement. Mother noticed swelling over anterior chest wall 3 months after onset of fever. So initial investigations were done, like chest X-ray was done, where we can see bilateral upper lobe opacities with erosive changes in left third rib, and he got admitted in a local hospital where he was started on intravenous antibiotics. Gastric aspirate for CBNAT and MGIT was negative, and then pleural fluid culture was also negative. HRCT thorax was also done, which showed D3 vertebral collapse and third rib erosive changes. Biopsy from the swelling showed granulomatous inflammation compatible with TB and presence of well-formed epithelioid cell granuloma and Langhans-Giant cells. AFB was negative. So the child was being treated with a provisional diagnosis of tubercular spondylosteomyelitis, where he was started on empirical anti-tubercular drug, but there was no clinical improvement, so patient took LAMA and got admitted at ICH. After admission at ICH, we clinically examined the patient, but there was no growth faltering in the child, and past history was insignificant. There was a significant family history of 2 maternal aunts who died in infancy. On chest auscultation, we could auscultate bronchial breath sounds and bilateral crepitations. Other systemic examination were within normal limits. So chest wall incision and drainage of the multiloculatlet swelling was done. Pus culture was negative, CBNAT was negative with no microbiological diagnosis. So now we were dealing with the treatment failure because the child was having persistent fever, progressive respiratory distress, increasing chest wall swelling, and he also developed a bronchocutaneous fistula with purulent discharge. This is the video where we can see the bronchopulmonary cutaneous fistula. So in view of the paradoxical clinical worsening, possibility of iris, immune reconstitution syndrome was anticipated and corticosteroids were initiated with transient improvement. So even after 1 month of ATD and antibiotic therapy, the child continued to deteriorate both clinically and radiologically with persistently negative microbiological studies. We also reviewed the biopsy slide previously done, which was suggestive of granulomatous lesion and non-caseating granuloma. So now we had to rethink our diagnosis and consider the possibilities like drug-resistant TB, mycobacteria other than tuberculosis, some opportunistic infections, or were we dealing with some underlying primary immunodeficiency. So considering the severity of illness and the persistent disease course, PID workup was sent. The only factors arguing against PID were that the child had previously been healthy for as per age, with no prior hospitalization, no recurrent or prolonged infection or failure to thrive. The PID workup was sent to find the missing piece, and then we saw that NBT DHR burst cells were 0. So this helped us to come to the diagnosis of chronic granulomatous disease. And then we escalated the antibiotic therapy. Voriconazole was added for enhanced anti-aspergillus coverage. We can see this X-ray where it showed the radiological deterioration, and in view of the respiratory worsening, child was shifted to PICU. So since the provisional reports pointed towards a possible chronic granulomatous disease, and we have to consider that what were the organisms causing, like nocardia, Staph aureus, Aspergillus, Serratia and Burkholderia. Bronchoscopy showed mucus plugging and bilateral upper lobe involvement. So we achieved a diagnostic milestone when the pan-fungal PCR came positive for Aspergillus and nocardia. So our final diagnosis was chronic granulomatous disease with invasive aspergillosis, nocardiosis and adenoviral pneumonia. ATD was stopped and nocardia targeted therapy was initiated following standard guideline. Then after 2 weeks of initial clinical improvement, child again developed recurrent fever spikes and worsening respiratory distress. Repeat bowel culture and blood culture still remained sterile, and literature supported adjunctive therapy was considered for inflammatory worsening in CGD. And we started the child on IV methylprednisolone at the rate 0.8 mg per kg per day, which was tapered off to 0.4 mg per kg per day for the next 4 weeks. Then the child showed gradual clinical improvement and respiratory support was weaned. Chest X-ray showed radiological clearing. After 4 months, he was discharged hemodynamically stable on oral antibiotics and steroids. This is the timeline of events. So the take-home points from this case is when you hear of hoops, think of zebras, not only horses. Not all granulomatous disease in TB endemic regions is tuberculosis. Failure to respond to ATD should prompt evaluation for alternate diagnosis and immunodeficiency. CGD can closely mimic pulmonary and spinal TB. Fungal pneumonia in CGD can cause vertebral osteomyelitis, ribs erosion, and even gibbous formation. And early suspicion of inborn errors of immunity can prevent delay in diagnosis and targeted therapy. Thank you.
Good afternoon, everyone. Today my presentation of topic will be from acute encephalitic syndrome to refractory seizures, unmasking a Mogart overlap syndrome. So, 11-year, 5-month-old boy admitted with complaints of fever for last 4 days associated with cough and cold, along with one episode of GTCS starting on day 4 of fever, and was admitted outside in a medical college on that day. There were also 4 more similar episodes on that day of admission with altered sensorium. He remained afebrile since hospitalization. The child was managed during that period with IV Levera, ceftriaxone, vancomycin, acyclovir, 3% NaCl infusion, mannitol, assuming a provisional diagnosis of acute encephalitic syndrome. So there was also neither any previous history of seizure nor similar history in any of the family members. Upon arrival at ICH, a general clinical assessment was done, and airway-wise, breathing-wise, circulation-wise, the vitals were stable, except the child was disoriented, sensorium-wise, and a bit confused. So we came to the provisional diagnosis of acute encephalitic syndrome, looking at the clinical triad of fever, seizures, along with altered sensorium. So after coming to ICH, he had been started with injection acyclovir, vancomycin, doxycycline, and ceftriaxone according to our PICU protocol, and along with that, routine investigations were also sent. So MRI brain was done, which actually didn't reveal any significant abnormality, but a claustrum sign was seen. So the claustrum sign, which we could see here between the putamen medially and laterally between the insular cortex, that raises suspicion for autoimmune encephalitis or fires. So the routine blood investigations sent were absolutely normal and everything was within normal limit. The CSF analysis showed a cellularity of 20 cells, which was 100% mononuclear. But the CSF PCR sent was also negative. So the pivot now changed from infective acute encephalitic syndrome to autoimmune encephalitis. So why this changed? Because there was a deterioration on 48 hours of hospitalization. According to sensorium wise, the child had waxing and waning of sensorium. The child also had profuse oral secretions. There were orofacial dyskinetic movements. Intermittent focal seizures continued. And why AEs became unlikely? Because first of all, the CSF PCR was negative. And even the child remained afebrile after 24 hours of hospitalization. So IVIG was initiated at the rate of 2 gram per kg over 3 days, and autoimmune encephalitis panel was also sent. EEG was also performed, which came out to be normal. So here we could see the orofacial dyskinetic movements of the child, which is quite significant. Now the new diagnostic dilemma arrived when there was the entry of infection-triggered encephalopathy syndrome, that is ITs. Why ITs arrived as a diagnostic dilemma? Because there's a upper respiratory PCR panel was sent, which came out to be positive for adenovirus and influenza A. The blood adenovirus copies were sent, which later came out to be negative. Oseltamivir was started, but why ITS became a strong contender, that is very important. There was a documented antecedent infection of adenovirus and influenza A, and the post-infectious immune response, after which the neurological symptoms followed with the previous onset of fever, to take it more strongly towards ITs. CSF also showed only mild inflammation because there was only 20 mononuclear cells, which was not typical of aggressive direct viral encephalopathy. Blood viral copies also came out too negative, suggesting the active infection had already cleared. So what we saw and why we escalated the AEDs on day 5 of admission, because there was continuous intermittent focal seizures, which was localized onset, not fully controlled, with orofacial dyskinetic movements being continued, and there were breakthrough events despite therapy. So there were 4 AEDs which were escalated to their maximum dose, and along with that, a midazolam infusion was also started due to acute refractory episodes. So why FIRES and NORSE entered the next differential? FIRES, which generally stands for febrile infection-related epilepsy syndrome, is a subcategory of NORSE. So it requires a prior febrile infection with fever onset between 24 hours to 2 weeks of prior to the refractory status epilepticus. So here it was, FIRES came into the differential because there were requirement for multiple AEDs. EEG was normal. This was a paradox because it can occur in early FIRES before the characteristic patterns evolve. Claustrum sign on initial MRI described in FIRES literature. So FIRES fits the most because the post-febrile timing of the disease also says it. So the decision tree, now as the autoimmune antibody panel which was sent also came out to be negative, we also considered now the differential diagnosis to be seronegative autoimmune encephalitis. So if seronegative autoimmune encephalitis was suspected, we would have started on IV pulse methylprednisolone 30 mg per kg for 5 days. If refractory, then we can go for anakinra and tocilizumab. And if we are thinking of ITs again, then also we can start for steroids, or we can go for the wait and watch policy as it's often self-limiting. The diagnostic hunt rationale for choosing steroids is it covered all 3 differentials simultaneously, and after giving the steroids the sensorium improved and the convulsion also ceased, but there was a new evolving bulbar palsy which suggested towards Bickerstaff encephalitis, and an ongoing demyelination process may be prompting the repeat need for MRI. So code test like emoji was sent, IgG preferred method which showed emoji weakly positive, and the MRI also showed features consistent with demyelination. So we started to, there was a plan to start MMF after steroid sparing maintenance protocol to be initiated. So now there was the final diagnosis was autoimmune encephalitis, Mogad overlap syndrome, because MOC came out to be positive and refractory seizures and movement disorder continued along with MRI suggesting features of cortical encephalitis with demyelination. So this is the timeline of diagnostic evolution, like how the diagnostic changes evolved, and finally we came to Mogad as our final diagnosis. Thank you.
Good afternoon, everyone. Today I'll be presenting an interesting case where the clinical journey took us beyond the obvious, named The Decade That Told a Bigger Story. So, 3-year, 4-month-old female child born out of 4th-degree consanguineous marriage, previously able to stand and walk independently, presented to us with complaint of inability to stand and walk for past 10 months prior to admission, suggestive of a regression or loss of previously attained motor milestone. No history of trauma or fever preceding the onset, no family history of similar illness. Birth history was insignificant with no history of NICU admission. This is the video of the child 1 year back when she was able to stand and walk independently on her own, and the right-sided video is after admission when she was not being able to stand properly. Now coming to the anthropometric assessment, child's growth parameters were plotted on WHO growth chart, and both weight for age and height for age was markedly below 3rd centile with a birth weight of 2.8 kg, and weight for height was also low, falls just on 3rd centile, demonstrate the significant growth faltering with both stunting and wasting. So neurological examination, higher functional cranial nerve examinations were normal, bilateral plantar reflex were flexure with reduced muscle bulk and tone in all 4 limbs, no focal neurological deficit and no obvious spinal deformity. Musculoskeletal examination, however, gave us an important lead. There was widened wrist and ankle with preserved active and passive range of movement, and rachitic rosary was present at the costochondral junction.
X-ray of the wrist was done, which confirmed widened, frayed and cupped metaphysis, suggested an ongoing rachitic process, and provided the possible explanation for a difficulty in standing and walking. However, as the predominant history was loss of previously attained motor milestone, so considering the possibility of an underlying neurological cause in addition to ricket, an MRI of brain with screening of whole spine was done, which shows no obvious abnormality, but incidentally multiple rounded hypointense focal lesions were noted in the liver, which was followed by USG of the whole abdomen, which also showed hepatomegaly with multiple hypoechoic space occupying lesions in both lobes of liver. Bilateral kidneys were also enlarged in size with mildly altered corticomedullary differentiation. So now we were no longer dealing with an isolated bone pathology, and we had involvement of bone, liver and kidney. Initial lab investigations were done, and the most striking feature was markedly raised serum alkaline phosphatase. Inflammatory markers were negative with normal creatinine kinase, LFT and RFT was within normal limit with a mildly raised INR. On doing bone profile, we have found out another important thing, that though calcium and magnesium was normal, phosphate was profoundly low with parathyroid and vitamin B3 is normal. So this is not due to nutritional vitamin D deficiency ricket, and the predominant abnormality was hypophosphatemia. Now the question was, why this hypophosphatemia? So for this biochemical evidence of hypophosphatemia along with radiographic feature suggestive of ricket prompted the evaluation of renal tubular function. We have done an arterial blood gas which showed hyperchloremic normal anion gap metabolic acidosis and inappropriately raised phosphate excretion in 24-hour urine sample, which pointed towards proximal renal tubular acidosis. Meanwhile, serum alpha fetoprotein level came, which was also moderately elevated, and urine NGRS was weakly positive and eye checkup was within normal limit. Now at this point, collecting all these points together, that a chronic hepatic involvement with moderately raised alpha fetoprotein and chronic renal tubular pathology and hypophosphatemic ricket, they strongly narrowed our differential to some systemic metabolic or IEM like picture, and all of these features were consistent with tyrosinemia type 1. So whole exome sequencing was sent, the report of which is awaited. So how we come to our provisional diagnosis, that the child had history of failure to thrive that suggested an ongoing chronic pathology, and the child had no history of neonatal jaundice or vomiting in the neonatal age. The child had also widened wrist and rachitic rosary along with metaphyseal fraying on X-ray, which was suggestive of ricket, and the cause of ricket being hypophosphatemia. There was also multiple hypoechoic lesion, liver lesion with moderately raised serum alpha fetoprotein, which pointed towards chronic hepatocellular injury, and the cause of hypophosphatemia being increased excretion of urinary phosphate with normal anion gap metabolic acidosis, which pointed towards proximal tubulopathy, all of which pointed towards chronic or late onset tyrosinemia type 1. Now, this is tyrosine metabolism briefly. Type 1 tyrosinemia is mainly due to fumarate acetoacetate hydroxylase deficiency, in which the toxic metabolites damages the liver and kidney mainly. Type 1 tyrosinemia can further be divided into acute and early onset or chronic or late onset type. In acute onset, usually acute presentation is seen, and in chronic onset, late presentation is seen. And for the follow-up of this patient, phenylalanine and tyrosine restricted diet with the special tyrosine and phenylalanine free amino acid or protein formula, nitisinone, an inhibitor of 4-hydroxyphenyl pyruvate dehydrogenase, phosphate and active vitamin D3 for the ricket part, monitoring of liver and renal function test in regular interval for hepatocellular carcinoma risk, genetic counseling, prenatal diagnosis by chorionic villus sampling or amniocentesis, Sanger sequencing of the parents to determine whether the variants were inherited from carrier parents or are de novo, and multidisciplinary follow-up. Thank you.
Good afternoon to all. Today's topic of presentation is jaundice, anemia and hidden diagnosis. An 11-month-old male child presented with complaints of yellowish discoloration of skin and eyes, which has been noticed since 4 months of age, and intermittent low-grade fever for last 1 month, and abdominal distension for last 1 month. Child was born to a non-consanguineous couple, and birth history was uneventful. There is a history of previous male sibling death at 1 year and 3 months of age. According to the available history, that child had severe jaundice, pallor, and gallstone. On examination, the child was clinically stable. There was icterus, mild pallor, and on abdominal examination, the abdomen was soft, but hepatosplenomegaly was present. On initial workup, hemoglobin was 6.9, total bilirubin was 3.4. It was mainly unconjugated, and LDH was raised, reticulocyte, corrected reticulocyte count 4.2. So there is significant anemia along with unconjugated hyperbilirubinemia. So we are thinking of some kind of hemolysis might be going on. On hemolysis workup, direct cum test was negative. We then performed osmotic fragility test, which came to be normal. Serum haptoglobin is again low. We then evaluated for hemoglobinopathies and red cell angiomyopathies, which shows HPL16 normal, GCSPD activity normal. So summing up to this, it's a feature of suggestive of Coombs negative non-spirocytic hemolytic anemia with unconjugated hyperbilirubinemia and normal red cell enzyme and hemoglobin structure. At this point, the case became more unusual, and we had to broaden our differential beyond the common causes of hemolytic anemia. So we thought of other differential like alpha thalassemia, pyruvate kinase deficiency, storage disorder, and inherited causes of hemolytic anemia. On extensive workup, to exclude the infectious cause contributing to the jaundice, fever, and hepatosplenomegaly, we work up for viral markers and fever profile, which came to be negative. Then we performed serum ceruloplasmin and complement level, which came to be normal. And USG whole abdomen shows again hepatosplenomegaly and gallbladder sludge. Despite this investigation, we still did not have any unifying diagnosis. So we planned for whole exome sequencing, as there is a history of sibling death with more of like similar history. Whole exome sequencing showing cytosterolemia type 1, but it was came to be non-pathogenic or likely pathogenic variant. But there is a genotype-phenotype correlation which is very strong in this child, and the gene variants that was found here was quite significant, and we had consulted with our geneticist. Then we have done serum cholesterol, which was came to be significantly high, and to exclude one of the closest differential, familial hypercholesterolemia, we have done parental cholesterol, which came to be normal. As it is a compound heterozygous, our next line of work which left behind to do parental Sanger sequencing and estimation of beta lipoprotein and plasma phytosterol estimation. Now a few words about cytosterolemia. It is a very rare autosomal recessive disorder characterized by excessive intestinal absorption and reduced biliary excretion of plant sterol. Its incidence is less than 1 in 10 lakh population. Normally, the plant sterols are absorbed from the intestine through the sterol transporter NPC1L1. However, the body has an important protective mechanism involving the ATP binding cascade G5 and G8 transporter. This transporter helps pump excess sterol out of the enterocyte and also facilitate biliary excretion on sterol from the hepatocyte. But what happened in pathogenic variant, this ATP binding cascade G5 and G8 got muted. So there will be no pump back of sterol from the body, and there will be more and more accumulation of this plant sterol in the blood, and which get deposited over the RBC and making the RBC membrane unstable, and thus there is a splenic removal which leads to hemolysis. For management part, there will be most important diet modification, the foods to be avoided like vegetable oils, nuts, seeds, avocado, and chocolate. And for pharmacological treatment, ezetimibe is used, which inhibits NPC1L1 transporter. For take-home message, think beyond common causes in chronic hemolytic anemia, and genetic study plays a pivotal role. And cytosterolemia is an important and potentially underdiagnosed disorder. Genetic findings should be correlated with clinical and biochemical phenotypes, and cytosterolemia can present primarily with hematological manifestation. Thank you.
Very good evening, everyone. I am Dr. Payal Chakraborty presenting to you this case, Beyond the Swollen Limb, a diagnostic challenge in a neonate. This is a term, normal vaginal delivery female neonate on day 8 of life presented to us. Birth weight was 2.94 kg. Immediate cry after birth was there, no antenatal risk factors present. The child presented to us with the swelling of left foot since birth, and there was progressive extension to left leg with overlying skin having this bluish purple discoloration. USG diagnosed in utero swelling of left lower limb of the fetus at 20 weeks of gestational life. There was no fever, no complaints with oral intake, no restriction in movement of the affected limb. In clinical examination, we found that there was this massive diffuse swelling involving the left foot and left lower leg. Overlying skin condition was tense, bluish purple, warm to touch. Edema was there, non-pitting, and no ulceration with no bruit, and no obvious cutaneous hemangioma was found. Peripheral pulses were palpable but very feeble. So, these were the lab reports. Initially, the child was admitted outside, the baby, with thrombocytopenia and FTP greater than 10,000. D-dimer was markedly elevated, and consumptive coagulopathy was suspected. So, at our center, these were the reports. The platelet count was 50,000, and APTT was 30 with INR of 1.3. The two red arrows point at the time of intervention. MRI with MR angiography and MR venography, they show there's diffuse thickening of the subcutaneous tissue. The whitish portions, they show the edema with mild subcutaneous bleeding and hemorrhagic areas. Mild muscle edema was there, no abscess. MR venography and MR angiography were normal, so there was no high flow vascular malformation. Diagnostic journey, what were the differential diagnosis? Neonatal cellulitis, not possible because the CRP was normal, procal was normal. Deep vein thrombosis, not possible, MR angiovenogram normal. Klippel-Trenaunay syndrome, possibly, but not likely here after the MRI because no bony involvement was there and no capillary malformation was present. Most likely a soft tissue tumor. We could not do skin biopsy since the coags were deranged, so risk of having high bleeding. So, this is a histopathological picture of the diagnosis we came onto, that is of Kaposiform hemangioendothelioma with Kasabak-Merritt phenomenon. We could not do the biopsy, so the picture has been put together. Why this diagnosis? Because it was a progressive enlarging vascular lesion, not likely an infantile hemangioma because it's non-progressive mostly, and severe thrombocytopenia was present here, so Kasabak-Merritt had already entered in the picture. Markedly elevated FTP D-dimer was there. Intralesional hemorrhage was found in MRI, no vascular malformation. In management part, most important is steroids and sirolimus. Those two red arrows going back pointed at this point of intervention, that is first one steroids, second one sirolimus. So thereafter we can see the coagulation profile improving and the FDP went down to 3,500. Coagulation monitoring and serial platelet counts are very important for the follow-up plans. This was the outcome in a period of 1 month from leg girth of 18 centimeter to 7 centimeter and foot girth of 24 centimeter to 11 centimeter. Following treatment, there was progressive reduction in limb swelling with improvement in skin discoloration and clinical stabilization. So, what is Kasabak-Merritt phenomenon? It is a rare neonatal emergency with, associated with Kaposiform hemangioendothelioma, also with tufted angiomas at present, not associated with infantile hemangioma. Diagnosis is primarily clinico-radiological, which we did here. Biopsy may be hazardous and early disciplinary care is important. Sirolimus and steroids is important for the management. So, these are the drugs which we use for sirolimus and steroids. Both were started at the given doses, and this is the follow-up plan. First weekly, then once in 2 weeks for the first 3 months, then till sirolimus continues once monthly, and we need to check the trough level of the sirolimus. Most important take-home message is believe and have faith in your clinical diagnosis. Thank you.
Good afternoon, everyone. I'm Dr. Monindranath Burman, MD Pediatric Resident from Institute of Child Health of Kolkata. And today I'm presenting a case entitled When Varicella Unmasked a Rare Syndromic Albinism. A 1 year, 6-month-old female child presented to us with high grade of fever for last 7 days and generalized vesicular pustular rash. The rash started 10 days back on the chin and then progresses to limb, upper and lower limb, and leading to extensive involvement of whole body. And child took oral acyclovir for 10 days outside in view of varicella rashes. The rashes transformed into multiple crusted lesion and also pustular formation was there. The child also had a facial swelling and poor oral intake. The child was sick looking and on blood investigations there were high counts with predominant neutrophilic and high inflammatory markers were there. So IV antibiotic was started. Meanwhile, the blood culture report came which shows Staphylococcus aureus. But the child responded well with IV antibiotics and clinically improved with fever and rashes gradually subsided. As we look at the child seems fair-skinned with hypopigmented hair unlike any of her parents, and light color iridis was there unlike any family member. And on careful examination we can see the horizontal pendular nystagmus on the both eyes. But there was no petechiae purpura or organomegaly. There was no history of bleeding tendency from any side, and there was no history of recurrent infection. The child was born out of 3rd degree consanguinity, and developmental milestone was normal and birth history was unremarkable. From this point we can draw some differentials that are oculocutaneous albinism, tyrosinemia, phenylketonuria and homocystinuria. The oculocutaneous albinism is of two types: isolated oculocutaneous albinism and syndromic oculocutaneous albinism. The important syndromic differentials considered were Shediac-Higashi syndrome, Hermansky-Pudlak syndrome, Giseli syndrome and Vici syndrome. The child has clinically oculocutaneous albinism, but the question is it isolated or syndromic? For this we have done some basic blood investigation along with peripheral blood smear, which shows no giant granulin leukocyte. Giant granulin leukocyte is a characteristic feature of Shediac-Higashi syndrome, which we can see in the right side picture. And also we have done hair microscopy, which shows reduced and unevenly distributed melanin compared to normal hair in the right side, and there was no clumping of pigment in the hair. The clumping of the pigment can be seen in the Giseli syndrome. Since differentials diagnosis included syndromic forms of albinism such as Shediac-Higashi syndrome and Hermansky-Pudlak type 2, which may be associated with immunological abnormality, and child had presented with extensive bacterial infection, so an immunological workup was performed to look for any underlying immune dysfunction. But the immunodeficiency workup came out to be normal. Meanwhile, the eye checkup was also done, which shows iris transillumination defect along with retinal pigment abnormality. And bilateral ocular tomography also suggested to assess foveal hypoplasia and grade of severity. BEPA was done, which was abnormal, suggesting visual pathway defect. To establish the diagnosis of, to establish the definite diagnosis, we have done whole genome sequencing. The genetic analysis identifies a homozygous pathogenic splice site mutation in HPS1 gene, which follows the autosomal recessive pattern and which is consistent with our history of parental consanguinity. Therefore, the final diagnosis came out to be Hermansky-Pudlak type 1. Some discussions about Hermansky-Pudlak. Hermansky-Pudlak syndrome is an ultra-rare autosomal recessive disorder with an worldwide prevalence of 1 to 9 cases per million, and only 770 genetically confirmed cases are reported in medical literature since till 2023. Hermann-Pudlak type 1 was associated with the oculocutaneous albinism and delta granule deficiency causing bleeding, and characteristically associated with progressive pulmonary fibrosis, and granulomatous colitis are also seen. And Hermann-Pudlak type 2 also associated with oculocutaneous albinism and delta granule deficiency, but characteristics here is neutropenia and immunodeficiency and recurrent infection. The treatment protocol and follow-up plan for our child is the child requires multidisciplinary follow-up from ophthalmology perspective, regular refraction assessment and low vision support is required. From hematology perspective, bleeding risk should be assessed particularly before any invasive procedure, and drug such as aspirin and NSAIDs should be avoided because of platelet dysfunction. And pulmonary follow-up is important because almost every child of Hermann-Pudlak type 1 present with pulmonary dysfunction and fibrosis later in the life, and HRCT and pulmonary function test is considered when age is appropriate. And gastroenterological follow-up is also required, important because suggestive of chronic diarrhea and blood in stool given the risk of glomerular chloritis. The key message here is clinical feature on inspection often guide us to diagnosis, and genetic investigation required for final diagnosis, but genotype-phenotype correlation is a must. And early diagnosis enable us to anticipate multidisciplinary care for our patients. Thank you.
সবাই আয় এখানে next year 15th of August we will again meet in this hall, and fortunately that's a Sunday, so every year, and I expect that our students, our ex-students will come to this 15th August program every year, so that it also becomes a old boys meet. Hey Manjuri kothay gelo re? Hey Manjuri, aye. Hey Chuni, aye. Ahona, aye. Chuni aye, Chuni aye. It's an ex-student also. Chuni. এই ছবিটা তোরা কিন্তু বেঙ্গল পেডিয়াট্রিক গ্রুপে পোস্ট করে দিবি।